Poppy. Good girl. Good boy.
Empty this and use it for.
Yeah, by the way, we got empty this.
Simkali vile. Anaitwa nani? Taska. Amekula.
We thank you for the organizers of this event and everyone who is involved in the registration, moderation, as well as presentation, that everything shall be done to the glory of your name. For we have prayed this, trusting and believing in Jesus' name. Amen.
Thank you so much, Professor Mande. So ladies and gentlemen, before we start off, I'll just start with a bit of housekeeping. Again, to remind you, for those who were not in yesterday or missed the announcement, the facilities that you'll need to use are both on your right and left. So you just turn to your right, turn to your left. We have the exits, but kindly as you leave, just try and leave quietly to avoid any interruptions. Please put your phones on silent mode to avoid any interruptions to the speakers and presenters. And for those who are presenting and haven't submitted their presentations to the information desk, with Dr. Momanyi there, please kindly do so before your presentations. In observation of COVID protocols, I'm going to kindly request for all of you to keep your masks on throughout the session, and please use the sanitizers which are on your tables, and please try and social distance, even as you're having tea. Let's just understand that we still have a pandemic with us. We're going to be having a very long session today, and today is actually World Rabies Day. So we're going to kick this off with a session on rabies. And I'm going to invite the session chair. But before I do that, I'm also going to invite my co-host, Dr. Dominic Otrangi.
So we are trending online on hashtag WD 2021, KVA 2021, both on Facebook and Twitter. And we have our social media influencer, Naomi Mutua. Say hi.
I think they're celebrities right now. So.
Yeah. So kindly, if you're on Twitter, you are on Facebook, tweet, so that we trend online. Let everybody ask themselves, what is this that is happening in Malindi? Thank you.
And if you have any requests, if you need anything at the moment, kindly reach out to Dr. Dominic and I, and we are definitely going to assist you. So karibuni sana. So I'm happy and I'm so humbled to have the opportunity to invite Dr. Wakusama to chair our session on rabies. Karibu sana, Daktari.
Good morning once again, and welcome to this session for rabies. We're going to have about 10 presentations, and I'm a stickler of time. So I would request the presenters to really to the time given, although we have started late. So the first presentation is a keynote address from FAO ISAVET program. Its role in building the capacity of frontline animal health workers for rabies control. It's going to be given by Rina Wangila. Welcome, Rina.
Good morning, colleagues. I am Rina Wangila. I work for the FAO That is the Food and Agriculture Organization supporting surveillance activities or epidemiological activities. In FAO, we have the Emergency Center for Transboundary Animal Disease, abbreviated as ECTAD, and our main focus is on priority zoonotic diseases as identified by the government, among them anthrax, rabies, brucellosis, and we also support the control of transboundary animal diseases. I have my colleague here, Dr. Mark Nanyingi, who is our One Health consultant. Mark, yes, so we also, here is also Mark Nanyingi with me. So without wasting any more time, the Secretariat, please load my presentation. So the role of in-service applied veterinary epidemiology training in rabies management. We know that the people who are interacting with the community, the people who are interacting with the animals, and especially dogs, are the frontline animal health workers. And we saw that it is important for us to enhance surveillance of rabies if we are going to work towards its elimination. And so as FAO, we launched the ISAVET program that focuses on the One Health approach. And what is ISAVET? It's a field epidemiology program that focuses on applied veterinary specific competencies and skills. In this country, we have two main specialization colleges for epidemiology. One is really applied, and this was the field epidemiology training program that was hosted at the Ministry of Health. And for FAO, we've also come up with an applied training program for our frontline animal health workers. Why? Because we realized FETP program was mainly focusing on anthrax. So our students will go out there and collect data on rabies. They'll go out there and collect data on anthrax, brucellosis, cholera. But the DVS also has implementation strategies that I need to implement. And they are not only focused on the PZ, we are looking at FMD, mastitis, which is a very important production disease, coccidiosis, and all that. So we saw the need to have this program. So it also has One Health focus. We didn't completely run away from One Health focus. We also saw the need to have the wildlife component coming in strongly to play its critical role for One Health approach. And so we have the wildlife component that is very, very, highly considered for implementation of our program. So currently in Kenya, health, we hope that our trainees will get MSc certificates . Next. So what is the goal? The goal of this program is to create a veterinary workforce that is equipped with essential skills and competencies to enhance surveillance. And this is going to work across all the livestock production systems and along the value chain in an effort to mitigate the impact of diseases on animal health, welfare, farmer livelihoods, food security, safe trade, and public health. We are the main implementers of one of the Sustainable Development Goals, and this is zero hunger. So our main focus is not only on public health, but food security and also safe trade. Safe trade, we know that our livelihoods most of our clients' livelihoods are based on livestock economy. So we do not want to have diseases like RVF, not only impacting on human health, but also impacting on our global trade, both regionally and internationally, and also local. So the objective is to provide essential veterinary services at local, subnational, and national levels, to develop the knowledge and skills in applied epidemiology for ISAVET graduates, incorporating the One Health approach. And we also want to target the zoonotic diseases and priority diseases in partner countries, Kenya included, Uganda, Tanzania, and also the Francophone countries in West Africa. So the main role of this program today is its contribution to the control of rabies, which is a disease that has a huge impact on human health. We've been told that 59,000 lives are lost annually, globally, and that is mainly in the poor households of Africa and Asia. But we are also told that the cost of treating the disease, not controlling, treating after it has crossed from the animal interface to the human interface, it's about 8.6 billion. Dr. Karani has just made an article that has appeared today. And yes, so those are the figures we're looking at, and we want to play our role as a veterinary workforce towards the contribution of elimination of rabies. So we also want to strengthen the animal health surveillance system. A strengthened health surveillance system will assist in timely detection, timely response, and timely control of not only rabies, but also RVF and other transboundary animal diseases. So we also need to, the goal is also to strengthen emergency response to natural and man-made disasters, including emerging disease outbreak investigations and management. In the region, some of our ISAVET trainees have played a very critical role in responding to COVID-19 pandemic. Case in point is the animal laboratory in Ethiopia that is conducting laboratory diagnosis of COVID-19 samples. Even the case follow-ups, case follow-ups are being conducted by ISAVET trainees and graduates in other countries. So we hope that we are also going to play this important role here in Kenya as we proceed building our capacity. And so far, we also have trained a few mentors and trainers. I think we now have 15 mentors and 15 trainers, and we hope to train more. So why are we focusing on the frontline animal health workers? It's because they are at the community level where the disease events occur. Diseases, yeah, they occur in Nairobi, but we also have diseases occurring in Elwak. We have diseases occurring in Maikona, in Marsabit, in Busia, ASF, sometimes crossing over from Uganda to Kenya. So those are the people we want to target, and they're the leading edge on animal disease outbreaks. As an epidemiologist, you live in Nairobi, but you need to work with the local staff to tell you where was the first index case reported. And that's where you want to follow up on the case. They also have the best access to field data. And so we just want to train them to package this field data well. And they have the high quality data, and they are the primary source of epidemiological information for decision-making and action. One of the things that have been ailing us for long in the industry, especially in terms of resource mobilization, is that we do not package our information well for the policymakers to see the need to increase resource allocation to the animal industry. So with this data collection, we hope that we'll have the decision-making and action and advocacy tools for increased resources to the animal health industry. Next. So how many components do we have for the ISAVET? We have the three main components. The first one is a 3-month-long training, which is currently ongoing. The first trainees were selected, 25 of them selected from 25 counties, both the border counties of Marsabit, Bungoma, Turkana, West Pokot. We also have trainees who are selected from both the paraves and the veterinary professionals. And these underwent they are currently undergoing a 3-month training. The first 1 month was in class, and we call it the didactic training, whereby you have trainers who are trained coming in to train our trainees on the various competencies that I will deliberate further on. And after the 1 month training, we now released our trainees to the field to go and practically practice, to go and put in practice what they have been taught in class. If you're talking about One Health approach and you have a case of rabies, are you going to go out in the field alone, or are you going to constitute a team that is multi-sectoral so that you have that collaboration? We know that as vets, we might be very strong in the animal health component of rabies, but is that when I'm bitten by a dog, will I go and will the diagnosis in the hospital be recorded as rabies? Rarely that is not the case. The medics will pick that as an animal bite case. So it is our trainee to know that when they go for that investigation, they have to relate the reported animal case bite, or rather the rabies case that has been reported in an homestead, to see whether there are several cases of animal bites at the health facility around there, so that they correlate that and see how best to manage. The second component is training of trainers, and it's a one-week training workshop. We've held 2 so far. The first one was a regional one with our colleagues from Ethiopia, Kenya, Tanzania. And we also had another one in country that we conducted early this year, just after COVID. Okay, not after COVID, but after the first phase of COVID. And then we have the component that is the third one, which is training of mentors who are very critical. The longest time spent by our trainees is with the mentors. They will take them through the required audits that we expect the trainees to have before the graduation, and I will go through that next. So what is the structure of Frontline ISAVET? I mentioned that there are skills that we're interested in. There are 47, and these 47 skills fall under 14 competencies. And the first, the first domain that we want to have competencies and skills building is epidemiological surveillance. The second one, which we do during the second week of the didactic phase, is on field investigation and response. We also look at the preparedness, disease prevention, response, communication, ethics, and professionalism. I cannot emphasize on this, but this was mentioned by several of our speakers that we want our professionals, when they go out there, they conduct themselves with ethics and professionalism. And this is why we work very closely with KVB. They are part of our training. They are part of our National ISAVET Program Steering Committee. Because we believe that if you do it right, then you can have the right reports, and you can also have the platform to stand on when you are saying that you want more resources. Why? Because of this and that, so that we just don't advocate without the tools that are required. And the fourth one is a hands-on exercise on field visits in the nearby districts. And how this is done is that for the Frontline ISAVET training, for the first month, we go to a county. And this last one, we had it in Nakuru. So we had a scoping mission to identify the livestock challenges in that county. And during the 4th week, during the hands-on experience for our trainees, exposure of our trainees, we want to try and provide more information on the livestock challenges in that district, so that at the end of the training, the county is also able to have some reports out of our being there for the 4 weeks to also use it for planning and management of livestock diseases, livestock mitigation strategies. Then I've mentioned about the home-based field project. Our trainees are in the last month. Actually, they have just completed this phase of the training, and we were taking them through implementing a field case study that they had come up with. Before we admit you to the ISAVET program, we expect that you look within your county. If the problem is FMD, do a case study on FMD, so that you will provide solutions, or rather recommend solutions to your county on how to better control FMD. If the problem is mastitis, please look at it, because it's a very important production disease. Most people are losing their income at household level because of persistent cases or chronic cases of mastitis and all that. And so the first month was to organize and initiate the field project. Then the second month, we hope that they were able to collect their data and analyze it. In October, in September, they have been preparing their report of the field project. And we hope that in November, we'll call them again to give us a report of what they have done. And they won't give us full thesis, because in the training, we also taught them on presentation skills, on how to come up with the PowerPoint and communicate to the people, especially in a very good, concise report, because most of these policymakers don't have time to go through the 78-page thesis or 28-page. We want them to come up with a 10-page concise report and a PowerPoint, maximum of 10 slides. What do you want done? How do you recommend we address this problem? Next. So the structure, or rather the management structure of ISAVET in Kenya, I've mentioned the National ISAVET Program Steering Committee with membership from the Ministry of Agriculture, Livestock and Fisheries. We also have the Council of Governors, represented through the caucus of County Director of Veterinary Services. We have academia. The University of Nairobi is a very key advisor on how this program is going to be implemented moving forward. And also the improvement of the curriculum. We also have development partners, FAO and Co-Group, which is also an organization that is funded through USAID. And professional bodies. I've been told that time is up. So the composition of the ISAVET Technical Working Group, you can see where it is. We have various partners also and stakeholders. Next. So this is just showing the various activities that we've implemented. I've mentioned this before. We have the TOTs trainings that we've had. We're now currently training 25 ISAVETs. Next. So anti-rabies, now we have been told that we are in stage 3, 2017 to 2027, full-scale implementation of the rabies control strategy. So what is our role? Having the required workforce to undertake this full-scale implementation. Next. So we have the 4 pillars of rabies control. We have the mass dog vaccination, the prompt provision of PEP, public health education and awareness, enhanced surveillance, and advocacy communication of the same. Next. So what I'm presenting here is just the various skills that have been impacted by ISAVET program under the 4 main pillars towards elimination or critical for elimination of human rabies. So under epidemiological surveillance, we hope that the competency to communicate the purpose and characteristic of the animal health and public health surveillance system. How do we report diseases? Is our surveillance system, does our surveillance system have the key attributes of a sensitivity, usability? Is it stable and all that? So we need to have a very robust surveillance system to be able to undertake rabies surveillance. We also hope that our trainees are able to summarize, analyze, interpret surveillance data and notify the stakeholders immediately. If you have a case of rabies, do you wait for 2 days before you report to the DVS, or do you know that it's a requirement and it's emergency to report it immediately? Next. So the other key pillar for the rabies elimination is enhanced surveillance for rabies in humans and animals. And we have equipped our trainees with the field investigation and response skills, mainly through the main steps of an outbreak investigation. And we hope that they'll be able to contribute to early detection and diagnosis of rabies cases in the country. Next. So that is just pictorial presentation of what our trainees went through. This was in Nakuru, I think Bahati sub-county. We also emphasize on biosafety, biosecurity, especially for cases like RVF. You do not want your workforce to be exposed and also to transmit the virus further than where it is. They are supposed to contain it. Next. So under mass dog vaccination and prompt provision of PEP, we have been doing mass dog vaccination. So what is it that we trained our trainees on for them to be able to do that? Ethics and professionalism, act in accordance with accepted standards. You're told, do not put a vaccine next to a cold pack. Why? Because you're going to make it not effective. You're going to inactivate it. So please follow those instructions. It might be difficult to do that. Have your collect data. Have you vaccinated? Please give those figures, the right figures to the authorities for them to know how far they are with the mass vaccination and all that. So, and one main one, I know I'm out of time, is the One Health approach. And this is cross-cutting. One Health, I'm sure it's been a gospel that has been preached for long now, and we know what it entails. But one thing I've mentioned is that the environmental sector, the environment sector in this country is not so strong in One Health, and we want to improve that. Next. So that was the One Health panel that we brought in for ISAVETs to know the need to have an One Health approach. One Health approach is just not in Nairobi, it's not at ZDU. It should be at that county, at the sub-county. And One Health approach is not supposed to be a physical office. It's a concept. You do not have to have a physical office with a laptop, a computer, a secretary, no. You have it in a meeting so that it's ad hoc. Next. Advocacy, communication, and social mobilization. We taught them on communication, on how to communicate effectively with technical and non-technical audiences. When you're going to raise awareness on rabies, so you're going to call mass call for mass vaccination. How do you communicate to the community? Are they responsive? Can we say that we were successful in our call for mass vaccination? Anyone? Yeah, so think about it. Next. So public health, education, and preparedness, we taught them on how to interact with each other, when to report if it's rabies. You don't just report a case of rabies in your office, please also involve and inform other stakeholders that are key in that. Next. So we have a few trainees who are currently working on rabies, and one is a trainee from Kericho, that's a paravet, and he's looking at the assessment of rabies cases in domestic animals as presented in Kericho RVIL from the period of 2016 to 2021. Those are the research objectives. In Kilifi, where we are, here there's a trainee who is also a paravet, who is looking at he's looking to assess the magnitude of dog bite cases and the subsequent uptake of rabies post-exposure prophylaxis in the Kilifi County. Thank you, Dr. Wagusama. That's the end of my presentation.
Thank you, Rina. That was quite exciting. Our next presenter is going to be Professor Dumbi from United. He's going to present on United Against Rabies, effective use of vaccines, medicine, tools, and technologies. Professor Dumbi, welcome.
Many thanks, Dr. Kusama. It's working. Waiting for the presentation. Good morning. So today marks 136 years since that experimental protocol that Louis Pasteur, the French chemist and microbiologist, tried on a young boy who had been mauled by a rabid dog. And 28th September, which is a World Rabies Day, is a day we celebrate, you know, that thing that Louis Pasteur did, and also marks when Louis Pasteur died about 126 years ago. Next. So over those 100 years, we have learned so much about rabies that somewhere around 7-8 years ago, countries in the world decided that it's possible to end any death from dog-mediated rabies by 2030. In fact, for Kenya, we made that strategy in 2014 and it was adopted by us as stakeholders together with government. A year later, the World Health Organization, the OIE and FAO came up with this global strategy for elimination of rabies by 2030. To make this effective, there has been a forum that has been formed by the three world bodies, the World Organization for Animal Health, the World Health Organization, and the Food and Agriculture Organization of the United Nations. And that United Against Rabies Forum was launched last year during a day like this, the World Rabies Day. And we have a website that you sort of can see what the URL is about, but also listen to the speeches by director generals of these three organizations. Next. So what is the idea? The idea is to have a phased approach to achieving rabies elimination by 2030. You have a phase 1, phase 2, and phase 3. And phase 1 is where we are at, which is the startup, where we hope 29 countries can start implementing the rabies elimination activities. Move to the next. So the URL has identified 3 key objectives. The first objective is to effectively use vaccines, medicines, tools, and technologies, which, as I mentioned at the start of this talk, have been available for more than 100 years. We have a good, efficacious vaccine that is now even quite safe in animals and in humans. We have a lot of tools that have come up, mobile phones. We are able to map where we are vaccinating. We are able to tell where cases are happening. And all these are really nice vaccines, medicines, and tools that can be used to reach the goal of a rabies-free world by 2030. The second objective is we are learning so much as countries. Kenya is at the forefront, informing what's happening within the sub-Saharan Africa. And the experiences of Kenya need to be shared with Tanzania, shared with Rwanda, shared with Uganda and other countries. So the second main objective is to generate, innovate, and measure impact of these elimination activities happening at different parts of the world. We know that where we have had success in elimination of diseases or eradication like smallpox, rinderpests, resources played a big role. And in fact, as you can see, we are almost there with polio, and it has been as a result of great investments by many organizations, inclusive of like the Gates Foundation, that has poured money into polio eradication. So that objective for URL is to find a way to sustain commitment of resources at the international level, but also at the national level. So the way this works is an international committee has been formed, referred to as a working group. So we have 3 working groups that have been identified. The first working group is how to effectively use vaccines, medicines, and tools. And that's the working group that I chair together with a colleague of mine from the CDC in Atlanta, Dr. Ryan Wallis. And I would like to just give you a brief about some of the things that we are focusing on, and then invite you for a webinar that will be a bit more elaborate in the coming week. So we are interested in 5 main things at the moment as a start. The idea is to catalyze activities for countries that are rabies endemic. And the 5 things that we are working on at the moment is a minimum essential surveillance data elements. So as what Rina has presented not too long ago, people on the ground or the field workers do not collect excessive unnecessary data or collect too little data that can inform elimination activities. So we are aiming to identify what are those minimum essential data elements that we can have in the world for rabies elimination. Second one is that, as you know, there are numerous tools now that are available for support of rabies elimination activities. We have, different organizations that have come up with mobile phones, at different times and with different abilities and characteristics. And it becomes a little bit difficult if, say, you're coming from Nandi County to decide on which of these tools should I use. So one of the roles of the working group is to identify what tools are available and have a way of characterizing them so as you can have it easy as you make a decision on what tool you should use. The third one is mapping of global activities for rabies elimination. I mean, if you listen to the talks this morning, there's going to be lots of work happening in different places. And in a way, if these things are not mapped and you know who is working on what, it becomes difficult to collaborate and you might actually be doing repetitive jobs. So the idea is that at a global level, you're also able to map all the work that's happening on rabies, and that is used to make people collaborate towards this common goal of 2030. And then you've just started 2 work streams, one on improving human-animal bond, and one on identifying the rapid diagnostic kits that can be used in the field and that can be adopted through the OIE system, so as we're not just dependent on the much more expensive microscopy that has to happen at the DVS. Next. So today I'd like to just focus on 2 of those. And the first one is on the minimum essential surveillance data elements. And we have identified 4 key important areas for which we should address this issue. One is on animal surveillance, animal vaccination, human surveillance, and human vaccination. The problem is what you collect at the field and what goes to the national level are really different. And so if there's a request from WHO, from OIE to make a certain report, you'll end up having more data than you need to report. And one of the ideas is to make sure that you can harmonize that what's collected is useful across all sets. So on the animal surveillance, there are 5 core data elements that we propose anyone working on rabies elimination should focus on. So should report on the number of animals investigated by suspicion of rabies, and what kind of surveillance you have. Is it passive? Is it contact tracing? Is it active surveillance? And what are the species that you're identifying? The second one is a case classification. Is it a confirmed case? Is it a suspect case? Has it tested negative? Has it tested positive? Or is it just a non-case? And also including that, the geographical location. So as you're able to identify where it is that you're making progress and where cases are flaring up. Then there's diagnostic tests performed. What are we doing? Is it just based on clinical diagnosis, or have you used the rapid diagnostic kits that are now becoming much more available? And where you can, have you gone ahead and sequenced to know what variant it is? And I think that's an important parameter, because in the future, when Kenya is near elimination, you want to know when you have a new outbreak, what is the variant that is driving that? And then also a simple recording of the number of laboratories that can confirm rabies within a country. And that will help, obviously, at the global level to know how a country is performing. Next. On the dog vaccination, we are proposing 4 core data elements. The first is the estimated dog population, some which you can achieve like through census, like what Makueni did, or you can have some quick cross-sectional studies at a local level to identify what number of dogs you have got. And often you use a human-dog ratio for that. The second core data element is the number of dogs vaccinated, and you're basing it, just report the annual. And then the vaccination coverage and how you achieved or how you determine the vaccination coverage. And because it's an important thing also, what number of dogs are impacted by your dog population management. Next. On the human rabies surveillance component, there are many more data elements required here. And I'll not go through all of them. I'll just go through the main idea is to be able to report the number of human rabies exposures that have been investigated, dependent on the case classification of the offending animal, but also on the WHO categorization of bites, which goes to category 1, category 2, category 3, with category 3 being the most severe and likely to end up being a rabies case. The second one is number of human rabies investigated by those characteristics. And the third one is number of laboratories that are able to confirm human rabies. When we started, I think, the work on rabies, the diagnosis for human cases was all done in Kabete. I think Kabete no longer takes samples from humans, but luckily the National Public Health Labs now have got capacity to do that. And I think that's good progress, that you're able to make a diagnosis for rabies as well on the human side. Then the other really critical part is on the core data elements for PEP, post-exposure prophylaxis. What are the schedules that you're using? Number of vaccination centers that you have got, and my colleague Mumba Mutunga will be talking about that. Number of people initiating vaccination by animal case classification, number of people receiving, immunoglobulins, and whether they have completed their vaccine doses. Next. So that's one work stream. The second work stream I talked about is that we have numerous tools that are needed for supporting rabies. And if you think about the elimination activities, there are many components of it. There's a human component, there's an animal component, there's a local component, there is a sub-county component, national component. And this graphic developed by Ryan Wallis is a good demonstration. It appears busy, but that's how much rabies activities are connected to one another. So you could have different tools that address different components of this complex rabies landscape. Next. So the idea is to come up with a set of criteria that can use to evaluate these different tools that are available. And we have selected 7 of them. Accessibility, data collection needs, data storage, how flexible is the tool, the ease of using it, and the training needs, and also sustainability. We go to the next one. What we hope to develop is a site where you have your different tools and they are taken through those different characteristics, and there is a peer review that happens to allocate some scoring system to each of those tools. And the idea is not to make tools compete. The idea is for you, who is a practitioner helping with rabies elimination activities, have a way of starting some evaluation to make a decision as to where should I start, which tool should I use. And here's a good example comparing two tools here. A tool one would be accessible, easy to use, and limited functionality. If you look at that graph, so the closer it is to the writing, the better. The farther away it is, it doesn't do well. So like for tool one, you can see functionality is a bit limited. For tool two, you have more of, it's comprehensive, it's difficult to use, and barriers to access, and you can make that kind of comparison. So the United Against Rabies will provide a site, and the OIE is helping with that, where all those tools will be, and you can make a decision based on that. And that we hope can catalyze the speed at which we adopt these things. Next. So yesterday, there was a webinar from 3 that was talking about COVID-19 and rabies and how COVID-19 has affected rabies elimination activities. In the next 2 Mondays, so next Monday, we'll have about an hour and a half to tell the world what working group 1 has been doing regarding the effective use of medicines, tools, and technologies. And the Monday after that, we'll have working group 2 talking about the strategic and operational support tools that you have got towards meeting zero by 2030. So I'd like to end by inviting you, next slide, to attend the webinar that will be coming Monday. And I hope that we are able to discuss a bit more, and we can provide you a bit more information about the mapping activities. And those are the 2 work streams on rapid diagnostic kits for rabies that would like to discuss with you. So it's a pleasure, and many thanks for listening.
Thank you. I can confirm I was in that webinar yesterday. It was very exciting, and I encourage you to follow the other 2 that are remaining. You'll learn a lot about rabies. So our third presenter is from Dr. Joseph Kitur. He's going to talk to us the impact of dog vaccination coverage on rabies outbreak probability and cost. Welcome.
Good morning, colleagues. My name is Joseph Kitur. I work for Boehringer Ingelheim. I don't know if it's visible on the right side of the screen. That's the name of the company. It's not a very easy name to pronounce because it's a German name. Even me, I struggle a little bit to pronounce. I'm here today with 2 of my colleagues who are also veterinarians. Boehringer Ingelheim is a company run by veterinarians. We were in discussion with Dr. Mande when we were having lunch whether vets have managerial skills or not. And our company president has been a vet in the past, and the business volumes were doubling. Again, my 2 colleagues are vets, but I'm not very sure if even me, I went to business school after vet school because of those doubts. So I don't know if it's just people branding us out there that we don't have managerial skills, so it's true. Maybe, but Dr. Mande said he'll see what to do about it so that the companies that are in animal health industry can be managed by ourselves, and we can be in full control. That's just on the sideline. So, Professor Mande, I'm very sorry. I think I'm very sorry. So, Professor, I think we had a long discussion about that with so many of our colleagues during lunch hour. So in my presentation, I don't want to go back to anything that has been mentioned. So I'll try to really skip anything that has been mentioned. So Boehringer Ingelheim is a company in one of the largest companies globally. We're actually among the top 3. This is in global business position. Not locally only, but we are talking about global business. So our areas of leadership are in parasitology, pet parasiticides. We are a world leader. If you remember, several products were done by us. Likewise in equine, likewise in swine. This is where we are #1 in the world. And to maintain these positions is not very easy. And then what I'm calling there, we're also number one in VPH. What I'm calling VPH there is veterinary public health. For us means FMD vaccines. So in globally, 70% of the FMD vaccines used globally are supplied by Boehringer Ingelheim. So in that area, we have been a world leader. We even developed the first FMD vaccines that came into the world. Next. So I just want to mention, before I go into my topic is about rabies, but I just want to mention a few things where the company is involved in. One of the areas, as I said, is in pet parasite control. And this is an area I said we are world leaders. So you'll remember Frontline was the fipronil, the product that was used for many years. It's still being used now, and is one of the best products for control of fleas and ticks in dogs and cats. Now we have a new molecule, and whenever we have new molecules, we try to educate everybody so that they can be used well, so that we don't end up with problems, because these are the tools that we need. Someone had talked there about the tools like rabies vaccines. These are part of the tools that we need to really be successful. So NextGuard is a chewable tablet. You just give to your dog. The dog swallows. It clears fleas and ticks for a full 1 month. Then you repeat again. So this one is already in the market in Kenya. I know most of you are very familiar with it, but these are new molecules which have no resistance because they're new in the market. We choose to go with the 1 month reapplication because this new class of molecules is called the isox. And the specific molecule, for example, for NextGuard is afoxolana. They have, at a high concentration, you may have problems with the CNS signs in dogs. So we don't want to give a very high concentration because there's still discussions around there. So we keep to this monthly dose for safety also. And you get very good efficacy when you repeat. And again, if you go for a long time in one application, by many days later, if you're targeting 90 days, maybe by day 60, certain tick species will start to come back, which maybe after the concentration has gone down. So the best approach is to give a monthly reapplication. Next. This is part of the tools that we talked about. Again, in rabies, these are the tools that we need. Our role as Boehringer Ingelheim is to provide the tools, what the main tool being the vaccine. So you all know that in terms of going out there to control rabies, the major cost is in terms of logistics. It's not even the vaccine. When you take the vaccine and the collar, if you're putting a collar and the syringe and needle, you are looking at less than 10% of the cost, or maximum 30% if you really, if it's really expensive. So the 70% of the cost is still around logistics. It's about yourself going with your car up to the village and then getting the dogs and all those costs of communication. So you don't want to go all that way. And then you choose a vaccine whose seroconversion is 50% or even much less. Because it will mean, if you take a cheap, low quality vaccine, let's say 50% seroconversion, it means for every 100 dogs that you're catching, only 50% will actually end up being protected. And it becomes a loss to you. Even if you take a vaccine that is 70% seroconversion, and you are targeting to achieve 70% protection in that population, you will still not make it. It means for you to get 70% and you're using 70% protection, a vaccine that's giving you 70% protection, it means you have to catch every dog in the village, 100% vaccination, so that you get 70%, which is not possible. So for example, Rabicin is 97%. Every 100 dogs, we have a lot of studies on this. Every 100 dogs you use with this product, you end up with 97 of them protected. So if you are targeting to protect 70% of the population, you will say 70% of 97%. So you'll need to vaccinate almost a good percentage still. But at least these are good efficacy products. These are WHO reference products in terms of rabies control. So that's Rabicin. We have this product in Kenya for many years, and most of you have experience using it. But I just want to emphasize on the need to use quality products so that you don't waste your fuel, you don't waste your time in the village, and then you end up not getting protection. Let's really remember that the key thing when you are going out to vaccinate is to get protection. It's not just about the injection and the vaccine, it's to make sure that the dogs are protected at the end of the day. Another key area where we are involved is in control of foot and mouth disease. This is what I was calling VPH. We will also have a seminar on this, a webinar. I want to invite all of you to this webinar. The passcode and the webinar ID is up there, but I guess the slides will be shared so you can also find it. But it's still a major area in our country. I just want to comment on our own FMD situation. I saw Dr. Abraham Sangula. Dr. Sangula is somewhere. We have been in so many discussions about FMD. This is an area of our interest. And I said we are global players supplying 70% of the vaccines in FMD. So the key thing in FMD also, I just want to mention in passing before I go into my topic, is again, just like rabies, to have the right tools to vaccinate. But as a country, if we do vaccination successful for like 2-3 years, and then we run out of vaccine, and then the virus will roll back all the gains that we had made. So it's like if Professor Mande takes you up to 5th year, and then something again brings you to the 1st year, it will be a disaster. So as a country, really, what we would, as a major player in FMD, there are two approaches. Either if you decide to rely on your own lab. I've been in pharma managing all these things, production, etc. Sometimes when you lack the bottle caps, just the caps alone. Sometimes you go to the manufacturer of bottles. One time I was relying on Diageo when I was doing some other business of amateurs. You go to the bottle manufacturer, he tells you, my brother, you are a small player. You just want 3 million bottles, Coca-Cola here. I have problems with the materials, raw materials. So for the next 8 months, I'll not be able to help you. So let's not be surprised if any manufacturer runs out of any product. It's really not news in the industry because it happens every day. One day it's about the cartons, the next day is about the safety tests, the next day is about bottles, etc. So if at the end of the day we cannot allow other players in the market, the other option then would be vaccine banking, where if you are relying on one player, then you tell another player that please keep some stock for us for emergency as a bank, so that in case my player here is out of stock, you bring your emergency bank and cover us to avoid the virus rolling us back several years from the gains. Otherwise, it becomes a back and forth. You go forward and then you come backwards. So we'll have all those discussions. Next slide, please, in this webinar. One of the other products that the company has brought into the market is a pour-on dewormer. This Eprinex is a epinomectin. You just pour along the back line of your cow, and it penetrates the skin and clears all the internal parasites. So it's a dewormer, but it's pour-on. Somebody was asking me yesterday, why would we make a pour-on dewormer? We do this because in other countries, this dewormer is also an insecticide. It's also indicated for control of external parasites. But in our country, it's registered for internal parasite control because already you have a lot of products that are used in control of external parasites like ticks, etc. So this one is available also from our distributors, and it's called Eprinex. This is a 0 withdrawal period dewormer in milk. So this is the only one of this type that you use on your dairy farm and you still continue consuming the milk the same day. So it's 0 withdrawal period in milk, and for meat, it's 15 days. So I don't want to dwell so much on Eprinex. It's not my topic of today. So let me go into my, my topic of today. And we are looking at the next slide, please. I don't want to mention anything that has been mentioned. Please move up to where there is next. Yes. So I just want to share with you this study. So my topic is about the probability of rabies outbreak versus the cost of the vaccination. So first of all, I want to start with this study. This study was done in Peru. In the capital city of Peru is Lima. So this was in 1988. In Lima at this time, there was no seriousness in rabies control. And you can see from that study that there are so many rabies cases in different species. In cats, in humans, in dogs, this was the situation. And that was in 1984. So they started first by making studies about the prevalence of the disease. And then in 1985, they started vaccination. And they actually were achieving 78% vaccination cover. And this is just in Lima. Lima is a city of 5 million people. At that time, I think now it's more than 10 million. because all of us are going forward in population. So this is what they did. They started the vaccination campaigns. And as you can see from the graph, the following year, in 1986, with 78% vaccination cover in dogs. You can see there were no cases in the other species. There were no cases in dogs. There were no cases there were no human cases. Everything else disappeared. So this just goes a long way to say, if you do more than 70% of cover of the dog population, it will really go a long way in controlling this disease. So if we are doing 10% or 20% or 30%, you will still have cases up and down. But the moment that you are able to give a significant cover, and then this is the point that you will start to control. So there are so many factors around there. You are also looking at, first of all, for this particular study, thereafter the government really took it up seriously, and they were vaccinating 7 to 18 million dogs per year. Next slide, please. So those are the human cases in that particular, in one small area of Lima. You can see in this small area, there were 60 human cases per year, human rabies cases. But after the vaccination, everything came down to 0. And then these are the vaccinations in the red column that I was talking about, that they were doing 7.1 million cases. These are the national figures now, up to 18 million cases by year. It's starting from that time up for quite a number of years. So this really goes a long way to show that when we do this proper vaccination, then we end up with a very good cover. Next slide, please. Next. Next. Again, next. Next. I don't want to go into a lot of details. I just want to show, please, let's go to the next slide, please. Yes, I just want to share on this slide about the cost implication when you are out there vaccinating dogs. And I just want to give an example with regards to what needs to be considered. One of the key considerations in the dog population is the young puppies that are coming into the population. So if you are looking to cover 80% of 70% of our population, you need to consider that there'll be new young puppies coming into the population within the same year. And this need also to be considered in the number of dogs. So the dog population is renewing at, let's say, a rate of 20%. And on top of that, the lifespan of a dog would be maybe 3 years or something like this. So these are things that need to be considered. Please, next slide. Next. Next again. Yes. So this is the main area that I was looking at. And I'm surprised the slide is not fully visible. But just to explain the red line and the blue line. So here now we are looking at the probability of outbreak versus the vaccination cost. So the blue line is the probability of outbreak. You can see when you're at a very low vaccination cover, let's say at 0%, the blue line is very high, the probability of outbreak is very high. But when you drive forward the vaccination cover towards 80%, you can see the blue line really comes down, the probability of outbreak really goes down, but you'll never really come to, you cannot bring the blue line to 0 because it's impossible. Just shows that in the village, okay, I'm finishing up. So the blue line just shows that in a village, it's not possible to vaccinate all the dogs. Some will get lost, some will not be reachable to you. And then the red line is about the cost. These are the logistic costs, the vaccine costs, CTC. You can see when, of course, when you're not doing any vaccination with the red line, still you're incurring costs on treatment of cases and human rabies, CTC. But when you drive vaccination forward towards 70%, that's the ideal now. The costs are quite low and the probability of outbreak are very low. So the ideal really is to do it at 70%, because if you come towards 20%, you may think as a country you are not doing vaccination. But really at 20%, you still spend money. It will still cost a lot of money to treat cases and have all this confusion in the village that the dogs are causing problems. While at 70%, everything is lower, the probability of outbreak is low, and actually the cost of rabies control is low at this 70%. Next slide, please. Next. So the other factors is about communication and who to target. This has been mentioned a lot. I don't want to go into that, but this is really important. Next slide. So this is the vaccine efficacy that I had explained. Dr. Osama will be done in a minute. Yeah. So this is the vaccine efficacy that I had explained earlier, that you need to use efficacious vaccines so that you have a good cover, so that your effort in the village is not really wasted. So we need to be very careful with the kind of vaccines that we are using. Next slide, please. And this slide I had explained earlier, that quality products will give you quality protection, and your effort in an area will really be rewarded. You will see the number of rabies cases going down. Thank you so much for listening to me.
Thank you very much. And thank you for understanding me. I'm not harassing anybody. I just want us to keep time and enjoy it. Thank you. The next speaker is Harriet Oboge. She's going to tell us about rabies elimination in rural Kenya, vaccine challenges, shortages in health facilities, low awareness and knowledge on rabies, and its management among health care workers. Welcome.
Sorry for that. And it's knowledge among healthcare workers. So as you all know, we've heard a lot about rabies, that it's a fatal viral disease causing approximately death of 59,000 human deaths globally, and mostly common in the rural Africa and Asia, affecting children around 15 to below the age, from below the age of 15 to below the age of 15, because they're the ones who commonly interact with dogs in the rural setups and just in our homes. So as you all know that domestic dogs are the source of infection in humans. And in Kenya, it's endemic, as we've all heard much about rabies. And currently, as we've heard, that there are implementation strategies currently going on with the stepwise progressive reduction of rabies in the country. And we have pilot counties that have undertaken the rabies implementation. Next. So next, please. So the objective of the study, as you can see, is assessing the knowledge, and awareness of rabies and its management among the healthcare workers. Particularly, this study was done in Makueni County, getting to know how knowledgeable they are about rabies and the management of rabies. Next, please. So yeah, the study was conducted in Makueni County and in health facilities where healthcare workers were interviewed. And in this study, the study was conducted in level 2, level 3 hospitals, and level 2 and level 3. So in the county and sub-county, Makueni County Hospital and the sub-county hospitals, 2 sub-county hospitals and 1 county hospital and 39 other healthcare units. And the study participants who are recruited in this study were medical officers, the nurses, pharmacists, laboratory technologists, and public health officers. So in this study, data that was collected to assess the knowledge of rabies management and availability of PEP in these health facilities, where we did a bit of demographics, rabies awareness, rabies management, as far as knowledge is concerned, knowledge on bite categories for rabies. As we've had before, there are different categories of bite, and this informs how you're going to manage the wound bite and assess whether you're supposed to give PEP or not. And also the available PEP regimens and the sites and routes of rabies administration and management of human cases, the different diagnostic methods, the DDXs, the differential diagnosis for rabies, how samples for rabies diagnosis is conducted, sample collection, and how these samples are transported to the laboratories. And also in the health facilities that were interviewed, data was also collected on availability of PEP and rabies immunoglobulin for a period between 2018 to 2019. So from the results of this data that was collected on the knowledge of rabies and management of rabies among these healthcare workers, about 73 healthcare workers were interviewed. These healthcare workers were from 43 health facilities in Makueni counties, in which the females there were more females, around 69 of them, age range between 22 to 60 years, and more than 50% of them had 5 years work experience in these facilities. So for the healthcare workers who are there, 56% of them reported that they'd encountered dog bites in their period of practice, and in which 64 out of the 73 had knowledge of how to manage rabies. And in terms of the different bite categories that are involved, 23 were aware of the bite categories that have been indicated by WHO. And in this knowledge of the bite categories, this was not associated in any way according to the work experience of the healthcare workers or their age. And in terms of how to manage the wounds, 12% of them were not aware of how to manage the bite wounds. Next, please. So from this study, in terms of treatment response, considering the different bite categories that are presented, just to get you, there are 3 categories bite wound in terms of the category 1, which is basically an animal that is rabid if it licks, there's no broken skin and all that, so there's no requirement for PEP. And also there's category 2 where there is uncovered skin, nibbling, and that one requires PEP. And then there's category 3 where there is, in case of multiple bites or in the upper trunk or when somebody is bitten. So on this knowledge of getting to know treatment according to the bite categories, around 61% and 84% reported that PEP is required for category 2 and 3, which is the correct way of administering PEP. And as you know, in case of bite wounds, the first step you need to do is wash the wound thoroughly with copious amount of water and detergent, and only 33% and 43% of these respondents reported the need for wound cleaning for category 2 and 3. So in terms of their knowledge for administration for PEP and rabies immunoglobulin, 75% indicated the required dose 5 doses, and 11% of the respondents did not have knowledge. And in terms of the route of administration, 73% indicated their knowledge that PEP is supposed to be administered via IM as compared to intradermal. As you know, that World Health Organization currently requires that we use the intradermal route, which is dose sparing, and but most of them had knowledge, still prefer to use knew about the intramuscular route of administration. And 10% had knowledge of the different doses and volumes of intradermal. As I've told you, that you require very little in terms of, like, intradermal is like 0.1 ml per dose, but for when you're giving the IM route, you use the whole vial. So you find that intradermal is it's saving on the doses, and thus availability for more patients to use it. So in terms of those who've dealt with rabies and administered, from these respondents, they said they preferred to use the intramuscular route as compared to intradermal route. And 51 had knowledge. As you know that PEP can be discontinued. You can discontinue the use of PEP once somebody has been exposed, in case in the period that, in the process that you're administering the vaccine, you get to know that the bite animal has been tested to be negative. So you're given the leeway to stop administration of the PEP. And also after around 14 days, when the animal does not present with any rabies sign, it's declared free of rabies. So you can discontinue. So only 51% of them had knowledge of this or when to continue it. And also rabies immunoglobulin is required for category 3, those who've had multiple bites and those who have a higher risk of this virus having greater effects from the upper trunk upwards. And only 18% were aware in terms of which category requires administration of RIG. So in terms of their preference for their route, the route of administration, that is intramuscular versus intradermal, they preferred the intramuscular. Most of them indicated that they preferred intramuscular because of ease of administration of intramuscular as compared to intradermal. So in terms of their knowledge, the assessment of knowledge to get to know whether they are aware of the clinical signs of human rabies, about 2/3 of the 73 respondents mentioned signs such as abnormal vocalization, hypersalivation, aggressiveness, hydrophobia, and paralysis, which are correct clinical signs for rabies. And only about 8% of them indicated they had encountered acute encephalitis, which is a differential for other diseases that cause acute encephalitis, such as meningitis. And in case of such cases of acute encephalitis, for those who said they had encountered, only one considered rabies as a differential diagnosis for acute encephalitis. So in terms of how to manage rabies cases that they encounter, only 90% had knowledge of how to manage these cases. And in terms of how to confirm rabies cases, only a quarter of the 73 respondents knew how to confirm rabies cases, and 7 of them who had knowledge indicated sample testing for postmortem, or collecting samples at postmortem and testing for rabies. And 32 of them indicated confirmation for rabies by taking antemortem samples such as saliva, serum, cerebrospinal fluid, and skin biopsies. And 2/3 reported they had various ways of, they thought of different ways of transporting samples for analysis, such as watertight containers, leak-proof. And we know any sample that is being transported, you need to keep a cold chain. So that is the first thing that you have to think of as far as any samples and rabies samples are concerned. So at least only 11%, 18% indicated frozen dry ice overnight, and 11% storage at -20 degrees Celsius. And in terms of in terms of handling rabies, handling sample collection, for those who are the respondents, 2/3 of them were reserved in terms of handling rabies samples in the health facilities, and 73% recommended that it is better that the laboratory technicians be the ones that handle these samples, these rabies samples. And 43 of the respondents were not aware of where these rabies tests can be conducted in Kenya currently, the laboratories that are conducting rabies confirmatory tests. And of the health facilities that were visited, none of them stocked the rabies immunoglobulins. And though the county referral hospital and the sub-county hospital stocked the PEP. And only 2 out of 11 health centers and 2 out of 28 dispensaries, the clinics stocked PEP. And those clinics or the dispensaries were privately owned. As you can see that PEP is not that available to these particular people. So just in conclusion from this study, in assessing the knowledge, awareness of the healthcare workers and how to manage rabies and getting to know risk assessments and all that, in order to be able to combine efforts in eliminating rabies by 2030. From this study, we were able to establish that there is low awareness on how to manage rabies, and following the risk assessment as required by the World Health Organization, there is low awareness on rabies and rabies management. And there's need also for community engagement and effective delivery of rabies vaccines as far as these efforts are concerned, and to increase PEP availability. As you see that the PEP availability in the health facilities, as far as say sub-county and the county hospitals, yes, they had, but what about other health facilities? So there's need to increase PEP availability to be able to control rabies, and free point of care is the way to go. And just in conclusion, also there's need for proper management of rabies exposures, and increasing awareness of the use of intradermal routes, which is dose sparing and saves costs. So that's it, and thank you.
Our next presenter, and I hope you're all keeping your questions so that we shall discuss them during the question and answer. Our next presenter is Maurice Murungi, going to talk about bulking a business case for rabies control, analysis, and cost effectiveness of mass dog vaccination in Machakos. Maurice, welcome.
So good morning and happy World Rabies Day. Okay, my name is Maurice Karani. I'm a student at the University of Liverpool doing a PhD, and I'm pleased to speak to you today about work we are planning to do in some parts of Kenya, that's Machakos, and I'll be shortly speaking about that as they load on the presentation. Presentation, please. Okay, thank you. So I will be presenting on the rabies control, and that's building a business case. As I introduce myself, I'm a graduate fellow at IRRI and University of Nairobi. There is a newly formed department, ORECA, that's One Health and Research Center in Africa. That's funded by the German government. Next. So really what I'm showing there is like the big picture, because when you think about it, we are talking about rabies today, but rabies is not the only disease that afflicts us. Rabies exists in an ecosystem, or in an health ecosystem, whereby there are other diseases they are raised in Africa. And when you look at it, we are in sub-Saharan Africa, whereby the greatest burden is on poor tropical communities. So there is rabies and there is other diseases. And when you look at Africa belt and also the Southeast Asia, that's where the biggest burden of diseases are. And I will be coming back to this, because when you're talking about economics, and some my colleagues have alluded to it, you need to think big, you need to think the health system way, so that then you are not putting all the effort, all the money in rabies and then leaving other priorities aside. Next. And then this is a picture you have seen before, or a map you have seen before. And this really shows where the biggest rabies burden is in the world. So the global picture is, you can see Africa, again, Africa and Southeast Asia. This is where other diseases are too, but still, those are the regions that still suffer, that are suffering a lot from rabies negligence, rabies neglect. So rabies, as we know, is neglected. And we say neglected is that there is no political will, there is no economic will to tackle the problems of rabies, but still also other neglected tropical diseases. And now together here, today, we are trying to see catalyze ways how we can then bring rabies more to the fore, both at the technical level, and we think at the technical level, we are making very good strides, but also at policy level, so that we see more economic commitment towards the elimination. Next. So I now want to go to what I think the problem is, what we are proposing the problem to be. And I'm happy my colleagues, people have worked before in this topic, have put it very well, that the problem is, next. The problem is that sometimes back around 2013, the world came together and developed a global strategy of tackling the rabies menace. That is the Global Alliance for Rabies Control, the WHO, the OIE, the FAO, came together and developed a global strategy. And the agenda was zero human death by 2030. And Kenya, of course, the technical arm of Kenya being very proactive. A few years after that, we adapted that and developed a Kenya strategy. We localized that to develop a very transformative agenda through the strategic plan for rabies elimination. And in that document, we have developed a stepwise elimination strategy. And where we should be today is 2021. We should be in stage 3, whereby we should be rolling out a countrywide intervention. And maybe that's the question we should be asking ourselves, whether that's what we are doing. And if you want to look at it in another way, that by 2030, where we should be having zero rabies death by 2030, that's about 9 years away. If you want to look at it, you can think about those are like 3 World Cups away. In 3 World Cups, we will be there. So we need to ask ourselves whether we are where we wanted to be, given that we are still carrying out small scale interventions. Like, of course, if you want to think about it, our art was at the right place. We vaccinated some dogs in Malindi a few weeks ago. Is that where we envisaged ourselves to be at this point? I think that's the question we can all think about. And what maybe the problem is that what I see as a problem is that the technical side, us and other people, are very engaged in the control strategies, but there seems to be a disconnect between the technical aspect of rabies control and the budget, or the people who hold the budget passes, they're not willing to release it. And I propose that maybe we need to improve on how to we communicate to them, so that then we can say how much does it cost, but not only how much, that would maybe the easier part, but at what cost, because then the economics come to it. And that's what I want to, next. Okay, sorry, there, that's okay. That's what I want to address too, because us and other partners, that is IRRI, ORECA, which is a department at IRRI, the University of Liverpool, and the VSF Germany, have come together in collaboration with the government of Kenya through the ZU, and are proposing a project at Chakos, and the funding, as I said earlier, is through the German government, the Ministry of Germany, to undertake a mass dog vaccination campaign as the underlying activity, but also other related activities geared towards the control of rabies. And for this, we chose Machakos. As you know, Machakos is one of the pilot counties selected in the Kenyan elimination strategy. So that's why we're working in Machakos. But also Machakos is known as a rabies disease hotspot. And there is a nice rural urban scale. So there you can see the dynamics playing out at urban centers, but also at the very rural areas. But also still, there is the human livestock wildlife that is very alive at that point. Next. So what we are proposing is that we'll try to quantify dog bites and rabies burden in this area. Also elucidate the dog ecology. But now, as part of that, we'll also be rolling out mass dog vaccination, whereby we will cost this vaccination, and of course now be able to report on the vaccination coverage and the cost effectiveness. Additionally, we will also be able to explore the One Health, how the One Health functionalities work in this area, and also explore the innovative financing as part of sustainable financing mechanisms that could be used in this area. Next. So that's what we'll be proposing, but now in the next few minutes, I want to talk about the economics bit of it. Because as I said, there seems to be a disconnect between the technical bit and the policy, or the people holding the money. And what we need to do is maybe improve data on economics, whereby I'm sure if I ask what comes to your mind when you think about economics, you will talk about decision-making, use of scarce resources, and that because that's the area we live in, the opportunity cost, the money we use to control rabies, that money can be used to do other things. For example, control malaria, control bilharzia, because again, remember, we are living in a health system. And of course, the utility, whereby this is where we enhance the welfare, the happiness, and the nutrition. And also at that, we need to balance the optimality. You don't want to spend so much money when then you lose the opportunity cost of that. And under this, we assume that human beings are rational utility maximizers. You want to do a common good, but although there's an assumption that then does not take cognizant about the human short-term needs. And in all this, data is necessary to show the policymakers why certain interventions are necessary. Next. So, and those are some of the things you may know, is that then to do this, you need some direct costs associated with the disease. For example, the cost of vaccination, the cost of population control, the cost of surveillance, livestock losses, and vaccines and regimes. And that has been mentioned before. Next. But of importance is that then there is the human metrics, because it's not only about the things you use, there is the value of human. And there I've mentioned some of the things that, that are important in human metrics: the cost of illness, statistical value of life, and of course there is the mortality rate, which is very common, especially in COVID times. And now to my final thoughts, there is need for standardized and robust surveillance, and there is a need for robust and coherent interventions. I mean, the vaccination program we did, is it sustainable? The small scale vaccination. There is more need for economic data to match the epidemiological data, which I think we are producing very well. And there is need for studies to gather momentum and uptake by decision makers. Thank you very much.
Thank you. This is your computer. Thank you very much, Karani. Our next presenter is Dishon Muloi. The presentation will be volunteer-based approach to dog vaccination campaign to climate. He will show it himself. I can't read.
Hi, everyone. So my name is Muloi Dishon from Malindi. I work as a molecular epidemiologist. But today I'll tell you a story of evolution. So evolution came from a man called Charles Darwin, and he proposed that things grow and die, isn't it? After some time, they die or they succeed. So here I'll tell you a story about some of our work in Laikipia, which is looking at enhancing, again, sort of the same thing for Machakos in Morris talk in Laikipia as well. So here, we began a study in Laikipia. Sorry, give me a second. Okay. Next slide. Yes, thanks. So in Laikipia, we began a movement called LRVC, which is Laikipia Rabies Vaccine Campaign. And this movement is sort of composed of several people. The main partner being PALA, who is found in Laikipia, working with the government of Laikipia, the ZDU, and other partners in the US and the UK, and importantly, working with Mission Rabies and also ILRI. Next slide. So why Laikipia? I'm sure all of us know much about Laikipia in terms of tourism, in terms of good hotels, and in the last few months about chaos with bandits there. So why Laikipia? Laikipia is very interesting to everyone, to animals, to humans, to wildlife, and to tourists as well. So as most of you are aware, Laikipia offers a very unique ecosystem in the sense that here animals, humans, and wildlife live together. We find, as you can see in this photo here, you can see some gazelles, some zebras, cattle, and humans basically living together, right? So this offers a good place to study the transmission of diseases across the human, livestock, wildlife interface. And then importantly, it's good to see that Laikipia, again, there's a continuum from urban areas in Nanyuki all the way to pastoral communities in northern Kenya, isn't it? So this offers a very, very good place to study exactly how these things go. Oh, sorry, go back to the last slide, please. Last slide, please. Previous slide. Sorry. I can't control the slides. Previous one. Thank you. As you can see in that map there of Laikipia, the dots basically represent where wildlife is. Then the colors represent the rural-urban continuum, from very urban areas to very, very pastoral communities. So Laikipia is very interesting that you'll have to think differently when it comes to rabies, because what works in Nanyuki won't work in Doldol. And what works in NRT in Isiolo won't work in Nyahururu, for instance. And again, in this ecosystem, we see rabies is very prone. We found a few cases of rabies in Laikipia, some work done by ZDU and colleagues from CDC. They found some cases of rabies in humans in this particular ecosystem, and the same case for wildlife as well. And then importantly is to know that Laikipia is the main area whereby we have a population of wild dogs, who are, of course, a critical species. And in 2017, we almost lost the entire population of wild dogs in Laikipia because of what? A dog disease, canine distemper. So again, just showing you how important it is to think of rabies, not just because of public health, but also for wildlife and ecosystem health. Thanks. Then, so for our work, next slide, please. So for our work itself, we began LRVC in 2015 with 3 of my good friends, Adam in Chicago and Didan in Wyoming. This campaign began as a conversation between the 3 of us over a cup of tea at Tilbury, and we thought of just doing something to sort of give back to the community. We never thought it will grow to where it is at the moment. So I'll explain to you basically how it has evolved from a cup of tea discussion all the way to sort of being at the top of discussion in Laikipia County. So we began this activity as a volunteer-based campaign, whereby we had veterinarians and also students from Katrina University coming in to support us through volunteer aspects. And then, as I mentioned again, Laikipia, there's this continuum of rural-urban distribution. And again, we have nomadic and pastoral communities and people actually who live in permanent areas. Think of Nyahururu, Rumuruti, and those other places around Nyeri, all the way to Doldol. It's a continuum, isn't it? So we were targeting all of them along that particular spectrum. We have 2 approaches. One is a central point station whereby people bring their dogs to a station, and there's door-to-door whereby you actually move to the communities themselves. As you can see in the second photo there, we actually went to a particular household in Doldol. And then lastly is that, remember what Sam said and also what Maurice said and others, is that it's not just about the number of dogs, it's about the coverage, isn't it? You must have a denominator. So for us, we use 2 approaches, that is mark research surveys, and then again, surveys at the household level to determine the coverage of vaccination. Next slide, please. So the first thing we saw was that, as I said, this is an evolution, isn't it? From something small to where it is now. So in the first photo here, which is a map of Laikipia in panel A, that's 2015. The box in there, that's Mpala Institute. So in 2015, we actually did a campaign just around the center. 2016, we expanded our campaign, as you can see in panel B. 2017, again, you can see how it's growing big, isn't it? As you speak now, well, COVID sort of messed up with the plans, but as you speak now, we're actually targeting all the 4 main communities in Laikipia, from pastoral communities to folks living in Nyahururu, whereby they're living actually in the homes like any other place in Kenya. So we actually seen a slow but a steady rise of numbers in terms of the dogs themselves and also the spatial coverage. But then remember what Maurice said is that it's not about the numbers, isn't it? It's not about the numbers. You can actually vaccinate 10,000 dogs in Malindi, but who cares? No one should, because it's not about the numbers, it's about the coverage. If you vaccinate 1,000 dogs of 1 million, it's the same thing as vaccinating pretty much nothing, isn't it? So we've seen the rise in numbers. You can see in that plot there, in that line graph there, there's a steady rise of numbers over that time. But the challenge we are facing in this region is actually having to eat our coverage. Next slide, please. So this is basically 101 of rabies, and all of us now know about R naught and hard health. There's a magic number which is placed by rabies specialists, 70%. And I'm sure everybody now knows about COVID-19 and coverage and herd immunity. So the number is 70%. So basically, just to again to reiterate this, is that if you think this is a population of dogs in Laikipia, if you vaccinate 70% and you have 1 case of rabies, okay, which transmits to another dog, those 2 dogs, they won't find a naive population to infect, okay? And again, we'll hear from my good friend Nanyingi about how they do the fancy modeling, how to actually get to that number. So this is the magic number we need to achieve in our work. Okay. But then to get that number is not very easy. Think of what we did in Mariakani a few days ago. It's not very easy. There's lots of thought needed and lots of work needed. First of all, you need to know the population of dogs in your area for you to say you've covered 70%. So in Laikipia, we had a challenge. Next slide. Yes, yeah. So we thought, let's jab dogs. It's fun, it's fancy, it's really cool to do it. Politically, it's correct to vaccinate dogs. But then epidemiologically, it's not that easy. So as you can see in that box plot here, we have 4 communities. That is agro-pastoral in blue, pastoral is that golden, then green is pastoral permanent, and then red is fully permanent. Okay. So the coverage rates in the y-axis, they show the extent to which a community we achieved. In the agro-pastoral, we had 24% thereabouts. The highest coverage was in permanent communities. Is that surprising? Is it? Probably not, isn't it? These are people who live with their dogs in the community. It's probably easy to get their dogs together or actually move where they are. But then, Kenya is not just people live permanently all the time. We have pastoral communities you have to think about. So the highest coverage was in the last bar plot there, which was 77% in, I think it was somewhere in Nyahururu, I think. The lowest was in Idoldol, as you can see in that particular plot there. So the question is, how do we get the blue bar to go all the way up to, say, 70 or 80%? Of course, I have no answers. So, but coverage is not just about the number of dogs. There are many factors coming into play. Next slide, please. Next slide. So the first thing we see is that when you have central stations compared to door, you'll probably have more coverage, isn't it? Right? So where we had central stations, you can see in the first line graph there, sorry, in the first regression line there, we had more coverage where we had central stations, okay? In the second one, we see that that's community areas over, yes. In sparsely populated areas, we had less coverage. That is, in denser areas, we had more coverage. And that's obvious, isn't it? Nyahururu, you'll find more coverage than in Doldol. And then lastly, that is supposed to be dog density of dogs. The more dogs you have in an area, the higher the coverage you're going to achieve. But again, think of pastoral communities. How do we reconcile these 3 factors together? Because it's not just plain and white. Sorry, next slide, please. Next slide. So the second finding we found interesting was the issue of financing. Rabies is a public good, isn't it? Right? But how do we get governments and even importantly, county governments to invest in rabies? So from our work, we've seen that the work in Laikipia is so that it costed us $7.44 per dog without contributions. Sorry, with no contributions, basically saying that there wasn't any contribution from any kind of contribution like accommodation, vehicles being given by a conservancy, $3.44 with in-kind contributions, things like all Pejeta giving us accommodation for veterinarians and all that. And the cost was higher in pastoral communities. That is, as you move into door-to-door, you increase your cost. So you must reconcile the need to vaccinate to increase the coverage and the 70% number and also the cost. Next slide, please. And then the story gets a bit interesting. So in terms of community outreach, again, you know, all of us here are scientists. We always assume that it's about biology. No, it's about the social aspects of how people live. So we worked with the community in several ways. One was working with posters, working with the community leaders, teachers, chairmen of communities. We also engaged school clubs across Laikipia and NRT region. We found that there was a likelihood of people who knew about rabies, they were more likely to bring their dogs for vaccination. That's obvious, isn't it? So these are some of the examples we used in our work, just showing you the posters and the messages. Next slide. But then it didn't work. Something happened. In 2016, there was a massive outbreak of carne distemper in Laikipia. We lost so many dogs in Laikipia and also wild dogs. So when we went back in 2017, we were like, no, please go back with the vaccine. You killed our dogs. And we were like, how do we kill your dogs? So we found that a 50% reduction in our vaccination uptake in Doldol and other pastoral communities, just simply because of misconception. So what we thought, maybe we should hire a rumor manager. Maybe pay someone just for passing good rumors, if they are. because these misconceptions, they actually do affect uptake of these public health messages. And again, it's not just about rabies. Think of COVID. How many of us here have heard of the whole story of this is a new world agenda to reduce population? COVID, vaccines are bad. Same thing, isn't it? Human beings, they're just full of misconceptions flying around. So the key message we saw was that there's need to engage stakeholders, importantly stakeholders, and then have open discussions with them. Don't just tell them what to do. Also engage with them. Next slide. Yes. Yes, so our lessons from this work. First one is that this is a grassroots campaign. It's a volunteer-based approach. It's not very easy because there's no funding coming from any particular sustainable source. So sustaining this grassroots evolution-based approach is not very easy. It may just die off at some point. We hope it won't. There's need to think about the long-term sustainable and scalable approaches in some of these approaches. And one of them is that these are vast areas with very few people living in there. Therefore, the cost is very high. Again, these are mobile populations, always moving up and down. And then the question is, should we rely on donations? I don't know. There's a need to think about the role of donations in these campaigns because donors have their interest and other things, right? So the moment the donor is out of this particular area, then there's no more of that. Then yes, need for stakeholder coordination and all that. Then lastly, we also worked with the Ministry of Health at the last few years. Yes, thanks, Secretary. Just 1 minute. Last slide, please. So now our next steps are, of course, continue the good work. Evolution is also ongoing. So continue the work. Again, having science and national and local priorities in place. And then importantly, what Sam mentioned about variants. So we need to know what variants are in our population. Are the variants in Laikipia the same variants in Makueni, in Machakos, in Kisumu and all that? So we began some work on genomic analysis, looking at for geographic models, and then disease ecology, thinking about all that. And then for more information, these are paper, all the partners there from my colleague, Adam Ferguson, Didan, all the way to some of course here and other partners. So if you want to know more about our paper, please go and read there. Last slide. So thank you so much to all of us. Thank you so much to, importantly, the county government of Laikipia for actually just being very, very supportive to us. Thank you.
Thank you very much for that interesting presentation. Now, our next presenter is Mbaire Chuchu, on the efficacy of short message system on compliance with rabies post-exposure prophylaxis regimen by human cases of dog bites in rural Kenya. When you talk, have your mic near your mouth. And, keep looking at me.
Good morning. My name is Mbaire Chuchu. I'm a vet epidemiologist and an upcoming infectious disease specialist. I will be presenting on the effect of phone text messages reminder on compliance to human rabies post-exposure prophylaxis. So this work is was informed by our previous studies. That's from what Harriet has presented here right now on the availability of PEP and our previous work on rabies surveillance. So from our previous work on rabies surveillance, we've noted that our bite patients are reporting to the health facility, but the completion of the 5-dose PEP goes low. So we wanted to see if introducing an intervention would increase the compliance and the completion of PEP. Next slide, please. So yeah, the strategy acknowledges the need to provide post-exposure prophylaxis, but this comes with challenges of availability, the cost, and people not just being aware of why they need to complete the PEP. Next slide, please. So there are challenges. Yes, we when we are doing surveillance, we tell people, yes, you're bitten by the dog, but you need to complete your 5-dose PEP, but PEP is not available. So we conducted a study, I think in 2018, and we found out that those counties that are implementing rabies surveillance activity, they have shorter stockout periods. So by then, like Makueni County and Siaya, they were saying the stockout period could be 3 weeks to 5 weeks. But other counties that were not doing rabies activity, they could have PEP stockout of up to 36 weeks. But again, after devolution, these counties stated that after devolution, they are able to control their money. Yes, they are able to buy more PEP. So PEP availability increased, but again, we are not out of the woods because there are other priorities coming before PEP. So they will opt to buy other drugs and forego buying the vaccine. So that means a person who is bitten is at risk of exposure. So if PEP is not available at the government health facility, so that means any bite patient will have to incur more cost on buying the PEP. So roughly, now when you go to health facilities, public health facilities, you'll buy a dose of PEP at 800. When you go outside to chemists, you'll buy that at 1,000, 2,000, 2,500, even 3,000. So for a person who lives in rural area, having an income of 10,000 per month, and ask this person to buy a vaccine 1 dose at 1,500, that is too expensive for them. And again, the challenges with compliance, people say, we forgot the dates. As in, for now, we are using, in Kenya, we are using the 5-dose IMSN regimen on day 0, 3, 7, 14, and day 28. For sure, if my wound has healed and I'm not educated, I might as well think I'm healed. And by day 3 or day 4, my wound is healed. I do not need the PEP because maybe I forgot because the date's well. 1 month later, I'll be going for my 5th dose or have forgotten about it, or my wound would have healed and I don't need the dose anymore. So currently, the Kenya route we are using the IM route, which has 5 doses, but there's another regimen, which is a 2-site. So this means you're getting 0.1 ml on 2 sites. So on day 0, you get 0.2. On day 3, you get another 0.2. On day 7, you get another 0.2. So that means by the end of your regimen, you get 0.6. On the other one, you're getting 1 ml per dose. So that means you're getting 5 ml. By the time you're finishing the second one, you're using less than 1 ml. So the second one is cost effective, is sparing, has a shorter period. But again, we haven't effected that in Kenya. Challenges being like what Harriet has displayed here. People say they are comfortable using the IM method. Again, when you use the second method, it means you'll have more patients coming to the health facility. Because when you have 1 ml and you're injecting 1 patient with 0.2, it means that 1 vial is open and you have to have more patients coming, or else you have to discuss that vaccine. So again, I said why we decided to conduct this study is because we are having low compliance rate and completion rate of sometimes 40, ranging from 40 to 60. Next slide, please. So how we conducted our study, we were running a surveillance project at Makueni County Referral Hospital, having a register that people register their names when they report the facility with dog bites. So the study was conducted between October 2018 and March 2019. And this was a single arm before and after field trial. So we enrolled the bite patient, the control group before, between October and December 2018, and the intervention group between March and 2019. We wanted to do this simultaneously, but unfortunately, ethical consideration, we couldn't. So we sent these SMS reminders to the second group of the intervention a day before they get their second dose. the other dose until the 5th dose. So then we wanted to assess if sending this SMS would have any effect on them completing the 5 doses and adhering to the days they're supposed to go. So, but yes, there are other factors that could affect the compliance, like ownership of health insurance coverage, cover. So Makueni County has universal cover where you pay 500 and anyone in your household can get treatment from any public health facility for free if you have that universal cover. We also wanted to see the level of education of the bite patient or the next of kin and dog ownership status and the cost of PEP, livestock ownership, bite category, if sex would also affect compliance. Next slide, please. So from this slide, we enrolled a total of 186 bite patients. The pre-intervention was 104, that is 56%. And our intervention arm had 82 bite patients. As from what Harriet has also presented here, as always, the victims are those below the 15 years of age. And from our universal health coverage, 89% were having the universal coverage, which means the cover, which means they were not paying for PEP at the facility. And of course, most of them were farmers, and the household size was 6 people, and the monthly income, people living the rural, was less than 10,000. So, next slide, please. So what was the effect of the SMS on completion of PEP? So from our SMS reminder, those who received the SMS reminder, the completion was 93%, and the group that was a control group was 78%. But now we did our modeling to see if it's true SMS reminder was effective, and those that received the SMS reminder were 3 times higher. They were more likely to complete as compared to those that did not receive the SMS reminder. So what was also the effect of SMS on compliance? By compliance, I mean, did you get your 2nd dose on day 3, the 3rd dose on day 7, the 4th dose on 14 and 28? And first on the time to dose the 1st dose of PEP, 32% received the 1st dose of PEP less than 24 hours. Sometimes we see deviations. Sometimes we see deviation and we see someone got a bite today, but they will come 1 month later for their 1st dose of PEP. And the average time to 1st PEP was 1.9 days without, there was no statistical difference between the two. So on compliance, the 2nd and the 3rd dose were 4 times higher likely to get PEP on the said date for those that received SMS. So these graphs here, the one on the left shows the spread of how people are getting the vaccines on the said date. The one that is below here is the intervention group, and the one that is up there is the control group. You can see deviations from the day they are supposed to get the vaccine. So day 3, day 14, and day 28. But those that were in that intervention group, they were more likely to get the vaccine on the said date. So yeah, there are other factors apart from, next slide, please. So there are other factors that could cause people to increase compliance. And one, we found out being a male, you are 3 times more likely to complete PEP as compared to female. That is a question you would tell us. I see most of us are male. Tell us why you'd complete more than with the females. Yeah, and the households that were having more than monthly income of more than 100 USD are 3 times more likely to seek PEP on the recommended days. So some of the reasons that people said they would not complete PEP was lack of funds, forgetfulness, and availability of the PEP, and biting dog was still alive. So the group that received the intervention, there was no one said that they forgot to complete PEP because of forgetfulness. So from this study, we conclude, and next slide, we conclude that SMS can be used, and they're important in delivery of public health intervention as a complementary strategy for strengthening health systems. And some of the recommendation is that we can integrate SMS reminders to work synergistically in the control and the elimination of rabies. And yes, we also need to increase awareness in the community on the need to complete their doses of PEP. Thank you.
Thank you very much. Most of us are males, you remember? Now, the next presenter is going to be Dr. Daniel Kise. He's going to talk about coverage of mass dog vaccination towards rabies elimination in Makueni County. Kise.
So good morning. I'm going to take you through a process we have undergone in Makueni County. If you could start the slide show, please. A lot has been said about Makueni County, and the main reason why we have a lot of discussion about Makueni is that at the time we launched the National Strategic Plan for the Elimination of Rabies, we picked Makueni, Machakos, Kitui, Siaya, and Kisumu as some of the pilot counties. And yeah, you can go to the next one. And what has happened is Makueni faithfully implemented this strategic plan, and today we want to have a discussion about some of the the things we have learned from that process. We have already heard a lot about rabies and how it is affecting people in Africa, Asia, Kenya in particular. The National Strategic Plan for Elimination of Rabies has also been talked about. It was prepared by stakeholders. Professor Dhumbi talked about that, and adopted and launched in Makueni County in September 2014 during World Rabies Day. Of course, it's built on several pillars: mass dog vaccination, timely provision of PEP, surveillance, and public health education. And this presentation is focused on the pillar about mass dog vaccination. That doesn't mean we have not captured the other pillars in our processes, but for this particular presentation, we are going to talk about mass dog vaccination. Please, could you go to the next slide? Yeah, so the story about Makueni, Kisumu, all that you are aware, how the two broad areas were selected to pilot the strategic plan. Of course, the idea was we pilot, we learn lessons, we move it over the whole country. So Makueni is there in the map. So at the point of starting this program, we had an estimated population of 987,653 against a dog population of 125,706. And like some presenters before me have talked, we needed to do a baseline population. That's how we came up with the 125 through a small census, which we conducted across the county, covering all the animals. But of course, the of interest was the dogs. Next slide, please. So after the census, we did a small pilot. Makueni County is organized in 6 sub-counties and 30 wards. So we picked 3 wards and we did work using the normal vaccination centers we have been using for cattle, for goats and all that. So we used that in our pilot. And then that was in August 2015. And then in December, we changed that a bit. You'll see the results. So in terms of planning, the programs were planned to be implemented at ward level. So the ward was our unit of implementation. Coordination was at the sub-county, and then supervision and support was from the county headquarter team with the partners we were working with. And the plan was such that we target school holidays when our young people are normally at home, so that we expect more turn up, because you know the young people are more close with the dogs. And next slide, please. So the other key issue about the program was publicity, which we did through the normal process of posters, which are distributed all over the place, announcing the dates of vaccination. Then we were working with our administrators, that is chiefs, that is, I mean, both national government and county government administrators. We had a small budget to facilitate them to do SMSs, to make telephone calls, and so on. We were also working very closely with the church leaders, because we were using them to advertise our programs for the coming week. So if we are starting on a Monday, we could move around the churches in the area and we give them the letters, then they would advertise. We were also doing mobile publicity with a vehicle mounted with a PA system, which would go around on the last day. Just as we plan to vaccinate tomorrow, then we would do it today, so that we remind people that the vaccination will be tomorrow. Next, please. So the vaccination was done on what we are calling static points. So we would pick the particular points where people are going to bring their vaccination. I mean, their dogs for vaccination. They are either mostly schools or market centers. And we had assigned in terms of personnel, we assigned a vaccinator to do 2 sites, so that we have a morning which started around 9. And then we do an afternoon, which was starting around noon, so that we utilize the personnel we had as much as possible. I have mentioned the costing we spend on the personnel. This is important because at the resort point, we shall be talking about the cost of doing a vaccination. So due to shortage of staff in the government, we against private sector service providers, mostly AHS, and we had an agreement that we facilitate them at the rate of 2,000 shillings so that they will get their own transport and get their allowance, and also the public staff. So the guy assigned a station was expected to do the vaccination, to do the recording, to do the certificates, and then they would collect, or at the end of the day, they would send their data to the sub-county officer who would now combine reports for the whole sub-county. Next, please. So in terms of analysis for this report, we are talking about population estimation. We had a census in 2015, which we used to do our percentage estimates for 2016. Then for 2017, 2018, we are working on increased population based on the dog-human population ratio and based on the population projections by KNBS for the human population for 2017. So we used that figure to calculate the percentage. And then for estimating the cost, we did all the activities that we did, we costed them. And then at the end of the costing, we divided by the number of dogs vaccinated across that period. And at that point, I want to ask Dr. Chucho to help me a bit.
Next slide, please. So, okay. So on this slide, we are showing the results of the vaccination. So we said we started with a census. The dog population was 125,700, and most of the dogs were male. And the human population, the projected human population for 2015 was 987,000. So by the calculation of that, we get a human dog population of 8 people is to 1 dog. So after doing the census, they wanted to pilot. They wanted to pilot the vaccination before going into the full implementation. And they did that in 15 wards. So the table on my right, the coverage on 2015, it is not appealing. The numbers were low. And from that, they learned lessons. And some of the lessons they learned that they had to reduce the distance between the vaccination points. So initially, they were using the usual kettle dip as vaccination point, but they noticed those were too huge distance between the vaccination points, and the community would not go to those points. So they reduced the distance. And again, they wanted to make, they were using publicity. By then, in that 2015, they used only posters, but posters were not effective, and they had to improve on that. So they opted to use chiefs and the public address and the churches. And from that, we can see the coverage changed and increased to in 2016. The other lesson they learned that they were taking one person and staying in a vaccination point the whole day. So they opted to use this one person vaccinating in 2 points. So one vaccinator would stay from morning to midday, then move to the next vaccination point that is closer to him for the afternoon session. So this map here is showing the vaccination coverage for the 3 years. So in 2016, the vaccination coverage was 63%, then 2017, 60%, and 2018, 57%. So from the first graph of 2016, you can see most of the vaccination coverage was happening in the northern part of the county. So that graph is just to show the disparities in vaccination coverage. Next slide. So this graph here, we wanted to show vaccination coverage per sub-county. Makueni has 66 sub-counties. So we wanted to show how the sub-counties were performing. So that dotted black line there shows the 70%. The continuous black line shows the performance of that sub-county. The blue dot shows the number of dogs vaccinated, and that is the Y2 axis. So the Y1 axis on this side is the 70%. So taking an example of one sub-county, which is the sub-county on my left, is Kaiti sub-county. We can see the vaccination, they started with a good number, then went decreasing over the time. Next slide. So we wanted to calculate the cost of vaccinating one dog. If you could look at this, what Makueni did and what Dishon has just presented, the approaches are different. So the total cost for vaccinating one dog, we calculated it to $1, $1.04. That is inclusive of post-vaccination coverage, post-vaccination surveys. So for Makueni County, they had census data. So they didn't need to do post-vaccination survey, but we conducted the post-vaccination survey as the surveillance project. So Makueni County, the cost of one dog is 0.99 USD, but most of this cost goes to procurement of PEP and paying the staff and coordination. So these beautiful maps here with different colors is showing the distribution of vaccination points in Makueni County. The 6 sub-counties with the distribution of the vaccination points. The other dark map there, it shows the distribution of vaccination points, and what is overlaying is the population of Makueni County. So the areas that look white is where we have higher population of human, and we can see where we have the higher population, there are more vaccination points. And the green line there is where we have the main road. If my photo could move slightly, you could be able to see, okay, the previous slide, you could be able to see that along Mombasa Road, there are more people along Mombasa Road, and there are more vaccination points in that line. Next slide. So this slide here, we wanted to estimate and see how long it takes a person to get to a vaccination point. So on average, a human walks at 4 to 6 kilometers per hour. So we took an average of 5 kilometers per hour and tried to estimate and see how long it takes the Makueni County or the community to get to the nearest vaccination point. The green dot there is the people walking for less than 20 minutes to the vaccination point. The red is people walking between 21 and 40 minutes. The blue is people walking between 41 and 45 minutes to the vaccination point. So 70% of these people in Makueni are working for less than 20 minutes. So calculating that, it means they are working for less than 1.7 kilometers. So that is the distance between the vaccination points. Extrapolating that, it means that 86,000 dogs are being vaccinated within 1.7 kilometers, and they can be vaccinated, they can be taken to the vaccination point in less than 20 minutes. Right. So we wanted also to check, previous slide, please. Previous slide. Previous slide. So we also wanted to check if distance between the vaccination point affects coverage. And we did a model. And so that for every 100-meter increase in distance between the vaccination point, the coverage will reduce by 1.3%. Next slide. So these maps here, we are showing the disparities in vaccination coverage in the 3 years. So the blue spot there is called a cold spot. A cold spot is when you have an area with a high vaccination coverage, and then the neighbors have high vaccination coverage. The red is an area with low vaccination coverage, and the neighbors also have a low vaccination coverage. So looking at 2018, we have an area with low vaccination coverage, but as Dishon said, sometimes we don't foresee challenges that might come and reduce our vaccination coverage. I remember in 2017 is when we had the election, and it was, they were coinciding with the election period. So most of the people would not bring their dogs for vaccination. And yet, again, what Dishon has just said on things like, now we are having the pandemic and people cannot bring their dogs for vaccination. So maps like this would help the county to identify areas that has a weakness and prioritize to work on them. Next slide. So yeah, from these slides, in the work of Makueni County, say it is possible to conduct mass dog vaccination where county government working with other partners, and there must be efforts to sustain the program. And areas to be focused on our publicity and distance that the dogs have to walk, and the timing of the program and your personnel. So to achieve elimination in the county, there needs to be coordinated efforts throughout the country. Thank you very much.
Person is going to be Mumba Mutunga. I'm reading what I'm given. Okay. So the topics: mapping access to healthcare facilities for rabies, post-exposure prophylaxis for dog bite patients in Makueni County. Makueni here. Welcome.
My name is Mumbwa Mutunga. I am a master's in medical statistics student and also a fellow at the Center of Epidemiological Modeling and Analysis, that is SEMA, and also a fellow at the University of Nairobi, Institute of Tropical and Infectious Diseases. And so I'm going to speak to you about mapping access to healthcare facilities for rabies post-exposure prophylaxis by patients in Makueni County, and this will be a spatial analysis. Next slide, please. So for most of the studies we've had and we've seen, the focus has been mainly on rabies, transmission dynamics, and mitigation strategies that advocate for mass dog vaccinations up to a tune of 70%, and human post-exposure prophylaxis. So what I am going to present to you today is the challenge of possibly putting PEP in all the facilities that we have currently, which is one, very uneconomical, and two, given the expensive nature of the facility, of the vaccine, it's very impossible to put it in all the health facilities. So what do we do? So as I have just said, the challenges of PEP are fast accessibility for bite patients and affordability that Chuchu and Harriet has spoken about, and then stockouts of PEP in health facilities, where for this work, our aim was to use spatial data to map health facility accessibility that could be important in guiding PEP placement, and not just placement, but optimal placement of PEP, which, as you all know, is an on-demand vaccine and is not always available in these health facilities. And again, as I've said, it is expensive and cannot possibly be placed in all the health facilities in the counties. So what are some of the barriers that we have for PEP access? So one, we have the geographical accessibility, which speaks about the distance for patients to the health facilities. And the other thing is the availability of care sought. So if I go to a health facility and I have a bite from a possible rabid animal, will I get the PEP? And then the other thing is financial accessibility, which informs the amount of money that I'll be asked to pay, and can I afford it? And then the other thing is acceptability, because as you well know, not everyone wants to will want to go to a health facility to seek for healthcare. So the other thing, so what was the objective of our study? So the objective of this study was to assess the physical accessibility for post-exposure prophylaxis in Makueni County. And the second one was to determine the optimal placement of PEP within the health facility network to increase access. Next, so for the methods. So we obtained several data sets from different sources that have linked there. And we use these data to build up on the cases and the results that I'm going to display to you shortly. So we use geocodes for all the health facilities within Makueni County. We took something called digital elevation model that is used to account for the altitude. And then the other thing we had is the population density within the Makueni County, the land use grid that shows the vegetative components of Makueni County, the hydrographic networks, which shows the water bodies. And the other thing that we looked at was the road networks, which includes all the types of roads that we have within Makueni County. Next. So for data analysis, we used a WHO tool that is called Access Mode, which shows the physical accessibility existing between the health facilities and the population. So we incorporated the health facilities as well as the population and how accessible these health facilities are to the population. So this tool has been used for medical, obstetric and surgical care like maternity services. And so it has been used before, but I think this will be the first time that is going to be used on an on-demand vaccine, which is the rabies post-exposure prophylaxis. And so what this tool does, it layers all the previous data sets that I showed you. And then once it layers them, it corrects and applies a respective traveling speed that, say, for example, walking through a thick vegetative area and driving through a highway as opposed to driving through a primary road. So it layers all of them together. And then we have a map that shows the different types of movements towards the health facilities that we have within the county. Next. So these are some of the results that we got. And I'd like to say right now that this is still a work in progress. And if you see the figure on your right, it shows you all the health facilities that we currently have in Makueni County. And it shows you the travel distances between those facilities and the population. And if you see that figure, you'll see that 46% of the population in Makueni County is within a health facility with between a 30 minutes walk or drive. And if you consider a 2-hour drive or walk, then 71% is covered. But now this is where the interesting part comes. In Makueni County, out of the 248 facilities, public health facilities that we have, only 12 stock PP. So we tried to look at what these 12 would look like if we mapped the 12 only and considered the whole of the population. So the figure on your left shows the travel time to the 12 PEP stocking facilities within Makueni County. And if you see the table down there, it shows that only 7% of the population in Makueni County is able to access a health facility that stocks PEP within a 30 minutes walk or drive to the facility. And then if you consider a 2-hour walk or drive combination, only 17% is able to access a PEP stocking facility. Next, please. Next. Okay. So what access mode does, it then does something we call a scale up, where it incorporates the scenarios that have been shown. And then if it sees that there are still a number of people that are not covered by the health facilities, it does something that we call scale up, where it identifies optimal facilities that could be used to stock, to say, for example, place whatever it is you're trying to map out. And so for our study, we found out that if we incorporated 9 more facilities into this study, then probably those will be optimally placed such that they could cover a bigger population. And so what we are currently doing and trying to analyze is, if we added these 9 facilities on their own, could they be able to serve a bigger population as opposed to the 12 that are currently existing? Or we can add up the 12 plus the 9 and see if you're going to get a bigger population being covered and traveling a less distance to reach these health facilities. That way, we can be able to see if we are going to reach a bigger population. And the other thing that we are also trying to look at is to see if the health facilities that we currently have and these ones that we are proposing, if they could work together and increase the number of people that are being reached by the PEP. And also ensure that these are the health facilities that when one is bitten and they visit, they are stocking the PEP and it never runs out. Next. So what is the aim of this study? So the aim of this study was to provide guidance on the best way to ensure that potential bite victims get timely vaccinations, especially in rabies endemic countries and counties in our case. And this paper is an initial attempt to study the relationship between health facility travel time and barriers of on-demand vaccines. When I say barriers, when you saw the 2 graphs that I displayed, on a normal day, you'd say that if someone is bitten by a rabid dog or animal, they are actually within reach of a health facility. But the things on the ground is that not all these health facilities stock PEP. So what that means is that you will have to travel more distance to be able to reach a health facility stocking PEP. So this paper can be able to inform the different counties that we have here that given incidents, you can place your PEP at this point and ensure that it covers the bigger population. So the initial analysis given a number of health facilities within the county and the population can be used to draw that conclusion that I have just told you. But in actual things, the way they say vitu kwa ground are different. That is the same situation here. Next. So the limitations of this study is that we didn't feel the private sector in PEP provision because we did not have data. We weren't able to access data from the private sector. So that limits our inclusion scope, but I think in future we can be able to collaborate with the private sector to ensure that we can bring them in, and also when we are mapping, we can include the private sectors, hospitals in that network. Next. So the recommendations, these were the initial results of the study, and the next step will involve incorporating incidents so that we basically we do the mapping, but we also look at the places where the incidence is high and see if we can have a health facilities within those areas that can be able to serve the communities at risk. And then PEP data from private health facilities should be incorporated in this, as I've just said. And then to eliminate, remember, to eliminate and declare freedom from rabies, you need data. And that is the one thing that is a problem currently, that we do not have sufficient data to actually say that we are eliminating, even in Makueni County. Like if we had enough data to say that we are towards or heading towards elimination, then we will have that. But right now and here, I'd like to propose, like, for us to have that chance of saying that we are at the verge of elimination, probably we will need to incorporate something like the One Health system of integrated bite case management, such that after we've optimally placed these biting centers, or rather in the health facilities, when someone comes to those centers, we can actually capture that information, send it to the vet send people to the field, and they have that One Health system where there's reportability, and we can easily monitor a situation where there's an outbreak somewhere. So next, so I'd like to acknowledge my supervisor, who's Professor Thumbi Mwangi, and Mutono Nyamai, the University of Nairobi, where I'm registered as a student, KEMRI, Makueni County, where this work has been done, and the Center for Epidemiological Modeling and Analysis, where I am a fellow. Thank you.
Thank you very much. Now, our last speaker this morning is Dr. Samantha Opere. It's a long topic here. She will read it herself. And then after that, we shall go into question and answers. Thank you.
Good morning. Okay. Yes, my name is Dr. Samantha Opere. I am a vet, obviously. My presentation is very long. It's integrated approach to disaster of economic and animal welfare concerns. It's a two-part presentation. Because of my love of donkeys, I will divert your attention briefly and then bring you back to rabies. Yes. Yes. So next slide. So I know most of us are on office or WhatsApp groups, yeah, where there's always information about different work-related issues. Next slide, please. And then play the video. So on the 31st of December 2019, my colleagues and I received this particular video in our WhatsApp group. Is it playing? It is not playing. Play the video. It's not? Okay. Anyway, so the video was of a woman. She's complaining that their donkeys have been bitten by some flies and they are unable to work with the donkey. So the next slide, please. So we went to Meru Igembe, Tigania area, where we did our initial assessment of the issue. We had donkeys. It was like a fashion show for donkeys. So donkeys were in skirts, donkeys were in stockings, donkeys were in bodysuits, donkeys had gunias. And all of this was because of some flies that were mysterious, and they didn't know what was causing these flies. And so they tried many options of drugs. In the video, she mentions they've put tobacco, they've put every spray, and their last resort was to now dress their donkeys with their clothes, because the donkeys were being bitten and they were bleeding and they were unable to work. Next slide, please. I don't know if this one will play, but if it doesn't play, this lady is an old lady, you can see, and she's, in the video, she's beating, not beating, she's, it's gone, this thing, this one, yeah. She's doing this to the flies on her donkey's legs because, yeah, whisking, yes, on the donkey's legs so that the donkey can eat, because the donkey is one eating, and when they're not eating, they don't have enough energy to work. Next slide, please. So on the next slide, when we undressed the donkeys, this is what we found, that they were in poor body condition. The flies were mainly biting the ears and the legs. If you're very close, you might see the flies on the wounds that are there. Next slide, please. So in the area, we had been told there are roughly 2,500 donkeys. Of these, 1,000 had been affected. And of those, 181 had been reported dead. Next slide, please. So because of technology, we looked at the flies on the body. If you can see, there's some small dots of blood. It means where the fly bit, as it left the animal bleeding a bit. So we collected a fly, we debated among ourselves, but we sent, it's good to have friends in different spheres. So we sent this image to someone at Kentech, and he identified it as Stomoxis calcitrans. Yes, you remember. So this is Stomoxis calcitrans. So now that we know what we are fighting with, we went ahead to collaborate with the county administration. So you can see a chief there. Next slide, please. There's a chief, there's the county vet, that's Dr. Mboroti of Tigania West, and there's my colleague Martin, who is now representing the animal welfare organizations. Basically, we can't intervene if we don't have support from our administration, if we don't have the county vet whose problem now is the flies, because the lady says, tunaomba serikali. So he's the serikali on the ground related to livestock matters. And we came in because we are specialists in donkey welfare. So there was Brooke and there was Kendat. The next slide, please. Because we are working with people who have the drugs, this is a photo of Dr. Kani from C. Cooper's Kenya Limited. They have healing oil. So we roped in people who we know have the drugs that can be used. So we also got Ultravetis because they have Ectopor, and we got Vectocid. So it's always good to work with your friends when they're in different aspects. Next slide, please. On this one, we did some sampling. So we worked with Chuka University. We collected samples from 132 donkeys. The results from this, we got 4 donkeys had some babesiosis species and 42 had trips. So this was probably the cause of death for some of the donkeys that we had. Next slide. So because the issue had come from Nation had highlighted that donkeys were being dressed in Meru. So we had to get Nation and other stations, this is Baite, the lower one, to come and tell people that we have discovered what these mysterious flies are. So they came and they did another article. Dr. Kinoti yesterday mentioned, next slide, that donkeys and dogs have a close relationship. He mentioned that the dogs are most likely to bring rabies to the donkeys. And in this case, the donkeys, when they're flies, led to the dog also getting the flies biting their ears. So we also attended to some dogs. Next slide, please. This is the sea of donkeys we were met with. Next slide. So as we did our intervention, I know it's been repeated since yesterday's presentation that messaging is key. We had some people who said they had used Ectopor and other sprays, but the issue might have been it wasn't effective because the application was wrong. So this is, the top photo is a county officer demonstrating how to apply Ectopor. And the lower one is a community member spraying the donkeys. Remember, spraying is from back to front, down to up, so that the acaricide gets onto the skin of the animal. Next slide. So our overall outcome was that we managed to reach 736 donkeys. We managed wounds of 400 donkeys and 5 dogs. The image there shows an undressed donkey shining in the sun. because the intervention that we had was effective. Next slide. But the reason for all my stories is this, that we need to work with people outside our sphere to get solutions that we need. So with the administration, with the county vets, ourselves, research and pharmaceuticals and media, 2 days later, after the first video, this was primetime news at 9:16 p.m. NTV then reported that beasts were unburdened. And because we gave the correct information in terms of what was causing, what these mysterious flies were, the journalist was good at getting an image of Stomoxys calcitrans. Yes. But now I bring you back to rabies. Next slide, please. Yesterday, Dr. Kinoti had mentioned how we had a rabies case in Nairobi. My many circles there are just to show the sequence of events. We start with the donkey owners network. One person's donkey gets rabies and we get a call as a welfare organization. We then send our service provider on the ground. As Brook and partners, we are scarce on the ground. That's why we tend to build the capacity of the private practitioners in the area so that they are able to then handle all our cases, and we refer the cases to them because they're the ones who are there. So the person who went said that the signs that they saw in the donkey were looking a bit like rabies. So he then went, because it's notifiable, he informed Dr. Karugu, who is now the county veterinarian, and we went along with KSPCA to collect the sample and then take it to Kabete, where it was confirmed to be rabies. As I go to the circles on this side, there's the issue of the networks. We're talking about community education, which is key for all of us to eliminate rabies. Do the people who own the animals know what they're supposed to do? Are we getting the schools and religious institutions involved? I like that Makueni has been very outstanding here because they have had a lot of success and they've been working with all the networks and they've shown that collaboration truly makes a difference. And the other thing that we need to know is we can't work alone. So we should work with schools. We already know that 40% of the people who are bitten by dogs are children under 15. Even as you look at the image, I think it was mentioned here that they do vaccination during school holidays because children are the ones who will bring their cats and they'll bring their dogs. This image shows some girls who are sitting with gunias. In the gunia, there's always a cat. So this is why children are key and we need to sensitize them properly. We also need media because media have a wide coverage. We shouldn't just be talking about rabies in September or when there's an outbreak. We should talk about rabies every day of the year so that people remember that we have a goal of eliminating rabies and we can only do it if we all work together. Next slide, please. So the outcome of our intervention was that we got 1,654 dogs. We got 302 cats and 431 donkeys. I know you'll say that donkeys really don't transmit rabies, but just for the sake of the owners, because donkeys don't have shelter, but they are outside. And so the owner might not know that it interacted with a rabid dog. And for the case that we had, the owner didn't know that his donkey had been bitten by a rabid dog. And so when he was bitten, it's not the first thing that he thought of until the donkey had started showing signs. So also the time it took for him to go and get his PEP was also quite delayed. Then we reached 2,104 animal owners with information on rabies and post-exposure protocols. Yes. Yeah, again, this is just another image of a child, probably under 15, who brought his dog for vaccination. So it's just emphasizing that the link between children and rabies and their pets is quite close. Next slide, please. So my final words are this, that alone we can do little, but together we can do so much. I I think it was mentioned here that when you go to the health clinic, that you are, the health workers are not really keen on rabies. And I identify with that because in Kisumu, I went to get my booster shot and I walked from nurse to nurse. And finally I got to the doctor trying to explain that, no, I have not been bitten, but because of my job, I need a shot. And no one is understanding. Were you bitten? No. So why do you want the shot? Were you bitten? No. So why do you want the shot? So it's upon us as the professionals in this area to also go out to other health workers, even our politicians for buy-in so that we can get more coverage and be able to eliminate human rabies by 2030. Thank you.
Okay, now because I consider only 2, 4, 6 seats, can we have the initial 6 presenters sit here? Or would they rather sit where they are and they answer from there? Okay, please. They can sit more. Yeah, could we have 2 more seats added there? And I hope we have a lively discussion. Presenters, please. Presenters, please. Okay, so some more will come. Now, do we have any questions? Yes, there are 2 questions over there. Who is there? There's a 3rd one there. There's a 4th one there. Good, good, good.
Dr. Mulai, where is Dr. Mulai?
Okay, when you ask, tell us your name. Just your name and then do the question.
My name is Nyamoya from Kwale. Thank you for the wonderful presentations. This was one of the best presentations. Okay, mine is figures don't lie. From yesterday, we have been talking about deaths of people in Kenya from rabies. Some have said it's 500, some is 1,000, some is 2,000. So I don't know who actually takes the lead, because we should have one figure. If we are talking about Kenya, we should just have one figure, 500 is 500. Then when we talk about rabies samples, collection and dissemination of rabies samples, I don't know really what we're talking about, because confirmation of rabies, we know, it's about the head, because we have to go to the brain to confirm it. So when we talk about collection and dissemination of rabies samples and the storage, what are we talking about? And finally, on publicity, just a comment, is that it's also important that when we vaccinate these dogs, especially for the next round, to take the telephone numbers of the owners. It's very important the owner feels included when he's either given a message or a text to inform of the activities going on, other than just the church and the other publicity methods. Thank you so much.
Okay, let's answer one by one like that, and let's be very specific. Dumbi, would you like to answer that?
On the number of people that die from rabies, the fine print is this. The estimate of 587 with a confidence interval that goes down and up come from a 2015 paper that was done by Katie Hanson. And unfortunately, it's based on the results of Dr. Kitala's PhD work, which happened in 1992. So there is actually a big gap. There are no papers available that tried to estimate that. So they used what was available for Kenya, and that dates back almost 30 years ago. The estimate of 2000 is an attempt, back of the envelope attempt in calculating the number of people that die from rabies in Kenya. That was done when we were preparing the strategic plan. So that accounted for the incidence of rabies bites that we were seeing at that point, and also accounted for the number of dogs that were estimated based on the human dog population ratio. So the true figure is unknown, and we are using modeling estimates to say that the death that comes from rabies is somewhere between 500 to about 2,000. Now, you raised an important point. It's extremely difficult to confirm a rabies case in humans for the very reason that, same thing you're suffering with COVID. Testing is not well done. And unfortunately, the only way we confirm a rabies case is through a post-mortem. And once death has happened, it's an extremely difficult thing to do a post-mortem in our culture at the moment. So we are dependent on modeling outputs. If I am to provide you a bit more confidence, even the malaria estimates that are done for the Sub-Saharan Africa also depend on that. We have a big problem on data within the continent, and you have to depend on this kind of approaches to give us some idea where to start from.
Thank you. And the next question, who among you would like to answer? Okay, Madam.
Thank you. Thank you very much for your question on collection of samples. So for humans, it's you're right. Confirmation is through postmortem when you collect a brain sample. But remember, in humans, there are differential diagnoses. The presentation of encephalitis, it presents has different diagnoses. There is cerebral malaria, there's meningitis, and rabies is just one of them. So when you're presented with this case, how would you know that this is not malaria, it's rabies? So one way to find out that this is rabies is through antemortem sample collection, which you collect saliva samples and a skin biopsy at the nape of the neck. Thanks.
Okay, on publicity, anyone who wants to answer that? Publicity. Let's park that. Next question.
Yes, I have questions to two presenters. One is to my name is Professor Kiurani, University of Nairobi. One is to Dr. Rina Wangila. In terms of the award, you mentioned the awarding MSc certificates. Is that true? Because I didn't understand how you can give an MSc certificate after a 4-week training program, and you're using the University of Nairobi as your standard or collaborator. And then, so just clarify that, because the University of Nairobi has its own standards. So then, can I ask my second question? The second question is to Dr. Samantha Opere. I can't see her. Okay. Because I noticed your emphasis was on the stable flies, which was very, very good in terms of what you showed us. But you also mentioned the fact that the donkeys had trips, but you didn't talk about the trips in any way in terms of your management. First of all, because Stomoxis is a mechanical vector for trips. So what trips species did you find in the donkeys, and how did you manage them in terms of both treatment and prophylaxis? And then you also used, for fly control, you also used ectophore and vectocid. So why use both? What is your rationale for using both, other than the fact that they were probably from two different companies?
Thank you, Professor, for that question. I think I didn't communicate well. The current certificate that we are offering is not an MSc certificate, but just a certificate to show that the trainee completed the 3 months training. What I mentioned on the intermediate, advanced, and frontline is that currently we are at frontline. In the future, we are looking at intermediate and advanced and be able to house that course either in the University of Nairobi or Egerton at advanced level. So these are plans for the future, 5 to 10 years, maybe.
Thank you. Opere?
Hello. So on the first, we didn't use both the ectophore and vectocid. So ideally, we were mainly doing the spraying, but we demonstrated how ectophore can be used for future prevention. So there was just maybe one demonstration on one animal, but majorly we measured on the vector seed to immediately get rid of the flies. On the trips, we usually have our animal health practitioners, the private ones. So they're the ones who followed up with the cases to do the treatment for the donkeys that were identified to have had trips. Okay.
We'll have another question before we get one that has come through some other means. You will be next. Please proceed.
Okay, thank you. I'm Dr. Mwangangi from Veterinary Department, Nairobi. My question goes to the scientists who are working in Makueni. I've seen in the initial stages, you attain very high percentage, sometimes up to 99%, then it came down. So I do not know whether this one has been caused by, is it an apathy, or is it because those dogs had already been vaccinated and they had not maybe completed the 1 year for revaccination? Secondly, do you have to sustain the 70% continuously so as to say that you have acquired herd immunity, or you consider now like those factors which are overlapping? And thirdly, in this period when you have been vaccinating, have you noticed any change in terms of human and dog rabies cases in Makueni County? And lastly, a comment. I think there's a clinical officer in the house. And when we had lunch yesterday together, she told me that some of these things which are One Health, we need to be publicizing them, publicizing the KVA conference, scientific conference, not just for us as vets, but across the One Health approach, even to our colleagues in the ministry. Because they are even the colleagues who are just here in Malindi, they do not know that you are discussing about rabies. Now, wako hapa. So that is something maybe going forward we should consider for us to be able to really pass these messages instead of passing just to ourselves, saying, okay, we found the other side, there was no much publicity, and yet that.
Okay, that's a very long-winded thesis. I would take it as advice and go to the next question. Sorry? Okay, who would like to answer those questions about the numbers changing from 97% to 5%? Is any of you ready to answer that? I thought it was kind of answered in the lady who told us there were, no, Kibor, it's Kibor, I think. You can try. Yes. Don't try, just do it.
Thank you. Perhaps I could combine those very many questions with also the question about publicity, because the dynamics of conducting a vaccination campaign, whether rabies or any other, is in livestock is complex, and that can be seen from the results of what we have achieved here in Malindi. After 2 very serious days of work, I'm told we did about 200 dogs, which we vaccinated about 200 dogs, which is like an average of 1 dog for each one of us. So the other factor of publicity is also cost, and that is why a lot of these programs don't succeed. Now, in terms of why the figure is going down, I can only speculate because I don't have data to prove that. But one of the reasons about percentage going down is related to the population of the dog which we projected to be going up. Otherwise, the absolute figure for 2016 and 2017 is almost the same, as a slight drop in 2018. The other thing was alluded to by Dr. Chuchu, the politics of 2017. You remember we had the two elections in 2017, and people were fully on politics instead of other normal activities. This also affected our 2018 because it took a long time to form government and get approvals for our programs. So that is speculation. I can't say that with a certainty. And of course, there is also fatigue, possibly. And then there's the matter of sometimes dogs die of other things like canine distemper, actually mostly canine distemper. Then people say, the last time you vaccinated our dogs, they died. So we can't bring our dog. We had such points. The other matter of 70% is in terms of Makueni, I started by saying we were doing the pilot for the national program. So it was our desire to do 70%. Unfortunately, we were not able to do 70% across the county. We did in some sub-counties, in others we were not able to do. But the bottom line is we conducted a pilot, and there are lessons which have been learned and which can be used to upscale into, as we move to the national. I've also made a lecture. Sorry, I think I would like to stop there.
Now, I've got only two questions two people that I'll allow, that gentleman and the question that was written and brought here. And then we go for coffee. The rest we can discuss as we have our coffee. Time is not on our side. So gentlemen, please.
Thank you, Chair. My name is Dr. Soka, formerly a mayor of Malindi, and currently the State Department of Livestock. First of all, a harsh reminder, please, let us wear our masks correctly. If we can't, please leave the hall. Thank you very much. There's been a lot of rabies this morning. Thank you, Dr. Mwangangi. I think what I wanted to know is, I think this was Harriet. In the course of your interaction and interviews with healthcare workers, there are very many cadres. Did you check on their CMEs? Because the health facilities normally hold the CMEs every week. CMEs are continuous medical education sessions. And I thought if you had raised that, it could have flagged it to the management of these units to have this rabies issue status flagged out. Because if the healthcare workers get this wrong, if they get it wrong, it will not be very comfortable for all of us. Okay, that was the CMEs. Did you check on the CMEs? Lastly, I'm happy that the matter of the SMS reminders has come up. I think that's the way to go. Most of us will remember, even under COVAX, we needed a reminder, even at our level, to go for your second dose. Thank you very much, Chair.
Thank you very much for that question and for your comments. On the CME, I'm responding on behalf of Harriet. And yes, we checked if the healthcare workers were getting CMEs on rabies, and they were not getting that. Remember, rabies is not one of their priority diseases. So people tend to think rabies is a disease of the dogs. So it is more on livestock and more on the vets. So what we did is to introduce CMEs. So we are currently doing that more often, and they are getting the training. Thank you.
Okay. Professor Dumbi has received 3 questions. He will read and answer them.
So from my friend, Dr. Kibore, there are 3 questions. One, on policy level, Should government increase PEP in health facilities, or should government focus on elimination of rabies in pathogen host, which is the dogs? I think the answer is it should do both. As long as we have got rabies endemic within the dog population, there will be people that die because of lack of access to PEP. We should invest in both. The Global Alliance for Vaccine Initiative has declared that it's going to support PEP in humans, but also have put a rider that has to be accompanied by mass dog vaccinations. So remember, the goal is to stop any death from dog-mediated rabies. So when the rabies is there, we provide PEP, but also make sure that we can vaccinate and eliminate the disease in dogs. Second question is, in your opinion, who should be given more priority in risk allowance? A health worker handling a suspected normal human being bitten by the dog, or a veterinary practitioner handling rabid dogs in the field to prevent the disease from crossing over to humans? I think the answer is clear there, right? The person at greatest risk is a veterinarian or someone working with animals. I don't know about risk allowance, but I know from the strategy, we recommend that they get at least pre-exposure prophylaxis. And as Samantha was saying, that's something that needs to be known even within the medical fraternity. On risk allowance, I'm afraid I'm unable to answer that question. I would possibly put it over to the DVS.
I think the DVS can answer that during coffee. Or the DVS, you want to answer it now? I'm sure you have to check. You have to check with the treasury. Well, that's a very difficult, loaded question. I think it's been exciting, and I really wish to thank you for the good participation. I was told that we must go for tea. I'm sorry, but I would really love, is it really burning you? Okay, spit it out. And don't lecture, just ask the question.
Thank you very much for the opportunity, and my apologies for keeping you waiting. It's quite critical to me and as to my organization. I'm Patrick Mwende. I work as a research manager at World Animal Protection. I love the presentation by Dr. Kise and partly by Dr. Chuchu on coverage of mass dog vaccination in Makueni County. And when the presentation just ended, I started receiving so many text messages from colleagues asking me why World Animal Protection is not part of that. It's not mentioned anywhere. And as you know, World Animal Protection has funded rabies vaccination in Makueni County. We have participated in vaccination campaigns there. We have helped in media coverage, as well as producing educational materials like the ones which you see here, and distribute them to Makueni. And in fact, we have conducted educational training for students in primary schools and all that. So I'm asking that because we believe it's unethical when you look at it from scientific point of view. And Dr. Kise was the coordinator of that project, and he really knows that. So I'm interested to know why World Animal Protection was missing that presentation. Then to addition, thank you for the volunteer-based approach which you mentioned. But as well, you misquoting vet interns and vet students and young vets who contribute a lot to that volunteer-based activity. But of course, I know it's there in your paper, but I think it's wise to have them mentioned, because if we are looking forward to work together as a team, we have to acknowledge those who participate in some of these activities. Then the last one to Maurice, maybe we have time. Rabies vaccination is quite an expensive one. Are you going to try to see the data that Vision has on volunteer-based activity in Makueni, to see if that is what you should advocate for, because you rightly put it that money is scarce and you don't have future. Is it one of your chapter in your PhD thesis? Thank you very much for your time. Thank you, Chairman.
Okay, those are very good questions, and I think we can answer them during coffee. And I really want to thank you very much for all this. Many people, I don't.
Karibu kwa kipindi cha Mifugo ni Mali, kipindi kinachowafunza wafugaji mbinu bora za ufugaji na kuwakinga mfugo wako kutokana na magonjwa mbalimbali. Ugonjwa wa miguu na midomo ni mojawapo ya magonjwa ya mifugo ambayo ni rahisi sana kuambukizana.
Huu ugonjwa wa miguu na mdomo usambazwa kupitia kwa wale ng'ombe ambao wameshikwa wakitangamana na wale ambao hawajashikwa, na pia na zingine vifaa ambazo madaktari wanatumianga.
Ugonjwa wa miguu na midomo husababishwa na virusi ambavyo huathiri ng'ombe, kondoo, mbuzi na nguruwe.
Dalili ambazo zinaonekana kwa ng'ombe ambaye amekocheka ni joto mwilini, kudondoka kwa mate, na pia kulegalega kwa miguu, na pia kusaka meno, na pia unaweza kuona matiti na mdomo kuwa na vidonda nyingi. Jambo la kwanza ya kwamba ugonjwa haina tiba, na jambo la kufanya kuzuia ni ya kwamba tunatumia chanjo kila miezi 6, na pia kutenganisha wale wameshikwa na ugonjwa na wale bado, alafu pia kuripoti mlipuko wa ugonjwa huo wakati wowote ukitokea kwa ofisi ya Veterinary ile iko karibu, ili tuzuie kusambaza ugonjwa.
Kwa maelezo zaidi, wasiliana na daktari wa mifugo aliye karibu nawe.
Karibu kwa kipindi cha Mifugo ni Mali, kipindi kinachowafunza wafugaji mbinu bora za kulisha na kutunza mifugo.
Umuhimu wa lishe bora katika ng'ombe wa maziwa ni kwamba utaweza kupata maziwa mengi ambayo utaweza kuuza na upate faida ama fedha ya kujimudu nyumbani. Pia utaweza kuuza wale ng'ombe wenye watakuwa wakizaliwa kila mwaka, utauza upate fedha pia nyumbani. Dalili ambayo inaonyesha ng'ombe wana afya mzuri ni kwamba kukua kwao itakuwa ni haraka, ngozi yao ni laini na nyororo, maziwa ambayo yanakamuliwa ni mengi, na pia ng'ombe ambayo anafutia macho.
Ili kuhakikisha afya bora ya mifugo, hakikisha kuwa mifugo wana majani ya kutosha na pia wanapewa madini kulingana na uzito na umri wao. Hakikisha mifugo wanapewa maji safi na ya kutosha. Wapatie dawa za minyoo mara kwa mara. Kwa maelezo zaidi, wasiliana na daktari wa mifugo aliye karibu nawe.
Is that we make a difference. Our desire is that the livestock farmer will reap benefits that they have not reaped before in applying better feeding methods for their cows, better marketing for their products, and that way we are all winners. The bank wins for their investors, the county government wins in a community that has been empowered.
Sisi serikali na wafadhili wengi wangependa sana kufanya kazi na wakulima, lakini kwa sababu kila mtu anafanya kazi kivyake inakuwa vigumu. Kwa hivyo tunawaomba jiunge kwenye cooperative. Kwa kwenye hizi cooperative tunawaomba sana sana mtu angalie kushoto kulia nani yuko kwenye cooperative.
The KCB Foundation now has a great opportunity to collaborate for a good cause which will benefit the economy of the communities in Narok. From Narok, we can feed Nairobi, Nakuru, and Naivasha. KCB Foundation is going to make an initial investment of 30 million shillings, which will create for farmers and break the circle of dependency and poverty among the people of Narok County.
Katika hii partnership between the county government na KCB Foundation, I believe we are going to the next level kama farmers wa Narok County.
Tunafurahi sana kupata development partners kama Kenya Commercial Bank ambaye siku ya leo tutasign MOU ya kuendeleza hiyo agenda ambaye iko kabisa katika County Integrated Development Plan, kuona ya kwamba tunaenda kudeliver kwa hiyo agenda ambayo iko katika CIDP yetu. We are partners, we are friends, na wakati mumekuja kwa agenda kama siku ya leo kuendeleza hiyo partnership, on behalf of our county yetu ya Narok na partners, we want to say we are very happy, we are very excited.
And we try to make sure the vaccine is a live vaccine, it can cause the disease. So we treat with long-acting antibiotic, that is 30%, it can stay for a whole week. Good, so that's done. Okay. So this is now showing the vaccine is there. And this thing that the ear tag does not come out. This one. Okay. This one.
This one?
So go ahead and press. Yeah.
There are over 3.4 million working donkeys in East Africa, working endlessly in some of the harshest of conditions. At times, these animals are overworked or suffer with years of medical neglect and end up dead. However, their labor plays an important role in the lives of the most vulnerable communities, depending almost entirely on them for livelihoods. In most instances, the income from a single equine can support a whole family. Youth in urban centers depend on donkeys to earn their daily income, where donkeys are a means to an end. In the arid and semi-arid areas, women use donkeys to support their households with domestic chores like fetching water and firewood. In high productivity areas, men and women use donkeys to ferry their farm produce to their homes and to markets. Since 2012, Brook East Africa has been supporting donkey welfare improvement programs in Kenya, Tanzania, Somaliland, and South Sudan. Brook East Africa, through its partners, provides treatment for the working equines and works with local communities, women, and youth groups. We also offer help to working equines in need through our partners, vets who are always on the move, hopping from county to county, sometimes attending to animals in far-flung areas of East Africa. We are also involved in advocacy activities, lobbying government and security agencies to put in place policies that lead to improved animal welfare in the region. Brook East Africa continues to seek partners to strengthen its resource base and reach more people in East Africa. With your support and partnership, we will be able to continue our donkey welfare improvement programs, reaching more vulnerable working equines in more areas throughout East Africa. Beyond that, we endeavor to keep up the critical role of collecting information and data, working towards our target of directly reaching over 400,000 working equines in East Africa by 2021, thereby positively impacting more than 2.4 million people. To support Brook East Africa, visit our website, send us an email, or give us a call.
What makes a dog smile? Is it being called good boy 1,000 times? Or it's a bowl full of canine dog food? Because every serving of canine dog food is a bowl full of cheer. Canine dog food for happy, healthy dogs. We are the heartbeat of technology, with our finger on the pulse of healthcare that has significantly impacted our region.
Cosmos was started by my father, Prakash Patel, who is also a pharmacist. And then he decided early in the 70s and 80s that he had a desire to make Kenya self-sufficient in medicines. At that time, Kenya was importing a lot of medicines, yeah? So in 84, we started manufacturing at the present premises, yeah? That's when I came back from England. My background is also a pharmacist. My father decided that we needed to attack 3 pandemic diseases of Kenya that was faced. Yeah? So first and foremost was malaria, second was TB, and later on came HIV. And at the same time, look at essential medicines, because he said this is what Africa is going to need, this is what Kenya is going to need, and we need to do something for the people.
Cosmos has always been a company focused on quality. It's the foundation stone of this company. And I think, 30 years, 40 years on from when the company started, we've achieved that.
Cosmos operates a literal world-class facility with a total built-up area above 300,000 square feet, 5 manufacturing blocks, warehouse with over 180 API and 6,000 SKUs, on-site finished goods marketing and administration offices, staff canteen, and 24-hour operation. Our production capacity is quite wide, with over 1 billion tablets manufactured annually and 20 million packs of medicine sold annually. In addition to being recognized by the Pharmaceutical Society of Kenya and the Pharmacy and Poisons Board, Cosmos also has USAID, WHO, GMP, and European Pharmaceutical Inspection Corporation Scheme (PICS). Our current therapeutic areas of manufacturing specialization include diabetes, hypertension, antibiotics, anti-inflammatory, HIV, TB, cough and cold, anti-diarrhea, and others, as well as veterinary products. These medications have impacted the lives of millions. As a snapshot of that impact, more than 300,000 patients are currently on Cosmos diabetes and cardiovascular medicines countrywide.
Hello, participants of the 55th Annual Kenya Veterinary Association Scientific Conference and 15th World Rabies Day celebration. I would like to say welcome from Action for the Protection of Animals Africa to this event. APA is an animal welfare organization whose vision is an Africa where animal welfare is core to society. And the main mission of this organization is to ensure that animal welfare is integral in livestock, companion animal, and wildlife, so as to improve the lives of our animals and the interactions with our humans and environment.
And we at Action for Protection of Animals Africa want to see animal welfare becoming the core in the way we work, the way we grow our animals, the way we interact with them. And it's because of this we will be working in 3 project areas. The first is in disaster management, where we will want to see animals protected during disasters and having their resilience build after the disasters, so they can be part of who we are, our core.
When disasters happen, it's not only the humans who get displaced, but also the animals, whether livestock, companion, or wildlife. It is a known fact that when disasters happen, that the livestock that people run away is their initial source of food and their initial source of income while they are trying to stabilize themselves and disaster aid comes in. Therefore, it is very important to maintain rescue of animals in disaster and in wildlife areas, as this is a source of income for a country.
Rabies, Rift Valley fever, malignant catarrhal fever. What do all these have in common? These are diseases that affect our wildlife, livestock, and even us. We at Action for Protection of Animals Africa are working with national and county governments to develop plans that will see all our animals better protected, carrying out vaccination programs, and even teaching farmers and livestock owners how to better protect their own livestock.
The second area we'll be working with is animals in communities, and this area will be mostly centralizing in the area of dog population management and rabies elimination. As you know, globally there's a goal to eliminate transition of rabies to humans from dogs by 2030, and after that eliminating it in dogs in the rest of Africa and Asia. This is very important because dog population management and rabies affect various areas in our society. Depending on the number of dogs, you can either have a sustainable, healthy city, or you can have a city full of strays. In farm areas, dogs can also spread rabies to livestock, causing losses at the household level, and especially if they bite and the owner of the household dies and he's an income earner. Dogs also, unfortunately, in wildlife area carry diseases like rabies and distemper, which when they enter wildlife zones can kill and have wiped out whole packs of large cats and wild dogs. Therefore, it is very important to maintain dog population management and rabies elimination. As in disasters in management, we shall also be working in the areas of community, academia, technical persons, and at government level.
And redefining how we also live with wildlife, redefining how we manage our environment so that it is optimal for our livestock and our wildlife, and ultimately for ourselves. We are also going to work in the area of companion animals, wanting to see dog population management, rabies management, and other diseases controlled within companion animals, and the companion animals are treated well and become part and parcel of our families and our livelihoods.
In regards to wildlife, which is our third category, we'll be working in a specialized area or areas. The first one being disaster risk mitigation and management. The other one will be working where there is a confluence of human, animal, and livestock. And this is intervention in areas of human-wildlife conflict and zoonotic disease mitigation across these borders so that we can have sustainability in areas where humans and wildlife live together to ensure productivity and livelihoods in the livestock sector and in the wildlife area.
We in APA come with a combined experience of 25 years working in Africa, Asia, and even in Latin America, where we have the experience and the expertise to help communities, farmers, animal owners, institutions, governments to put in place policies, programs, trainings to see these things come to fusion. So join us as we protect animals in Africa.
And I can see that most of our colleagues here, we have interacted. Some are ongoing PhD master students and researchers that we collaborate. So welcome for the meeting, for this session. And I'll call upon the first presenter, that is Jared Serem. Welcome.
Good afternoon, everyone. Good afternoon. Okay, I thought we've just taken some tea and some nice snacks. Good afternoon. Good. At least that's better. So, my name is Jared Serem, and I work for Diamond V. So, Diamond V is a global animal health company that produces nutritional health products. It's American-based, and I offer tech support to mainly poultry and swine. That is in India, Middle East, and Africa. So that's my area that I cover. So this is going to be something slightly different from what we've had from morning. So I know we've been talking about rabies. So this session, I know it's all about food security, and we know that we are key drivers of food security as well as the health of the animals. So as I was sitting there, just a quick thought crossed my mind, and I want to pose a question to you. Do chicken and pigs get rabies? Yeah, it's to us. Do they get rabies? Yes, no, yes, no. So we are not sure. So I went and checked quickly. Yeah, they have a potential of actually getting it, but it's almost, I think we have recorded almost 0 cases. So it's something very difficult. So this morning, I'm going to talk about optimizing gut health and immunity. And I would request that maybe if you can move the video up slightly on the screen to the top corner. Yes, to the corner, please, so that you're able to see the slides. Yeah, thank you. So optimizing gut health and immunity for performance in poultry. And I'll be talking about the role of postbiotics. I know this is a fairly new terms. I know we've heard of the probiotics, we've heard of the prebiotics, we know of the antibiotics, of course. But today I'm going to introduce to you a fairly new term, and we are calling it postbiotics. So please, next slide, please. So in my presentation, this is the outline. So I'm going to introduce to you gut health and immunology, and then we'll also talk about the role of postbiotics on gut health and immunity, and of course on the performance of chicken and pigs, and then we're going to do a summary. And we as vets and in animal production, those two keywords, so gut health and immunity, play a very significant role in terms of feed efficiency or maintaining the health of the animals and being able to produce optimally. So another quick question, what is gut health? I know we've heard of gut health over and over again. So gut health is a fairly big term in the industry. Everyone is talking about it. When we talk about reduction in antimicrobial use, we talk about gut health. However, we lack a real meaning or a keyword to describe gut health. So someone tried to define it by giving it an index. And when we talk about gut health, we are talking basically about the gut microbiota, the beneficial bacteria versus the pathogenic bacteria, the balance between those. We are also talking about the gut integrity, and we are also talking about the gut, the immunity within the gut. And when we talk about the immunity within the gut, we are talking about some of the immunoglobulins, such as the immunoglobulin A. We have also the macrophages and all those. And then there are other elements also, and I've seen Dr. Yamo is around, welfare and the feed. So these are likely to affect the balance of the microbiota as well as the gut integrity. Therefore, being able to influence how healthy a gut is. So let's move next, please. So that is basically about gut health. And then about immunity. So I'm going to just describe to us briefly about immunology. And I'm going to begin with the innate. So we have two types of immune system or classification. So we have both the innate and the adaptive, right? So from the innate immune system, it's usually the first line of defense. From a time of injury or from the time when a pathogen enters the body, what happens is the first line of defense kicks in. The skin, the cells that are around the skin, the mucus, all these will protect us from these potential pathogens. So it comes in within a short time, it triggers inflammation. We all know of inflammation. And the main aim of inflammation is just to trigger the movement of cells from the different parts of the body towards that site where we have a potential threat. So basically, We also have other cells, activation of natural killer cells, antioxidants, and complement protein that's going to eliminate pathogens within this first line. So the aim of a vet, or the aim of anyone, should be always to maintain the pathogen within this limit. However, next slide. If the pathogen is not eliminated at that stage, then the adaptive immunity comes in. And what does it do? So it comes in within, let's say, 12 hours or after. So it comprises of the cells. We have the complement proteins, and then also we have the non-specialized lymphocytes. And also we have cytokines and secretory immunoglobulins A that play a key role in maintaining the adaptive immunity. So this is the immune system that you're targeting when you are doing or giving the rabies or whichever kind of viral vaccine. So you want to elicit a response as soon as possible and being able to maintain that for a longer duration of time. Thank you. Let's go to the next slide. So I hope we can still be able to remember energy partition from our second year classes. So the energy from the food that we eat, from the time it enters into the mouth, this energy is going to be partitioned and split into different functions. So if you can look at the two vertical boxes, so the gray part represents the energy that is required to maintain the basal metabolic rate, and then the middle one is supposed, it represents the immunity, and then the upper one, or the green one, represents energy that's going to be available for food, growth, and activity. So when an immune system is not efficient, it resembles to the one on the left. So you have most of the energy going into maintaining of immune system. How about when it is efficient? Most of the energy is going to be released for the animal to produce and perform. And that is why we are bringing in the aspect of importance of immune system. So the immune system should be activated when there is a threat in the body, and then soon after, it should go back to the resting state as soon as the threat is eliminated. Next, please. So the biotics family. So in animal nutrition, we've heard about the probiotics, the prebiotics, but today I want to introduce also something about postbiotics. So for the prebiotics, so this is just trying to modify and enhance the gut health and also try to enhance the immunity so that whenever we keep our animals, the immune system is efficient and being able to conserve the energy for us to be able to produce well. So the prebiotics, these are fuel, and these include the non-digestible or the long-chain carbohydrates. When they get into the gut, they combine with the probiotics, the live organisms, and then they synthesize what we call the postbiotics. And this is through a fermentation process. Next. So what we have, Diamond V is a leader in fermentation technology. And this is what the company has been doing for the last over 78 years. So what we have in this case is a postbiotic, is a fermentation-based technology. And I would like to show us just a few examples on gut health. So gut health, one of the measures, we talked about the gut integrity. We also know about, we mentioned about the villi in the gut. So the longer the villi, we know the healthier the gut. So with this, when we give antibiotic growth promoters to our animals, what we intend to do is also to enhance this so that they are able to utilize the nutrients efficiently. So as we can be able to see, this was on a swine model, and we can see that our technology is natural, non-antibiotic, but it's able to produce a response, and you have higher villi, therefore more efficiency. Next. So the other important element also on gut health is gut permeability. So whenever we are stressed, what happens is, we know there are tight junctions, and whatever is in the lumen of the gut is not supposed to cross into blood, including enzymes and pathogens. But what happens when we are stressed. Because these tight junctions are held together by protein-like molecules, usually they get oxidized. And what happens next? Just to demonstrate, click next, please. Previously, please. Previous slide, previous. Okay, next. Yeah, unfortunately it can't play. So the substances that are on the lumen will cross, these will usually relax and then they'll just cross into blood. And that is not, that is undesirable. Next. So this is the same technology for humans. And this is a rodent model. And what was done is rodents were, one group was injected with the product and then the other group did not have. So what happened is after some time, they were exposed to heat stress. And what we see from this, blood was drawn and then serum lipopolysaccharides were detected or checked in the blood. And what we are able to see is with the control ones, there is a high level of lipopolysaccharide within the serum, meaning because this is a product from the death of the pathogens or the gram-negative bacteria. So it is found, more of it is found in the blood as opposed to those that were not stressed. Therefore, it means there was kind of a protection. Next. So this is on beneficial bacteria. We have both the beneficial and the negative bacteria. So beneficial in the bacteria in the gut, we have the bifidobacterium, we have the lactobacillus. These are the good bacteria. So when that was checked, also with our technology, you can be able to see, or with a postbiotic, you see that we have more beneficial bacteria on the red bar, but the negative ones, we see there is a reduction on that. And then on the AGPs, antibiotics, of course, will eliminate all of them, which is not the same case with the postbiotics that selects for the beneficial bacteria. Next. And then this is on immune system, overall immune system. And I hope we can be able to remember how inflammation occurs. Interleukins, can we be able to remember that? That's how the cells are able to communicate with each other and trigger inflammation. So under normal circumstances, if you don't give an antibiotic or if you don't give something that will help the animal, so what happens usually is you have increased levels, rapid increase both at the local level where the injury is happening and general. So what we are able to see when you give an antibiotic or postbiotic, what happens is the curve of the interleukins is reduced because we don't want an overreaction. Yeah, because when you have a new overreaction, then you end up with the problem. Next. And then when we vaccinate, what we see is you have faster response. This is a Newcastle disease virus. So you have faster response that lasts for a longer duration of time with the vaccine. So it's able to at least help the animal being able to respond well to the vaccine. Next. So in terms of efficiency, we see better feed efficiency and better body weights because of those benefits that I've highlighted. Next. So in summary, what we usually say is our technology or the postbiotics are highly stable and are able to produce more consistent results because what they do is they support the immune strength and digestive health. Therefore, you will have less energy to be used or that can be wasted, and therefore you have more benefits that will come out as both in money terms. So you have better efficiency, therefore less cost of production. And I feel that this is the area that we as vets should be also focusing on, because the problems always are not just for treating, but trying to manage some of the conditions that we have at the farms. Thank you very much.
Okay, thank you very much, Serem. Let's appreciate him better. He has kept time. And for questions and comments, please reserve them until the other presenters have presented, then we'll deal with that together. So can I call upon the next presenter on antimicrobial resistance? Dishon Moroi.
Yes, thanks, Professor, for the introduction. Right, so now I'm off from rabies to AMR. This is what I do, that's what I earn my living on. I'll explain to you a quick overview of basically the epidemiology of AMR in Nairobi, so to say. And I'm sure most of you know what AMR is, isn't it? It's a new buzzword. Everybody talks about AMR in bacteria, in livestock, in humans. But then what you want to know is that how is the connection of these pathogens in an urban setting, whereby people live with livestock together. Like I said, I come from Malindi. Right. So all of us know about AMR, isn't it? It's a problem. It's going to kill all of us if we don't do anything. Okay, rabies will, but AMR will as well. So AMR is a growing public health issue. There's lots of knowledge about it, but then importantly, it's how it comes into being and how it moves between populations and within populations. There's lack of data on that as far as I know. And then Nairobi, as all of you know, is the capital of Nairobi, whereby we have rapid urbanization, lots of people living together with livestock, with wildlife, and also environment, which is sharing between the two populations. And that environment is being exposed to manure and also human sewage, okay? And all of you know about One Health, right? Human, livestock, and environment. Therefore, AMR is a quintessential One Health issue whereby it affects all of us, right? In this population in Nairobi, like in other cities, the drivers of antibiotic use are high disease prevalence. There's lots of disease prevalence ranging from malaria all the way to HIV and STDs and others. There's increased antibiotic use with increased incomes. Most of us here, we probably have a Thanks. Oh gosh. So most of us here have probably a medical insurance card, isn't it? When you go to any hospital, I won't say the name, they'll give you a stash of antibiotics. Why? Because you can afford them. And then lastly, ease of antibiotic purchase. If you work in 20 pharmacy here in Malindi, you can access any antibiotic you want and you wish, as long as you can afford it. And then lastly is that in these settings, like Nairobi, we have urban agriculture, people keeping pigs, people keeping cows and keeping other animals. And these interfaces, you know, sort of these livestock keeping practices, they form what you call biological interfaces. So interfaces are a point whereby there's mingling of populations together. And that along these interfaces, you can easily share pathogens within and between populations, okay? So the perfect organism to use for these interfaces is E. coli. So E. coli is the best organism to study movement of pathogens across interfaces simply because E. coli is found in everyone. If I sample all of you here, I can assure you have E. coli. It's definitely not me. If you sample any cow, you'll definitely find E. coli. The environment will find E. coli. Therefore, this is the quintessential pathogen to look at transmission of pathogens across populations. Next slide, please. So again, we used E. coli in this study to understand that. So the objective of our work was to investigate the carriage and epidemiology of AMR across within and between populations, that is animal and human populations. And we had two hypotheses. Our hypothesis was that, first of all, these genes and these bacteria, they are distributed across the population in a cosmopolitan way. And then secondly, the livestock keeping increases risk of human carriage of genes. That is, people keep livestock have more genes than those who don't, okay? Next slide. And you can see, sorry, before you go back please. So I'll mention about the household. So in this household, as you can see here, this is a household of humans, chickens, and other animals and wildlife. This is the perfect place to study how these pathogens sort of move. Next slide. Kindly move the video down, please. Excuse me. Yes, thank you. Further down at the corner, yes. Right. So our study design was a clustered hierarchical sampling design, whereby this Nairobi, as you can see there, all the locations, sub-locations. So in Nairobi, we divided into wealth categories based on how much you have. Green, Karen, red, Kibera. Then think of the continuum, right? And then we sampled 33 sub-locations from those 7 categories, wealth categories. And then in each sub-location, we chose 3 households. Please remember that. So one household, which is the first one here, we have large livestock. So humans and large livestock, so cattle and pigs. The second household, we have humans and small livestock. So humans, chickens and rabbits, or guinea pigs. And in the last household, which is a control group, there is no livestock. Okay, so this is a clustered hierarchical sampling design. And then we collected fecal material from humans, the livestock, collected food, environment, manure, and we also sampled domestic wildlife. So things like bats, wild birds, rodents, few primates from Karen, and 1 mongoose from Laurentian. Next slide, please. Right, so now this is our, again, I just mentioned our sampling design. So we sampled from livestock, humans, and wildlife, environment, and the rest. And then so the first circle there, these are the populations. In the household, we also collected a questionnaire on things like antibiotic use, farming practices, and other metadata. Then the basic microbiology of this in the lab, getting the bacteria. So we isolated only E. coli, okay? Then we did ASTs for sensitivity of resistance. And then we did whole genome sequencing, which is where basically you look at the entire repertoire of genes, genes within a particular organism. So we sequenced up to 2,500 genomes of E. coli from this population. And then now everything was fused together into phylogenetics, which I just mentioned briefly. Next slide, please. Right, so this is a distribution of our sources. So we are the majority were livestock. Please move the video down kindly. Right, so the majority were chickens, you can see there. So no chickens, sorry. The majority were livestock, closely followed by wildlife, and also humans. And again, we sampled all kinds of animals in Nairobi. All animals, we sampled them, right from cattle all the way to guinea pigs. In terms of wildlife, we sampled wild birds, 14 species of them, rodents, primates, carnivores, and others. So basically, it's the entire One Health spectrum. We also have samples from food and environment, but I won't talk about this today. Next slide, please. So the first thing was to look at the AMR gene. So I said that we sequenced the isolates. We investigating the genomic footprint. The first thing was to look at the number of AMR genes. So again, just to remind you of how AMR happens, that you can have 2 ways of AMR development. One is what you call mutations, okay? The bacteria mutates to become resistant. And the second way, it acquires genes independent of mutation, okay? So these are the genes which these pathogens acquire, either from other pathogens or from the environment. And the first finding was that we found 56 AMR genes and 13 point mutations. So basically 56 movable genes, so to say, and 13 mutations. These are just things happening in the genetic makeup of the organism. And these genes and mutations were conferring AMR to 9 different classes of antibiotics. And again, remember, these are healthy animals and healthy humans, not clinical. As you can see in that graph there, those are basically all the genes we found and the distributions by host. Second thing, the most common genes were genes to SAL2, STRA, B, TET-A, and BLATM1B. These are genes conferring AMR to sulfonamides. As you can see, the peaks there, sulfonamide, aminoglycosides, tetracycline, and beta-lactam. Is it surprising? No. Why? Because these are the commonly used antibiotics in both humans and livestock, but wildlife. Who gives rodents antibiotics? Does anyone do that? Who are the Cascava folks? Do you? No, we don't, right? So these wildlife populations, you can see the color there. Which color is that? The golden color. They have lots of genes as well. The question is, where do you get them from? The answer is One Health. So then second last is that a good number of isolates add what you call ESBLs. So when you go to Aga Khan, or any other hospital for that matter, they're about to go and see your forefathers due to an infection. There's a class of antibiotics they'll give you. One answer now the normal ones, things like augmentin, they proceed to ESBLs. When you're about to go to see your forefathers, they'll give you carbapenems and colistin. So ESBLs are on that list, are the ones which are critically important antibiotics. So any AMR you find in healthy humans is very, very intriguing. And then lastly is that we found more genes in humans than other populations. Next slide, please. Next slide. So in terms of MDR, so MDR is multi-drug resistance, whereby you have AMR against three classes. As you can see in the first plot there, which is the human, livestock, and wildlife, MDR was common in either population. Please move the video a bit. Yes, so MDR was common in all populations, more in humans and less so in wildlife. But again, it was there, which is very, very worrying for again, healthy humans, healthy livestock, and wildlife not being given antibiotics. And again, the second box plot there, it shows you the number of genes someone was carrying. So we have a guy there. There's a goat from Umoja Estate, which had 18 AMR genes. Can you think of that? And healthy goats in the population having 18 AMR genes. There was one bird from Kasarani, which had all kinds of genes. Think of what it means too. If this is the picture in the community, think of the clinic. Next slide. Next slide, please. Yes, so the next thing was to look at what we call community assemblages. So I think as an ecologist, ecologists are interested in looking at communities. Masai Mara is a community, isn't it? We have lions, all kinds of animals in Masai Mara. So what you want to see is whether those communities live together in a perfect way. Okay? So what we did was looking at community assemblages of our AMR population, asking the question, are the genes in livestock the same as those in humans? Similarity, right? So we developed a similarity index using Bray-Curtis matrices, and then we did ordination techniques. And basically, don't worry about the workability of this. The key thing is that these star-like ellipses don't separate. Therefore, it says that humans, livestock, and wildlife have similar kinds of genes, not the same. They have similar kinds of genes, basically saying that the genes in livestock are the same genes in humans and also in wildlife. But then, next slide. But then you'd imagine that if you have similar genes, you also have similar bacteria, isn't it? It makes sense, right? If you have similar genes, you also have similar bacteria. That the E. coli in livestock and the E. coli in humans and the E. coli in wildlife is the same. But to our surprise, it wasn't. We only found 9 cases of identical genetically isolates. I can't show you because I don't have a pointer. But these are phylogeny of all our isolates. And basically, there's somewhere there where we only found 9 cases of similarity of the bacteria. But then we've seen a similar AMR gene, but different bacteria. So what could be happening? So we think it's not the bacteria. There's a vehicle. There's a vehicle carrying these genes between the populations, devoid of the actual bacteria. And those are what we call plasmids. So now bacteria is very interesting. Unlike viruses, it carries things from the population in a random manner. So we think plasmids are responsible for moving these AMR genes across populations without moving the actual bacteria. Next slide. So then to look at the co-occurrence of these genes or correlation of those genes, this is a cluster of genes there. So those are 3 genes, STR-A, STR-B, and STR and SAL2. So those genes were found in the same isolate all the time, X number of isolates. And if you do additive representation, you can see the number of isolates having a high number of genes always found together was also increasing as well. So we think there's something happening here. There's something happening here. That is the plasmids moving these genes between populations without actually moving the bacteria. To do that, you must do something else. So we are also doing what we call nanopore sequencing, which is able to give you more information about that. But just remember, the key thing is that the bacteria is okay, but there are things moving those things, moving their margins. Next slide, please. So the last hypothesis we had was that does livestock keeping influence air margins in humans? So this question is the holy grail of AMR in the One Health context. Does livestock expose humans to AMR? Some will say yes, others will say, I'll say no, others will say yes. So this is an example of a farm in Kibera. Someone with pigs living together with the pigs in a very dirty place. Is this person exposed to AMR more than someone in Karen? Next slide, please. Last slide. Yes, so the answer is no. Regardless of whether you have livestock or not, you don't have more genes or different kind of genes from your counterpart. Therefore, the answer is that livestock keeping has no effect on the human carriage of AMR genes. Next slide, quickly. But then there are two things which I found was significant. The first one was manure. If you have manure in your household, you are more likely to have more genes compared to those who don't have manure in their household. Next slide. If you are more in your household, again, human density influenced AMR carriage. The more you are in your household, the more genes you have. So in conclusion, next slide. First thing is that we found lots of AMR in Nairobi, more in livestock, in humans than in livestock, both abundance and diversity. Next slide. That is, we found similarities of AMR genes in both populations without the actual genomes. Therefore, it means that there's probably due to similarity in antibiotic use or plasmids moving those particular genes across populations. And then my last slide, I promise. I'm a pastor now. Last slide. Therefore, livestock keeping has no role, or let me say has minimal role, if any, on the human AMR carriage, but manure management and human density does influence human carriage. Therefore, thank you so much to everyone. Next, last slide. Thank you so much to all the partners. It was a huge project, 5-year funded project, $5 million, led by University of Liverpool, University of Edinburgh, where I did my PhD, Oxford, MRC, and other partners. Thank you.
Okay, let's appreciate Dr. Moroy for that. I think he has done very well. We know now why antimicrobial resistance is our One Health issue, and those who are in that area will pursue that. There are areas that can be pursued from what he has presented. So now, again, you reserve your questions, comments, until we have heard the other speakers. And the next speaker is Dr. Yamo. Are you with us? Yes, welcome, Dr. Yamo. He's going to talk about broiler welfare. You have 15 minutes.
Good morning, or is it good afternoon? Where I come from, morning ends when I've eaten lunch, and I've not eaten lunch. So I'm going to try and match what Dishon was saying, because we borrowed some people from Dishon to do some of the research that we're doing. The presentation, please. Yeah, so I'm just going to rush through this so that we just see what's happening at the other end of the world, how animal welfare connects to some of the things Dishon was speaking to. Next slide. Next slide, please. Okay. Next slide. We'll talk about some of the slides, the things you might have seen before. That's our vision as World Animal Protection. Next. That's our mission, and I usually say the important thing about our mission is that the we there is not Mwinde, Momanyi, and myself who work for World Animal Protection, but all of us, because animal welfare is a responsibility for all of us as humans. Next, and that's where we are. We have the important one is the number 8 office, which is in Nairobi, that looks after animal welfare, our work across Africa. Next. And for those who don't know, we have a new strategic vision that has 2 goals. Goal 1 is about ensuring farmed animals live good lives by transforming the global food system. And in one of these days, we will have a discussion around which is this global food system. And then goal 2 is about stopping wild animals being cruelly exploited as commodities in changing the systems that they live in. And so we have become slowly a wildlife and farming organization. And that's why maybe Mwinda was talking about dogs, and we are no longer we are no longer doing the dogs work, which is then given out to a partner, that an organization that we put together. So down to animal welfare. Animal welfare is about how an animal is coping the physical and mental environment that it is living in. That's according to OIE, or not only living it, but ultimately dies. That's according to OIE. And an animal is said to be in good state of welfare if it is healthy, comfortable, well-nourished, safe, and able to express innate behavior and not suffering from pain, injury, and disease. And it is governed around 5 animal freedoms. Next slide, please. And the 5 animal welfare freedoms are about freedom from hunger and thirst, freedom from discomfort, freedom to express from pain, injury, and disease, and freedom to express normal behavior, and freedom from fear and distress. And all these things work around ensuring that the animal is holistically managed. If you look at things like hunger and thirst, whatever you feed the animal should be meeting its physiological status, and if it's not, then most likely what happens is that the animal ends up underperforming and going into situations where it has challenges. And essentially, we normally say whatever you feed the animal ultimately ends onto your table. And that's the gist of the supermarket meat testing. Next. So in 2018, as an organization, we had across the globe, we did something around supermarket meat testing, which was essentially going to, next slide, which was essentially going to collecting pork samples from shelves of supermarkets and then testing them for bacteria, and then trying to find out if the bacteria were antibiotic resistant to bacteria. And so what essentially we are saying, and I think the critical one, is the US pork, 14 out of 16 samples from a supermarket like Walmart was found to be positive from antibiotic resistant bacteria. Next slide. But more important is that 9 out of those 6 were what we call superbugs. And I think my good friend Dishon has elaborated what superbugs are. Any organism that is resistant to 3 or more antibiotics is what is considered superbug. So in 2018, that was done across Spain, Brazil, Thailand, United States, Australia, and not in Africa. Hence the reason why we are asking what happens in Africa. Next slide. So last year, in between April and May last year, we then decided to replicate the same tests. And this time around, we then collected chicken and pork samples from 6 of the top supermarkets in Kenya. I hope you know which the 6 are. Across those counties listed there, Uasin Gishu, Kisumu, Nyeri, Laikipia, Nairobi, and Nakuru. And samples were then sent to Center for Microbiology Research at Kenya Medical Research Institute. Remember, we are not a research organization, so we work with research institutes in partnerships. And so in this case, we used Kemri. Next slide, please. And essentially, the samples were collected using EpiCollect, so that we also collected additional data where the fridge is, the GPS codes, the packaging method, storage temperatures, use of PPEs by the supermarket person, etc. And then the bacterial identification was done using PCR and biochemical methods, and antibiotic accessibility tested using World Health Organization recommended antibiotics. Next slide. So in terms of what we then found, which is what I want to rush through, the first thing is that the total samples were about 393 samples. Poultry represented about 52% of the samples, and the pork samples were 47%. Next. And there you can see the distribution according to supermarkets. Secondly, then, in terms of the supermarkets, pork samples, Supermarket 1 had 76% of the pork samples, and in terms of poultry samples, supermarket 2 had 31%. These supermarkets are known, and after the presentation done in April, 2 of them actually came to have a discussion with us around some of these things. Next. In terms of packaging, 53% were from the fridge, which means they were not frozen. They were from the freezer, fridge or freezer. And then 45% were from the fresh meat section. Within the supermarket, you find a fresh meat section where we then collected 45% of the samples. Next. In terms of packaging, 57% of the samples collected were actually pre-packed by the supplier. And we'll show you which suppliers those were. And then about 34% were actually packed within the supermarket. When you go to the fresh butchery section, you select what you want and they package it for you. Next slide. In terms of distribution of samples according to producers, pork samples, 56-57% came from Farmer's Choice, obviously because they're the biggest supplier. I want you to note that the interesting thing is that about 42% of the samples in the pork area were actually collected from what the supermarket calls their own brand. They bring in pork as fresh cut or freshly slaughtered animals, and then they can cut. If you then interrogate them, they quickly tell you it comes from the big brands. But if you push them a bit further, then you discover that some of it comes from local arrangements that are not necessarily from the big brands. In terms of the chicken samples, 56% came from Kenchik, and Farmer's Choice at 5%, and QMP Quality Meat Packers at 14%. Next. Then in terms of bacterial isolates, we had 611 bacterial isolates, and as all of us know, meat is not sterile. It's definitely going to grow bacteria, and so the number of bacterial isolates was not something significant for us to talk about. Next. Then in terms of bacterial isolates, I think it's good I'm coming after Dishon. Dishon has already said E. coli would be found in almost everything. For us, I think the important thing is the fact that we were able to isolate Klebsiella, Salmonella, and Shigella from these samples, which shouldn't be there ideally, but somehow they were finding themselves into that. And next slide. And then again, as I said, bacterial isolates, E. coli was the most, followed by Klebsiella, Salmonella, Shigella, staph at certain levels, and very little. Actually, there were 2 samples, one from each for Pseudomonas. Next. I think the interesting thing for us is then when we start looking at the antibiotic resistance by the isolates. And you can see about 33% from both pig and pork samples were actually what we call superbugs, which were resistant to 3 or 4 or more antibiotics, both for poultry and pigs. And then the interesting thing again was the kind of antibiotics that they were resistant to, of course, of major amongst the samples. Tetracyclines was the one with 39%, followed by sulfamethasone, ampicillin, and at the bottom, towards the bottom, you can see certain antibiotics that are significantly important in human medicine. Resistance was also being recorded to. So in terms of summary, what we are saying is that significant bacterial contamination was seen in pork and chicken and meat samples across the various supermarkets. There were high level of contamination as high as 480 times 10 to the power 4 in some of the samples. And the biggest culprit was actually what is known as the own brand, what the supermarket is marketing as its own brand. And again, as we might be aware, some of those, majority of the contaminants were not necessarily pathogenic. It's just to show that there was some level of contamination that was happening. Next slide. I've already alluded to the fact that the presence of Salmonella and Shigella was worrying because those were not supposed to be there. It shows some contamination. And the resistant patterns and phenotype of cells are also worrying because some of them were resistant to high priority antibiotics according to World Health Organization, like those ones that I've named there. And the question then we need to address ourselves, where is it coming from? Is it because we have poor welfare? Is it because there are certain things that you're not doing right? Is it because there's misuse of antibiotics? And I know Ilri and the team has looked at quite some studies around misuse of antibiotics and how antibiotics are then prescribed and used by farmers. Next slide. Essentially, what you're saying from World Animal Protection is that as the global population continues to grow, there's going to be intensive farming systems that come into place. And at certain levels, then those farming systems tend to then misuse certain antibiotics because you're trying to mask poor welfare. Next slide. And that applies even, especially for small-scale farmers, because I find people asking what happens in small-scale farmers, and the people who've done studies around Kiambu will tell you that a lot of small-scale farmers are actually misusing antibiotics because their housing is not right, ventilation is not right, hygiene and sanitation is not at the right level, and all these things are connected to the 5 freedoms that we mentioned earlier on during the day. The fact is that the antibiotics are being used to prop poor welfare, and there is something that we've seen, and there are studies around that, and that is then generating, leading to antimicrobial resistance around superbugs. And I think Vision will help us at some of these things to find out whether there's any relationship and whether there's possibilities of the spread going beyond what he was looking at. In terms of antibiotic use, which is the next slide, antibiotics are being used for growth promotion. I know it has been banned across Europe and in Africa, but it's interesting that only 71% of our EU members have actually stopped using antibiotics for growth promotion. And we know what is happening to the 30%. And where is that 30%? Is it part of the African continent that is still using it at certain levels? I also want it to be known that as an organization, we are not saying we can't use antibiotics. We are just saying that antibiotics must be used, but they must be used when you as the veterinarian has been consulted, we have made a proper diagnosis, and we are treating a sick animals with the appropriate antibiotics. And then there's use of antibiotics for prophylaxis and metaphylaxis that I think most of us know. Next, it's interesting then to then look at certain things about antibiotic use. The world is using about 131 tons of antibiotics every year. And 75% of that antibiotics is actually going to farming animals. And that's part of the reason why maybe we're having battles with our colleagues in Pharmacy and Poisons Board, because that's a big chunk of business. Yeah, if you look at Africa, in 2010, the developing, those countries known as BRICS, I hope you know which ones they are, used about 63,000 tons of antibiotics in livestock production. And it's expected that it will grow by 67%. My son tells me that BRICS also needs to have a K. And so what you're seeing in Brazil, Russia, India, China, and South Africa is essentially the same, mirrors what you're seeing here. And that means that there's going to continue use of antibiotics in livestock that we then need to address as an organization or an association. We estimate that 40 to 80% of antibiotics being used in farming is unnecessary. Yeah, the farmer calls, and the first thing we do, most of us, is to send them an antibiotics over the phone, say use this or Iledawa or something like that. We need to relook at that and start managing this process quite well. Data is very scanty. We've been looking around, and the data from Bitema in 2001 on antibiotic use is something that is what is readily available. Maybe Prof will help us to find out what is the current situation, because it's been a challenge. And you can see it also mirrors, the antibiotics resistance also mirrors what we found in the study with Cambridge, because tetracycline and sulfonamide, according to Bitema, was one of the things that were heavily overused. 20% of antibiotics used in this country goes into poultry, 20% goes into pigs, and 20% goes into dairy. So the farming system already caters for about 60% of antibiotics being used. Next, in conclusion, what we are saying then is that we as players in this industry need to improve animal welfare so that we use antibiotics more responsibly. We're also saying that we need to start implementing some of the things that you're talking about. We have a very good laws that talk about over-counter drugs. VMD is talking about over-counter drugs, but somehow these drugs are being found in agrovets and ending up in food systems that we need to be looking at. And consumers are beginning to also look at high welfare production system, because that helps to give a healthier product at the end of the day. What we are saying is in line with the 2017 World Health Organization FAO or OIE Global Framework on Antibiotic Stewardship that recognizes increased animal welfare as a prerequisite for reduction of antimicrobial use. Next slide. And of course, I know those who have been around, you know what the Global Action Plan on Antimicrobial Resistance is all about. And next, let me say like addition, my last slide. The Kenyan situation, we have an action plan and policy around reduction of antimicrobial resistance. It's ending in 2022, the action plan, which is a year away, and we need to then ask ourselves, have we been able to implement it, and where are we in terms of that action plan? And as you can see, it was signed by the relevant cabinet secretaries at that point. Next, thank you. I hope I've taken my 15 minutes.
Thank you very much, Dr. Yamo, for that very good presentation. We can learn so many things as we continue. The use of antimicrobials in growth promotion is still something that is very controversial, and also use of antibiotics when they should not be used is a concern. And the experts are here, so you've heard. We need to work on that, and we can corroborate. The resistance is also emphasized. And I want to say that even at PHPT, we have a laboratory, molecular lab, which is, has all the facilities to do molecular, and experts like Dr. Aboge, who can corroborate and maybe synergize what we are doing. Thank you very much. And the need of monitoring. At the break time, we were discussing with Professor Ogana the need to keep pharmacovigilance on what we use and the effects. So the other two presenters are virtual. I don't know whether they are set.
Hi, my name is Senjo Gichuya, a PhD veterinary epidemiology and economics student at the University of Nairobi, and a graduate fellow at the International Livestock Research Institute's Animal and Human Health Program, and also attached to the Zoonosis in Livestock in Kenya project that's led by Professor Eric Fevre. Today, I'll be talking about consumer preferences for safe pork products in rural Kenya. About 75% of the world's poorest live in rural areas and are dependent on livestock for income generation, as well as a source of nutrition. Livestock production worldwide is expected to increase and intensify in response to increase in demand for animal source food products. And we particularly see this with the poultry and also the pig sectors because of the relative ease of production. African countries are expected to have reflected a 155% increase in demand for pork between the years 2000 and 2030. And in Kenya alone, we expect to see a 268% increase between the years 2010 and 2050. And this is mostly due to an increase in population and also shifting trends in meat preferences. Pig production systems in Kenya currently range from intensive commercial pig farming, mainly in central Kenya, where about 82% are in the commercial sector, to free-range traditional systems, mainly in Western Kenya, and particularly in Busia, where about 96% of them are in the traditional low-input backyard production system. So with intensification, there is a great opportunity for improved food security and economic livelihoods. But we have concerns as to whether the current rural production and processing systems are able to handle this growth from a food safety perspective. Let's look at Busia, the study site, for example. Busia is located at the border of Kenya and Uganda. The major land use there is for crop production and livestock farming. And people rely on agriculture as a main economic activity. A large proportion of the population owns less than 0.6 hectares, and this is smaller than what is considered economically sustainable. Specifically about pig production, pig farmers are do this at a very small scale, and they sell their pigs mainly to local butchers around Busia, who in turn sell approximately 20 carcasses per month. So we see that overall, this is a very small scale system. Butchers in Busia are quite central to the pork supply chain, and they run everything from purchase of live pigs to the sale of pork. A day in the life of a pork butcher in Busia typically consists of procuring a pig from a farm, and mostly on a motorcycle or bicycle, slaughtering the pig in a slaughter slab that usually lacks facilities to ensure adequate hygiene, and sometimes in the absence of a certified meat inspector, transportation of the carcass in less than ideal conditions to their retail outlets, where they sell pork as raw to household consumers or cooked to hotel consumers. So clearly there are risks here. How do we remedy the situation? Food safety is classified as a basic human right and is therefore controlled and regulated by governments. But due to the resource constraints and also the diverse nature of food systems and aid regulation, some governments are unable to enforce the appropriate legislation. So alternatives that leverage market demand have been suggested as a solution so that the responsibility to ensure food safety does not rest completely with governments, but is somehow shared across various value chain stakeholders. Consumers are the central drivers in any value chain as they determine not only the quantities, but also the quality of what is produced, and can therefore either support or frustrate disease control strategies. We know that wealthy and urban dwelling consumers value food safety and are willing to pay a premium for food safety assurance. But what about low income rural consumers? We therefore sought to address these two objectives: to describe pork consumption patterns in Busia, Western Kenya, and to also assess their preferences and willingness to pay for safe pork. To address these questions, we carried out a discrete choice experiment with 401 consumers. We first began by carrying out focus group discussions that enabled us to identify attributes that were relatable with the consumers. And these were the veterinary stamp of meat inspection, where you can see a picture of a piece of pork that has a stamp and one that doesn't. We have hygiene, where we see a picture of a dirty butchery and a clean butchery. We have fat content, where we have lean pork and pork that has medium fat or high fat content. And then we have price that ranged across 4 different levels between 300 Kenya shillings to 390 Kenya shillings per kg. These attributes and their levels were combined to come up with 8 choice cards that had 4 options, each with a price tag attached to each option. And also we had an opt-out if none of these options appealed to them. Additional data that was collected was on consumption patterns and also socioeconomic characteristics. With regards to the consumption patterns, the mean purchase per individual was about 430 to 440 grams. And then the consumption frequencies for household consumers were about mostly a few times a week, or once a week, or sometimes even daily. And for hotel consumers, again, it was also a few times a week, daily, or once a week, mostly. The choice experiment analysis was done based on 2 theories. The random utility, first of all, we had the random utility maximization theory that states that an individual faced with a set of alternatives is expected to choose an alternative that maximizes their utility. And by random here, we mean that we can only analyze an individual's probability of choosing one alternative over the other. And this is not a deterministic equation. Secondly, we have the Lancaster's theory of consumer demand. And this states that individuals derive utility from the product characteristics rather than from just the product themselves. So based on this, I'll be discussing results from the conditional logic and the random parameter logic model. From these results, we see that consumers have a higher preference for pork that bears a veterinary mark of meat inspection, and also pork that comes from a clean butchery. The next question is, by how much? To answer this, we calculated their willingness to pay for these attributes. A kilogram of pork in Busia currently goes for about between 310 to 320 Kenya shillings. And based on the Lancaster's consumer theory, They're paying for the unique combination of all these attributes and other attributes rather than the entire piece of pork as a whole. Only that we cannot know what fraction of these 320 shillings, for example, goes into these individual attributes. Unlike other studies that use a discrete choice experiment as a market analysis tool to directly assess willingness to pay values for either a new product or a new attribute, say, for example, paying for a food safety label, this study seeks to use a calculated marginal willingness to pay values as a measure of just how much they value these safety attributes rather than finding out if they're willing to pay a premium above the current selling price. From the calculated willingness to pay values using the random parameter logic model, we see that they're willing to pay 301 Kenya shillings for the veterinary inspection stamp, and also about 212 Kenya shillings for meat that comes from a clean butchery. And from looking at the magnitudes of these willingness to pay values, we see that the veterinary inspection stamp and then hygiene are the most important attributes they consider while making a pork purchase decision. So what does this mean? We see that consumers in Busia significantly value food safety, and therefore there's a potential opportunity to exploit market-based incentives to encourage a certain degree of self-regulation in this value chain. However, we need more studies to get the exact premium above the current price so that it's easier to engage key value chain players who are business oriented. And in instances where willingness to pay doesn't necessarily match their ability to pay, we could look at exploring options that exploit their desire for safer products. Kenya, for example, as of 2013, has a devolved system of governance where the citizen's voice is now more powerful than with the previous system. So efforts in such a situation could therefore leverage their political capital, and I'm using this term loosely, to push for assurance of food safety. And so this brings out the need to invest in increasing consumer awareness about food safety issues in order to generate an effective market demand. Thank you very much for listening, and I'd like to acknowledge the funders of the project, as well as everyone I've worked with, including my supervisors and my colleagues. Thank you.
Thank you, Mase Siajoka. I'm familiar with that work because it's collaboration between PHPT and IRRI, and it was for PhD work. So the next presenter, Lawrence Ikiamba, is also online. Oh, he's here. Thank you. Welcome. You have 15 minutes.
Good afternoon, colleagues. My name is Dr. Lawrence Mongela, and I'm with PVM, CC, Agriculture, Livestock and Fisheries, County Government of Isiolo. My topic is on growth performance, umbrellas fed on processed Akicha totally seed meal as a replacement to soybean meal. This is my master's thesis, which I did, then graduated, and the paper has been published. Next. Yeah, this is the outline of the presentation. One, I'll do the introduction, background information of the study, statement of the problem, objective, justification, research methodology, results, conclusion, and recommendation. As you can see, the next slide, yeah, feeding the world's population is a present-day challenge, and livestock have an important role in providing for high-quality proteins to the consumers and regular income to the producers. And the chicken, they also provide an opportunity in feeding humans as they require little space. Also feed the efficient converters of feed into meat
and the eggs. And the survival and the growth of chicken are rampant by competition for feed with humans and other livestock species. And the situation is aggravated by drought, especially in northern Kenya, where I'm coming from. That's in the Assaus. This leads to low production and the productivity. The background of the study was that demand for chicken protein is growing rapidly, and globally, protein accounts for around 28% of the meat consumed. As I have already said, the adding of chicken requires little space and also feed. Like, for example, 2.3 kilograms of grain and 305 liters of water, you can produce 1 kilogram of chicken meat. And then there's this tree called Acacia totalis, which is quite prevalent in the Sahel, and it produces quite a lot of ponds during the dry season. And there's a lot of seeds which are inside there, and they are of no value because they are not even digested by the livestock. So this is the tree called Acacia totalis, which actually produces a lot of ponds, especially in September when it is very dry in northern Kenya. These are now the pods. You can see the pods and the seeds which I released after you thrash these pods. The pods are really eaten by animals and they are palatable. Statement of the problem. Soybean and fish, they contribute about 70% of the broiler feed cost. And the soybean meal is costly and facing competition. For example, you were told yesterday, 1 kilogram is costing more than 100 shillings. And then the alternative local feed ingredient could be cheaper. And then my hypothesis was that Acacia totalis feed meal could be used in feed formulation. So that's the objective of the study, is to determine growth performance of broilers fed on processed Acacia totalis feed meal as a substitute of soybean meal. The three parameters that determine the growth performance, one is weight gain, the other one is voluntary feed intake, and the last is the feed conversion efficiency or ratio. Justification, of course, the opportunities for change in type and the quantity of chicken feed ingredient is always being sought. And the Acacia totalis seed meal has now been used as an alternative feed ingredient feed in Kenya. And the research output could also contribute to academic knowledge and the alternative feed ingredient for food, for feed processing industries. Okay, next, they go to methodology. The experiment was conducted at the Mangasa Estate, Wabera in Isiolo County, and I employed a complete randomized design using 90 broiler chicks. And there were 60 treatments, and each with 3 replicates or 5 bands per replicate were fed different substitution levels of experimental diet. And the Acacia totalis ponds were thrashed to release the seeds, winnowed, boiled for 1 hour, that's the treatment, dried, ground into flour, and this was used in the feed formulation. Startup commercial diet was fed for the first 7 days for the chicken to acclimatize. And then the experiment diet was fed and will be done from day 8 up to day 35. Clean water was also provided and debilitum. The bands and leftover feed were weighed on a weekly basis, and data was collected. That was the mean body initial body weight, mean body and the body weight change, mean weight, final weight gain, voluntary feed intake, and the feed conversion ratio. And then data was summarized, was organized in Excel. ANOVA was done using SPSS software version 20, and the statistically significant results were subjected to Duncan multiple age test at 0.05 significant level to show where the differences were. So these are now the substitution level. You can see the first food, there was no Acacia totalis, then I increased to 20%, as the other one was reducing universally. So in the treatment 5, there was no soybean meal. So you can see how I arranged it. And these are now the experimental design. Those who are conversant with the experiments, that's how I designed the three triplicates. The bands were just being placed randomly because when they were in one area where they were growing, where they were brooding, they were homogeneous. So I could pick one and place it in the experimental units, which you can see them. And then this is the approximate analysis for the feed which was used. So the feed, we did approximate analysis to know what it contains so that we could be able to balance the diet. And even if you can look at that, that's how now the diet looked like in kilograms. So if you look at Acacia totalis feed meal, it was increasing as the soybean decreasing. Otherwise, all the other ingredients, they remained the same. There were total, about 16 number of feed, which were in the standard diet from broiler, starter broiler. You can see that is the Brunda, when the chicks I started with. You can see that those are now the experimental units, the cubicles. You look, that's myself when I was weighing the feed to put in the feeders every morning. Those are now weighing of the bands when they are also grown. And then you can see the ANOVA results. ANOVA results now you can see what is significant and what's not significant. So the initial body weight was not significant. And then the voluntary feed intake was not significant. But the others, all of them were significant. You can see the value is 0.00, going like that. Those who know how to analyze the ANOVA, they understand very easily that one. Now, I didn't done a multiple range test to show where the differences were. So in mean daily weight gain, you can see which one was number one. Treatment 1 was the heaviest, followed by treatment 2, treatment 0, and in that order. What we are saying is that the mean having the same letter are statistically not significant. So if you can see those one having A, it means they are not significant. That's what it shows. So you can see column 1, the mean daily weight gain, then the mean weight change, and the final weight gain. And then the feed conversion ratio. You can also see it was significant. Then let's look at the graphs. These bar graphs can show you very clearly which was the best. Then we follow my conclusion. Variation in growth efficiency was shown at different feeding levels, and there was no significant reference on voluntary feed intake. The p-value was greater than 0.05, and this shows the diet was good and it was actually palatable. And then on growth performance, there was significant difference in terms of weight change and also in feed conversion ratio. And of course, the lower the feed conversion ratio, the better was the feed. So, but if it is very high, then you are using a lot of food to get a kilo of that particular. To get that kilo of weight. And then Acacia totalis has accrued protein of that 1.74, which is comparable to that of soybean meal, which was that 6.37. So although some people say that soybean has got very high protein content, up to even 40 or 48, but when you go to the market and you buy the soy and you go and test, some of the results can be quite worrying, can be even very low. But Acacia totalis meal is a potentially invaluable ingredient in a poultry feed formulation. And then what is my recommendation? One, I want to recommend that Acacia totalis meal of up to 40% can be included in the chicken diet as a substitute of soybean meal, but it is optimal at 20%. So you can increase, you can put up to 40%. Which means this feed is available to us in northern Kenya, and it is readily available and is of no use. For cost effectiveness, Acacia totalis seeds should be collected and processed in large quantities. I'm also saying that farmers and industry players should be sensitized on the importance of Acacia totalis seed meal. And then Acacia totalis seed meal should be promoted. Acacia totalis 3 should be promoted for production of commercial poultry feed and environmental conservation. Further research is recommended to investigate the poor performance of 100% Acacia totalis seed meal as on growth performance of chicken. I want to say thank you very much. These are some of the references that I looked at, although there were quite many of them. That's myself looking at the experimental unit. I want also to say thank you to Kemu University. Also my two supervisors, Dr. William Chene and Dr. David Moria Mugambi from the same university. Thank you very much.
Thank you very much, Lawrence. That was indeed a very good presentation. Yeah, maybe for those who graduated earlier, we didn't find the faculty doing a lot of natural things. utilizing indigenous knowledge. And we now have Master of Science in Natural Products and Bioprospecting, where we try to find out what can we utilize, how can we utilize the natural resources. Like now, acacia tortoise, which is a natural resource. It's used by indigenous people to make porridge. And the people also eat the pods to gain some nutrition. Also, plants like Moringa oleifera can be used for that. And also Propolis duriflora. So there is a lot in the nature. Even my colleague here, Dr. Uchwangi, he isolated a compound, an extract from a plant, which is doing better than anti-cancer drug, doing better than vincristine. So let's not ignore our natural resources. They are there, and we want to advance them. So the next presentation, second last presentation this morning, is by Kevin Momanyi. Welcome, Dr. Momanyi. Let's give him a clap as he prepares to present.
Good afternoon. So welcome to the presentation. My name is Dr. Kelvin Momanyi. I work for the World Animal Protection as a campaign officer. So let's go next. I'm going to pass a few slides because they have already been covered by most of my colleagues, which they have made my work very easy. So let's go next. Essentially, this presentation is going to show us the consumer perspective towards aspects to do with antimicrobial resistance and animal welfare. This slide has already been covered, simply tells us that as an organization, we've moved from working on 4 programs, which were animals in communities, animals in disasters, and also in farming, but now we have more focus on food systems and wildlife. Next. Next one. So this study was done by a research agency called FLOOD from the UK. And the aims of the specific research objectives were basically to showcase the knowledge and attitudes of people towards antimicrobial resistance, and specifically their concerns towards human health impacts. Next. And this poll covered 15,700 people globally, with the poll from Kenya specifically targeting responses were received from 1,045 people. Next. And then we go next. So that's where we are. So feedback from the respondents shows that actually 82% of people think actually under 75% of the global use of antibiotics used. So we are looking at the total volumes of antibiotics used in the world. People think actually less than 75% of them are used in farming. Whereas we know from research that has already been published is actually around 75% is used in farming. So it is underestimated among the population. So we go next. These are some of the comments that came up. And what the comments are showing us, actually there is low awareness among the people who are responding. And remember, this is a global community across all the continents that we are looking at. For instance, one comment was, I was not aware of the full extent of antibiotics used in livestock. I saw it here in this particular research. We go next. This particular shows that people, majority of them actually feel that overusing of antibiotics is actually wrong. You can see in Kenya, the specific is actually 85%. And actually that cross-cuts across all the countries. They feel the use of antibiotics is wrong, that overuse. We go next. Media has also exemplified or has highlighted this factor, whereby there's this next pandemic, as we've heard from previous presentations. For instance, The Independent, The Guardian, these are major newspapers globally showcasing that. Next. Same in Africa, back at home, major also newspapers, our Daily Nation here, is showing that exactly, stop escalating antibiotic resistance or we perish. All right, we go next. The concern of superbugs in farm animals has also come up. Like 88% are concerned about the possibility of these superbugs coming actually from our farm animals. We go next. And their main concern about superbugs is actually around it's actually personalized. It's something that will affect them as individuals. Like for instance, it will cause adverse effects for themselves or their families, or it will contaminate their meat. We go next. Then these are some of the comments about their superbugs impact around farm animals. For instance, this individual said, I am shocked that actually 75% of the world's antibiotics are actually used for animals. We go next. This was showcased by Dr. Yamo, who is my campaign manager. It shows a specific study we did in Kenya, shows us actually E. coli was the most isolated bacteria. And we do have almost 38.5% multi-drug resistance from samples that were collected from supermarket chains within our country. If we go next, it shows the list of antibiotics that have shown that particular resistance, tetracycline sulfasalazole, which has also been presented by one of the presenter here. Next. So how about the pandemics? Are they concerned? We go next. Yes, people are also concerned about pandemics, and this has been highlighted already in the newspapers. We go next. Specifically, pandemics from farm animals, you and I, and even people globally have been impacted by coronavirus. And what they are saying, actually 83% of them are concerned about the possibility of a pandemic originating from farm animals, specifically, not any other. You go next. It shows you actually even the population in Kenya, over about 50% of them were concerned about this possibility of a pandemic coming from our own farm animals. You go next. So what should be done in this case? One is that where is this challenge coming from? It has already been shown. The use of growth promoters, okay, treatment of infections, okay, without seeking the right professional advice, and also the use of prophylactic use of antibiotics because you want to do cover up. Next. The others, we held an industry consultative meeting early 2020, and these were industry players cutting from poultry, pigs, and also the other government sectors. What they also highlighted is actually the poor husbandry and animal welfare practices, which result to this problem of antibiotic use within animals. The others is actually around working alone and not sharing information, that consultation. And an interesting one is that actually governments are strict on what we're importing and exporting, but very sluggish or lenient in our local production per se. And also the producers, agrovets, drug dispensers, they are only concerned about the bottom line. Next. Then who should do more? You can view clearly that the farmers, the government, and the retailers, they have a task to do. We go next. The use of antibiotic growth is actually wrong. This is what people are saying. And majority of them across all the countries, you can see over 80% are saying it's wrong. Next. And they are also saying, the respondent, that antibiotics should only be used to treat animals and not to do prophylaxis. We go next. So what should governments do? Government should monitor and report, basically strengthen the surveillance systems. And number two, it is to monitor also pollution of farms. Next, retailers. So what should retailers do? It is to ensure that the meat they sell has those minimum standards within all their policies around animal welfare and microbial resistance implemented, and also be transparent to the consumers, telling them proper labeling of the products. We go next. So influencing change, how can we bring that change about? One is that producing meat from poorly treated animals actually is wrong. That is what our consumers are telling us. Next, what are the benefits? One is better quality meat when we produce better. It's better for the animals themselves, but it's also better for us and our environment. Next, some of the benefits, as you can see, it is actually demarcated. For Kenya, occurs both for quality of meat, but also better for the health. Those were the two concerns. They were more personalized to their lives. Next. What can consumers do? You and I, what they said is actually they want to switch to buying higher welfare meat. Another one is that they will refuse to shop from these retailers and supermarkets that don't ensure that meat comes from animals that have been produced well. Other comments in the next slide, it shows that These consumers, they are saying, I will try to buy my meat more cautiously, looking at those labels, high welfare labels, high stamping. I think it has already been highlighted by the presentation by Dr. Sianjoka, whereby the consumer was ready actually to buy when they have that government stamp in that meat. Next, then how can we also address this? An industry perspective, this consultative meeting we had, they said actually the producer can undertake farm audits, conform to standards. Suppliers can actually put consequences for non-conformity, and retailers should have that to do what we call an even playground. What they meant here is that let's label our products better so that you and I, as a consumer, we can have that ability to choose what we want to pay for, and also implement those traceability systems. Next. Then how can we demonstrate also from the value to consumers? How to do that? To show the consumers that actually we are doing better. One is to link what we are doing to the impacts to human health and the environment and to the SDGs. Two is to create this awareness, exactly what we are doing today about the impact of AMR and superbugs. And lastly is to develop the assurance schemes, which we currently actually don't have in Kenya. I think this is a challenge that we throw back to you as industry players for implementation. Lastly, conclusions. We've noted from these particular research pieces, several of them, and also workshops, is that there's a widespread lack of knowledge across board, okay, about AMR and its impact. Two, some people actually were actually shocked about the facts that actually a lot of antibiotics are used in farm animals, meaning if we inform people better, they'll make better choices. Next, concerns tends to be driven by personal. So personalizing that message, how this can impact their health, will help them make better choices, and even our producers and farmers. Next, generally, people think actually it is the producer and the government who needs to do more, okay? But how about the professionals? What is our role? Is it that people do not know our role? Just a question back to us, okay? And then government roles have already been demarcated for them. If you go the next slide, I think. Okay, yeah, there we are. And then also when prompted, I think people think that retailers should do some other things like putting into place policies and minimum standards to be implemented, and they should only sell products that are from humanely produced animals. These are what people are telling us and recommending to us as either professionals who should take that message back to our producers. And people will take action if they are given the right information. If people are told the impacts of their choices, they'll be able to do the right thing for themselves and also for the world. And lastly, is the industry really ready? The previous slide. Yes, the industry is ready. They're ready to shift from that working in silo thinking, and they're moving towards working collaboratively more. And I think these have been emphasized across this conference. Two, they are ready to invest in food labeling and traceability systems, which I know they are lacking. I hope that they'll be implemented later. And they are ready to also put this level playing ground, whereby they push in the right information to the consumer so that the consumer can be able to make the right decision for themselves. And lastly is to create that public awareness to both the stakeholders, the public, so that we make the right decisions. Thank you so much.
Thank you very much. And for this, the last presentation this morning is from Dr. Josephat Mwema. Welcome.
So my name is Dr. Josephat Mwema, and I'll be taking you through this presentation. But before I take you through the presentation, here is a small short story. So I grew up in one of the hardest and harsh environments in Ukambani, where when I was growing up in that village, we didn't have many tall people, so most of us were short. And I had this question: what could have happened to the people from that village where I come from. So I've heard this question for a long time, and then recently, my friend Tumbi Mwangi called me and told me that, so here is a project which could not only help you in answering your question, but can also earn yourself an excellent PhD. So that's how I found myself in the Livestock for Health project, which I'm going to talk about today. It is a collaborative project funded by USAID through Food and Agriculture Organization, or United Nations, and it is implemented by Washington State University Boji Allen School of Global Health. And it's also part of my PhD work. So next slide, please. So if you look at work which has been done by our friends and colleagues from INRI, you look at that paper which was done by Delia Grace. She did a review of what is the contribution of animal source foods to human nutrition. And there were key issues which were found in that paper. One was that animal source foods are a good source of high density micronutrients, and they are also very highly bioavailable. The other thing was that animal source foods are a better quality protein, and they are very important, especially in the first 1,000 days of a child life. And those 1,000 days starts from conception up to 2 years of age. And that time is when growth and development takes place. So if you are not well nourished at that time, even your adulthood will have challenges. So these animal source foods are very critical, especially for pastoralist communities where I've spent the entire working career of myself. So when this project came, I said, I'm on board. So what is this problem of malnutrition we are talking about? So I have no intention of taking you to a class of human nutrition, but basically malnutrition is defined as either undernutrition or overnutrition. Overnutrition is basically obesity, which is not our problem, but undernutrition is what is the key problem here. And undernutrition basically is represented by three parameters, which is standing, where you are short than actually you are supposed to be. Then we have wasting, and then we have underweight. So those are the key parameters we'll be talking about. And if you look at the research and studies which have been done, it has been shown that undernutrition is highly prevalent in sub-Saharan Africa and also Asian countries. So coming back to Kenya, we find that 26% of our children are stunted, 4% wasted, and 11% are underweight. And if you look at that map, which is on your far right, it shows you the red zones, which are critically undernourished, and most of them are in northern Kenya. And the most characteristic of those areas is that they are all nomadic pastoralist zones. So we asked ourselves, what could be the drivers of this undernutrition in those areas? So if you look at the next slide, there is this fantastic work which was done by Matere and his colleagues from FAO, and they were looking at over the years, how has drought emergencies progressed? And you can see clearly that over the years, drought emergencies have been increasing, both in frequency and also in intensity. And this affects forage availability, and by extension, the availability of livestock feed. So we also did some analysis of the reported cases of malnutrition in Marsabit County, and we plotted that against rainfall. And we found there was a correlation between the availability of forage and reported cases of human malnutrition. So with that, we asked ourselves, how would we intervene as livestock people, as veterinarians? How do we intervene with our livestock interventions so that we improve nutrition in human beings? So there is some work which was done by Leroy and his colleague Fragilo, and they were able to do a review of what is the role of livestock interventions in trying to alleviate undernutrition in humans. And one of the key things they were able to come up was that livestock are a good source of food and also nutrition security for humans. And again, they were identified that there are two main important pathways through which livestock can really improve human nutrition. And that was one, through increased production and consumption of animal source foods, and also through increased household income. So when you have disposable income, you are able to decide what you are going to eat. So you'll be able to buy the best quality protein for your household. So in that review again, there was one main challenge that for livestock interventions, we are not able to really get the impact in terms of what is the net contribution of livestock interventions in human nutrition. And this was because most of the studies which have been done, their design and methodology has always been poor in terms of their design. So this is how Livestock for Health was born. And this is basically a project which is has three objectives, four objectives. One is to look at, we want to provide livestock feeds to farmers in northern Kenya during critical dry period and see whether that is going to increase their milk yield in those households, whether that is going to increase milk consumption, whether that is going to translate into reduced cases of malnutrition. And the last one is to make sure that we look at how these interventions, once we do them, are they a cost-effective way of reducing or preventing malnutrition in those areas? So this is a cluster randomized control trial where we have 3 arms. In arm 1, we have a cohort of 1,800 households divided into 3, 600 per arm. So in arm 1, we provide them with livestock feeds for their milking animals. Arm 2, we provide them the same livestock feeds, but because there's a proverb which says that the way to a child's stomach is through the mother's head, so we also give them nutrition counseling, give the mothers nutrition counseling to make sure that they feed the children well. And then we have the control group, which is, we don't give them anything. They are our reference group. So in terms of data collection, we did a participatory study in the beginning to identify the community perspectives. We did our baseline, and we are doing a follow-up data collection every 6 weeks. So those are pictures showing the data collection we are collecting, both questionnaires and also nutrition data. So what are some of the key learnings we are getting for the community participatory study? That paper is already published. You can find them in that link. But the key messages from that was that in that study area in Marsabit, where we are doing this, the main source of livelihood is livestock, and malnutrition is highly prevalent during dry seasons. But we also found that communities are retaining some animals during the drought, the milking animals, when other animals migrate. And these are the animals we are targeting with our intervention of providing livestock feeds. The next one is in terms of milk yield in the households. We are finding that for the households where we are intervening, they have better milk yield compared to the control group where we are not giving anything. And then the next one is on milk consumption. We are also finding that children in the households where we are intervening, that is intervention 1 and 2, they have better milk consumption compared to the control group. And then in terms of monitoring for nutrition outcomes, so this is the work we are doing. So you can see there are children there who are at risk, there are others who have severe acute malnutrition, there are others who have moderate acute malnutrition. So at the end of the data collection, we are going to compare these across the groups and also compare them with the data we have been collecting there and try to see, to answer our third objective, whether providing livestock feeds and nutrition counseling during dry period is a way of preventing acute malnutrition. So with that slide, the next slide, I want to say that this project is providing some good, promising results on our role as livestock people, our role as veterinarians in trying to prevent malnutrition in children and also pregnant and lactating mothers, and particularly in the livestock dependent households in the pastoral communities. I would like to acknowledge my mentor, Professor Thumbi, my supervisors, Professor Oyugi, and Dr. Nzipora Bukania from Kemri, Dr. Mutono from WSU, we are working together. So when I started, I said this is a multi-agency project. So all those partners listed there, they are highly acknowledged for the support they are providing. And lastly is the field team I work with. So without them, I will not have any data to present. So thank you very much for listening to me.
Thank you very much. I will now call upon the presenters so that we can have question and answer session. Please. So as this one settle, then we can have the questions from online participants. Dr. Kuchwangi.
So our online colleagues have been asking questions this morning and they are saying that we are not answering them. So kindly just allow me to say a few. This is a question from Ezekiel Onyango. The definition by Dr. Serem wasn't very clear. Please give some examples of postbiotics. That's for Dr. Serem. Elizabeth Oko, Dr. Elizabeth Oko, we appreciate you. She's been very active online. Does Diamond V have an agent in Kisumu? And do they have formulations for the local chicken? That's for Dr. Serem. Mary Ann Iga, commendation to the organizing team and presenters. Dr. Guna has been very active online from Department of Public Health. We appreciate you. Dr. Edward Kiema to Dr. Yamo. Were there tests to determine pathogenic and non-pathogenic among the isolates? That is to Dr. Yamo. Can see here. Then Dr. Jonathan Orengo, there is need to find out the source of contamination, i.e. the samples along the value chain starting at slaughter. Question from Dr. Edward Kiema to Rollins. how did you label the broiler chick for each treatment in the experiment? Otherwise, that was an innovative study. And finally, there was a comment from Dr. Abdallah Twahir, who has been active online. Prohibition of antimicrobials as growth promoters needs to go hand in hand with education. In my travels, I was alarmed when I came across reports of the use of ARVs as growth promoters in poultry in Uganda. So education of both producer and consumer could help to counter these kind of practices. Thank you, Prof.
Thank you very much. Because of time, I think let's first appreciate them for a good presentation. We can see that they are all subject matter specialists. And I want to guide this way because we have so many questions from the online. I will first take only one question per presenter from the team here. Then we'll guide after that. So we can start from far end. Questions for Dishon? One question only for now. For Dishon? Yeah, if okay, a question for Dr. Yamo. Yes. Who has the next mic? Oh.
Thank you very much. My name is James Kituka. My question goes to Dr. Lawrence Mongera.
Okay, I wanted the one for, okay, since you have taken the mic, you ask.
Sorry.
But you wanted to go in order.
That was a good study, but one, during your study, was welfare of those bands compromised in any way? And what did you do finally with the bands that were in your study? Did you kill and hit them? And how sure are you that the Acacia totalis is not carcinogenic finally? Thank you.
Okay, a good question. Yes, you ask those who have not been asked for now.
Yes, so the question goes to WAP, but I'll ask it to Dr. Momanyi because it's from the same organization. I see that we have a lot of research going into the risk factors or the predisposing factors for antimicrobial resistance. And we're actually wanting to correlate that to the source, which is livestock keeping. Now that ILRI has identified that it's not really correlated, livestock keeping is not correlated to abuse of antimicrobials, but I would imagine that for WAP, I would then look at the research outputs by ILRI to try and mitigate the antimicrobial abuse, so that if we are now encouraging the vet practitioners, before they write any prescriptions, they have to have that two-way, four-way linkage between the field and the laboratory. Have your clinical diagnosis confirmed at the lab to direct you on the right antimicrobial molecules to use. Thank you.
I hope you are noting the questions so that we can answer together. Another question. Dr. Uchondo? No, Professor. Sorry, Professor. He was my lecturer.
Looks I have taught almost everyone here, including the very senior members. But anyway, my question is to Dr. Yamo, because you left the story unfinished. You said there are two companies that approached you with regard to your findings, but you didn't tell us what steps were taken and what is going to be done to ensure that we don't have such a high level of contamination. But even more important to me is what is the actual risk in terms of food poisoning? Because here you're going to cook that meat. So I'm wondering, other than the sporulating organisms, what is the actual risk to the consumer? Most of us just buy meat from a local butchery and we cook it and we have not been sick. So what is the actual risk?
We can have two more responses. Yes, my dean.
Thank you very much, Professor. I have an observation that is really stimulating, where you have a CC providing leadership using postgraduate qualification and not abandoning his identity as a veterinarian. And I've seen that amongst the others who have done that, and I think I want to appreciate him tremendously. His question is really, in addition to answering the efficacy concerns about the product he's using from that plant, I'm asking, has he linked with Unga Feeds? Or is he himself, as an industrialist, planning to commercialize those findings? So that, you know, because I think soybean meal is in shortage at the moment, as I hear. And so that you get that moving. But I would advise then also that before you do that, and as you commercialize, have you considered taking a PhD in that nutrition line so that you consolidate? Because a master's degree professor is only just an introduction to research. PhD is what really counts. Dr. Nanyingi will tell you that. Now I'm emphasizing it here.
Okay. Let's hear a comment from Dr. Wafusama.
Mine is just a comment with regard to growth promoters. The 5th OIE annual report on antimicrobial use in agents intended for animals from 160 countries that were surveyed shows that 70% don't use growth promoters, but 26% use them and 4% nobody knows what they do. But what is most worrying is that those countries that are using growth promoters, some of them are using tylosin and colistin as growth promoters. And these are actually listed by the WHO in the category of highest critically important antimicrobials. So you can imagine if there's going to be resistance on that, what will happen to the world? Of the 39 African countries that responded to this survey, 8 still use growth promoters. And in Africa, the most common growth promoters is bacitracin in several of these countries. Fortunately, colistin and tylosin were only in 1 or 2 countries. But this is based on what they told us they do. We do not know how really accurate that information is. So growth promotion is something that we should really have a dialogue on wherever you work to try and discourage the use of these agents. Thank you.
Thank you very much. I think now we'll give the presenters a chance to respond. We'll start from Dr. Yamo and then get clockwise, yes.
Yeah, thank you very much. I will want to start by responding to Dr. Kiema, whether the tests were done to determine pathogenic and non-pathogenic strains. That was done by KEMRI. It's only that in this presentation, we concentrated on the results that we've given. The subsequent tests that were done, including phylogenetic and even an organism that is still being looked at to just try and define which organism it is exactly. So we are in discussions with people like ILRI and collaborators from abroad that are also looking at identifying some of those organisms. And that's why we said, although some of them are not critical, the fact that some of the organisms that were identified are actually pathogenic and we need to be critical about it. Dr. Orengo asked about the source of contamination. It's an interesting thing that you're looking at. In fact, what we are trying to do now as an organization is to go back into the value chain and start seeing what the processes are. And for instance, we are just about to start a piece of research study that looks at whether pig farming is contaminating the environment, that we are doing with Calro. So it's a process that we're trying to look at through the whole value chain to ensure that we actually are identifying the critical places within the value chain that are important and critical that we need to be addressing. I agree with Dr. Twahir about educating people about AMR and the use of AMR, especially added to what Wakusama said about growth promotion. And it's a discussion we need to work about. I think, Rina, the other thing which is important, and maybe Momanyi will talk about it, beyond just looking at research, and we don't do this, as I said when I started, we are not a research organization. We work with partners. ILRI is one of the partners we work with, as you might be aware. And I think one of the things that Dr. Dishon talked about is the fact that manure is becoming a critical thing that contaminates the environment and has possibilities of being looked at. So part of that is why we look at, remember that second freedom for animals about a comfortable environment and ensuring that there is no discomfort and contamination in the environment that they are operating from. Dr. Kurani, I agree with you. I didn't want to bring the politics of retailers into this. The two big supermarkets in this country, and I think, let me leave it at there. The two big supermarkets are actually in discussion with that. It's for the vets to determine which are the two big supermarkets in this country. I will give you a hint. One of them is international, the other one is local. But the interesting thing is, and going back to food systems, the local supermarket that came to us is actually being funded by one of the big international banks, IFC, in its expansion processes. And I think the important thing to understand is that people like IFC and some of the funders, and when Momanyi put up that thing about what we are looking at in terms of engaging the retailers and looking at the global food system, one of them is looking at who's funding what. And at certain levels, there are certain funds that are coming into this country that are funding things that are not acceptable internationally in terms of welfare. And the question then we need to ask ourselves, is it that there are possibilities that these international brands will lock us out of their markets? And we talk about exports. For me, the biggest export market is actually the big supermarket that is sitting here, and there are certain policies and animal welfare policies that you need to look at and address. And if you can't supply that, then you're actually locking yourself and opening yourself to importation. And that's a big deal that we need to be looking at from the welfare perspective. I agree with you about the risk of cooking, but I also want to remind you that the big supermarkets are also supplying external players. If you look at a big producer like Kenchik, a good proportion of their products are going into the airlines. The airline doesn't have the time to cook. The Muzungu wants it rare. So if you're already having contamination with things like salmonella and shigella and it's not being cooked properly, you end up with situations where you have the airline condemning your local supplier to the airport because there's a contamination that came in. And that's an experience I had even when I worked for Kenchik, that you're blamed for somebody getting sick on a flight because the chicken came from a local supplier. That's one of the reasons why you then need to look at what you're doing in some of these things. Then the same organizations are beginning to have very vigorous standards in terms of what they do. You talk to people in Farmers Choice and Kenchik, they're being audited by KFC, they're being audited by supermarkets, they're being audited by literally everybody around animal welfare standards and food safety standards. And I think that's an important reason why we need to then take the lead and ensure that those standards are being met and being adhered to. I think Wakusama has just confirmed what I said, that 70% of the people have stopped using growth promotion. The rest of us are still, and we need to look at what responses we're getting from Africa. Thank you very much.
Thank you very much. We are now on this side. Let's start from, you have questions? Yes.
So thank you very much. I got very interesting questions. And the first one was from Dr. Onyango on the definition of postbiotic. I'm sorry, the time was quite short and limited, so I could not answer fully. or I could not explain fully. So what I would like to say about the postbiotics in simple terms, these are just metabolites that are produced by microorganisms as they carry out their normal growth or activities in the body, or biological activities. So that is basically what we mean by a postbiotic. So whenever we are feeding the prebiotics, for instance, the organic acids, whenever we are feeding the fat, the long chain carbohydrates. So what we are doing or aiming at is providing nutrients for the beneficial bacteria in the gut so that they can be able to feed on them, break them down, and produce some of the metabolites that are usually useful to the body. And one of the key ones of the metabolites are the short chain fatty acids, such as the butyrate. So butyrate plays a major and significant role in the gut. It provides nourishment to the cells. It has got some antibacterial activity, as well as it plays a role in modulating the immune system. So if you are able to enhance the production of some of these postbiotics, then it means we are also avoiding also the use of the need for antibiotics. So that is in simple terms. So these postbiotics, what we are saying is how ours is different is this has been produced in the lab. So you don't need to feed the live organisms, because you need to achieve a certain level of live organisms when you feed the probiotics. And the prebiotics also, you need to achieve a certain level, and they need to be in a particular site in the gut so that they can be able to be produced, and the stability issues also arise. So with this, the postbiotics being able to produce them and feed to the animal, they just go and act directly. And then the second question was asked about an agent in Kisumu. Yes, CKL is our distributor, and they have a presence in Kisumu. Our products, Diamond VXPC, they are present in the shelves, even in the agrovets. So the product can be used across all the species, including the kienyeji chicken. And then a quick comment on Dr. Wakusama's comment on the antibiotics. Yes, a number of countries have banned the use of AGPs, but the biggest debate has been, what are the alternatives? And this is what we are trying to give in and say that there are alternatives, the natural, and the ones that are not harmful. So thank you.
Thank you very much. For those who have asked me questions, they want to start with Dr. Kema. He has asked me whether there was any labeling of the chicks. For sure, there was no labeling of the chicks. What was labeled randomly was the treatments per replicate. Those were random. But the bands, the units were normally, they were 18 in number, because there was 6 treatments, and each was having 5 replicates. So the total number of chicken was 90. So they were just distributed randomly, being picked from where they were brooding, because they were homogeneous. So you are not specifically, you just pick, go around until all the chicks were distributed within the experimental units. So, and then those who know how ANOVA works, it works on means. So like the mean, there is what you call those which were found on the same food. If there was any difference, that's called an error. But when you find differences between this treatment and that treatment, it's because of the treatments. So that's how ANOVA normally works. And when you run, it can, especially like when I run that kind of multiple age test, it can show you where the differences are. So that's how that system works. Then Dr. Kiduka asked me about ethical clearance. Yes, I did ethical clearance. Of course, they cannot do any experiment without getting consent from the university, and also even from NACOSTE. The other issue is on whether this food is carcinogenic. One, there's no food which is good. All foods are not right. That's why you can see a rat does not eat beans, because it has got institutional memory. The hard disk, it knows once it eats, it will be eaten by it will have stomachache because of antitrypsin. So these factors are there. What you do is you do a little bit of processing. Like myself, I did the processing of this Acacia totally seeds by heating them for 1 hour, and they became quite palatable. If you could give to the goat, you could see it, they grew eat them so much. Then the other issue, what I wanted to tell you is that I saw that these Acacia totalis have been being fed to other animals, like the pigs, and also even the sheep and goats. So it's something that was being eaten by other animals. The other issue I wanted to comment is on this experiment. You can see I've shown you one attribute of the experiment. It is supposed to have 3 specific objectives. 1 was growth performance, 2 was to check on the carcass characteristic, and 3 was to check the economic benefit. When I looked at the carcass characteristic, there was no significant difference. I looked at the intestine, I looked at the liver, I looked also at the pancreas. Pancreas is very critical. Because if you feed the chicken on food which is having problem, or someone, if the microorganisms, the toxins are very high, the pancreas will be enlarged. So that is what you look. And even the intestine themselves, they will be, maybe you will find some statistically significant difference with the organs. So actually the organs are quite okay, which I looked at. Of course, the critical ones. And the other issue that I wanted to tell him is that this chicken, after that, I did also organoleptic test. I even myself tested, and they were very sweet, and I didn't have any problem. And then from there, I just started feeding them the normal food ration, but then the growth was becoming retarded. When you reduce the commercial feed, because of the poor, the poor nutrition in it, actually they were now not growing as fast as they were growing when I had put them in the experimental diet, because this was standard. The protein content, you can see it was very high. It's around 22%. You can see the energy was about 3,200 kilocalories. So it was a good diet. But now this became a little bit retarded. I fed them for about 2-3 weeks. Then the ones which I was not able to clear by myself, I sold them and got some money. That's it. Then let's go to that last question, Dr. Professor Mande. Thank you very much. Yeah, let me summarize. I was doing sensitization to the professionals here to know about that seed, because actually other animals don't even digest it. So I will look for possibility of doing masters with it. Number 2, we are doing something with the action end, SAMPAC project. We can see whether we can be able to process it, because after you remove the other bait, you just give it to the ruminants, and then you are left with the seed. Thank you very much, Professor. Those are my answers. Thank you.
In short of time, so a minute each.
Yeah,
Just
I think,
summarize.
yeah, I had only one question from Dr. Rina about, I think I'll interpret it as how does water protection collaborate with existing mechanisms like ILRI, who already done some research work. I think our response to that.
There are over 3.4 million working donkeys in East Africa, working endlessly in some of the harshest of conditions. At times, these animals are overworked or suffer with years of medical neglect and end up dead. However, their labor plays an important role in the lives of the most vulnerable communities, depending almost entirely on them for livelihoods. In most instances, the income from a single equine can support a whole family. Youth in urban centers depend on donkeys to earn their daily income, where donkeys are a means to an end. In the arid and semi-arid areas, women use donkeys to support their households with domestic chores like fetching water and firewood. In high productivity areas, men and women use donkeys to ferry their farm produce to their homes and to markets. Since 2012, Brook East Africa has been supporting donkey welfare improvement programs in Kenya, Tanzania, Somaliland, and South Sudan. Brook East Africa, through its partners, provides treatment for the working equines and works with local communities, women, and youth groups. We also offer help to working equines in need through our partners, vets who are always on the move, hopping from county to county, sometimes attending to animals in far-flung areas of East Africa. We are also involved in advocacy activities, lobbying government and security agencies to put in place policies that lead to improved animal welfare in the region. Brook East Africa continues to seek partners to strengthen its resource base and reach more people in East Africa. With your support and partnership, we will be able to continue our donkey welfare improvement programs, reaching more vulnerable working equines in more areas throughout East Africa. Beyond that, we endeavor to keep up the critical role of collecting information and data, working towards our target of directly reaching over 400,000 working equines in East Africa by 2021, thereby positively impacting more than 2.4 million people. To support Brook East Africa, visit our website, send us an email, or give us a call.
Karibu kwa kipindi cha Mifugo ni Mali, kipindi kinachowafunza wafugaji mbinu bora za ufugaji na kuwakinga mfugo wako kutokana na magonjwa mbalimbali. Ugonjwa wa miguu na midomo ni mojawapo ya magonjwa ya mifugo ambayo ni rahisi sana kuambukizana.
Huu ugonjwa wa miguu na mdomo usambazwa kupitia kwa wale ng'ombe ambao wameshikwa wakitangamana na wale ambao hawajashikwa, na pia na zingine vifaa ambazo madaktari wanatumianga.
Ugonjwa wa miguu na midomo husababishwa na virusi ambavyo huathiri ng'ombe, kondoo, mbuzi na nguruwe.
Dalili ambazo zinaonekana kwa ng'ombe ambao amekocheka ni joto mwilini, kudondoka kwa mate, na pia kulegalega kwa miguu, na pia kusaka meno, na pia unaweza kuona matiti na midomo kuwa na vidonda nyingi. Jambo la kwanza ya kwamba ugonjwa haina tiba, na jambo la kufanya kuzuia ni ya kwamba tunatumia chanjo kila miezi 6, na pia kutenganisha wale wameshikwa na ugonjwa na wale bado, alafu pia kuripoti mlipuko wa ugonjwa huo wakati wote ukitokea kwa ofisi ya veterinary ile iko karibu, ili tuzuie kusambaza ugonjwa.
Kwa maelezo zaidi, wasiliana na daktari wa mifugo aliye karibu nawe.
Karibu kwa kipindi cha Mifugo ni Mali, kipindi kinachowafunza wafugaji mbinu bora za kulisha na kutunza mifugo.
Umuhimu wa lishe bora katika ng'ombe wa maziwa ni kwamba utaweza kupata maziwa mengi ambayo utaweza kuuza na upate faida ama fedha ya kujimudu nyumbani. Pia utaweza kuuza wale ng'ombe wenye watakuwa wakizaliwa kila mwaka, utauza upate fedha pia nyumbani. Dalili ambayo inaonyesha ng'ombe wana afya mzuri ni kwamba kukua kwao itakuwa ni haraka, ngozi yao ni laini na nyororo, maziwa ambayo yanakamuliwa ni mengi, na pia ng'ombe ambayo anafutia macho.
Ili kuhakikisha afya bora ya mifugo, hakikisha kuwa mifugo wana majani ya kutosha na pia wanapewa madini kulingana na uzito na umri wao. Hakikisha mifugo wanapewa maji safi na ya kutosha. Wapatie dawa za minyoo mara kwa mara. Kwa maelezo zaidi, wasiliana na daktari wa mifugo aliye karibu nawe.
Is that we make a difference. Our desire is that the livestock farmer will reap benefits that they have not reaped before in applying better feeding methods for their cows, better marketing for their products, and that way we are all winners. The bank wins for their investors, the county government wins in a community that has been empowered.
Sisi serikali na wafadhili wengi wangependa sana kufanya kazi na wakulima, lakini kwa sababu kila mtu anafanya kazi kivyake inakuwa vigumu. Kwa hivyo tunawaomba jiunge kwenye cooperative. Kwa kwenye hizi cooperative tunawaomba sana sana mtu angalie kushoto kulia nani yuko kwenye cooperative.
The KCB Foundation now has a great opportunity to collaborate for a good cause which will benefit the economy of the communities in Narok. From Narok, we can feed Nairobi, Nakuru, and Naivasha. KCB Foundation is going to make an initial investment of 30 million shillings, which will create for farmers and break the circle of dependency and poverty among the people of Narok County.
Katika hii partnership between the county government na KCB Foundation, I believe we are going to the next level kama farmers wa Narok County.
Tunafurahi sana kupata development partners kama Kenya Commercial Bank ambaye siku ya leo tutasign MOU ya kuendeleza hiyo agenda ambaye iko kabisa katika County Integrated Development Plan, kuona ya kwamba tunaenda kudeliver kwa hiyo agenda ambayo iko katika CIDP yetu. We are partners, we are friends, na wakati mumekuja kwa agenda kama siku ya leo kuendeleza hiyo partnership, On behalf of our county yetu ya Narok na partners, we want to say we are very happy, we are very excited.
And we try to make sure the vaccine is a live vaccine, it can cause the disease. So we treat with long-acting antibiotic, that is 30%, it can stay for a whole week. Good, so it's done. Okay. So this is now showing the vaccine is there. And this thing that the ear tag does not come. First one. Okay. This one.
This one?
So go ahead and press. Yeah.
We are the heartbeat of technology, with our finger on the pulse of healthcare that has significantly impacted our region.
Cosmos was started by my father, Prakash Patel, who is also a pharmacist. And then he decided early in the 70s and 80s that he had a desire to make Kenya self-sufficient in medicines. At that time, Kenya was importing a lot of medicines, yeah. So in 84, we started manufacturing at the present premises, yeah. That's when I came back from England. My background is also a pharmacist. My father decided that we needed to attack 3 pandemic diseases of Kenya that was faced. Yeah? So first and foremost was malaria, second was TB, and later on came HIV. And at the same time, look at essential medicines, because he said this is what Africa is going to need, this is what Kenya is going to need, and we need to do something for the people.
Cosmos has always been a company focused on quality. It's the foundation stone of this company. And I think, 30 years, 40 years on from when the company started, we've achieved that.
Cosmos operates a literal world-class facility with a total built-up area above 300,000 square feet, 5 manufacturing blocks, warehouse with over 180 API and 6,000 SKUs, on-site finished goods marketing and administration offices, staff canteen, and 24-hour operation. Our production capacity is quite wide, with over 1 billion tablets manufactured annually and 20 million packs of medicine sold annually. In addition to being recognized by the Pharmaceutical Society of Kenya and the Pharmacy and Poisons Board, Cosmos also has USAID, WHO, GMP, and European Pharmaceutical Inspection Corporation Scheme (PICS). Our current therapeutic areas of manufacturing specialization include diabetes, hypertension, antibiotics, anti-inflammatory, HIV, TB, cough and cold, anti-diarrhea, and others, as well as veterinary products. These medications have impacted the lives of millions. As a snapshot of that impact, more than 300,000 patients are currently on Cosmos diabetes and cardiovascular medicines countrywide.
Hello, participants of the 55th Annual Kenya Veterinary Association Scientific Conference and 15th World Rabies Day celebration, I would like to say welcome from Action for the Protection of Animals Africa to this event. APA is an animal welfare organization whose vision is an Africa where animal welfare is core to society. And the main mission of this organization is to ensure that animal welfare is integral in livestock, companion animal, and wildlife, so as to improve the lives of our animals and the interactions with our humans and environment.
And we at Action for Protection of Animals Africa want to see animal welfare becoming the core in the way we work, the way we grow our animals, the way we interact with them. And it's because of this we will be working in 3 project areas. The first is in disaster management, where we will want to see animals protected during disasters and having their resilience build after the disasters so they can be part of who we are, our core.
When disasters happen, it's not only the humans who get displaced, but also the animals, whether livestock, companion, or wildlife. It is a known fact that when disasters happen, that the livestock that people run away is their initial source of food and their initial source of income while they are trying to stabilize themselves and disaster aid comes in. Therefore, it is very important to maintain rescue of animals in disaster and in wildlife areas, as this is a source of income for a country.
Rabies, Rift Valley fever, malignant catarrhal fever. What do all these have in common? These are diseases that affect our wildlife, livestock, and even us. We at Action for Protection of Animals Africa are working with national and county governments to develop plans that will see all our animals better protected, carrying out vaccination programs, and even teaching farmers and livestock owners how to better protect their own livestock.
The second area we'll be working with is animals in communities, and this area will be mostly centralizing in the area of dog population management and rabies elimination. As you know, globally there's a goal to eliminate transition of rabies to humans from dogs by 2030, and after that eliminating it in dogs in the rest of Africa and Asia. This is very important because dog population management and rabies affect various areas in our society. Depending on the number of dogs, you can either have a sustainable, healthy city, or you can have a city full of strays. In farm areas, dogs can also spread rabies to livestock, causing losses at the household level, and especially if they bite and the owner of the household dies and he's an income earner. Dogs also, unfortunately, in wildlife area carry diseases like rabies and distemper, which when they enter wildlife zones can kill and have wiped out whole packs of large cats and wild dogs. Therefore, it is very important to maintain dog population management and rabies elimination. As in disasters in management, we shall also be working in the areas in community, academia, technical persons, and at government level.
And redefining how we also live with wildlife, redefining how we manage our environment so that it is optimal for our livestock and our wildlife, and ultimately for ourselves. We are also going to work in the area of companion animals, wanting to see dog population management, rabies management, and other diseases controlled within companion animals, and the companion animals are treated well and become part and parcel of our families and our livelihoods.
In regards to wildlife, which is our third category, we'll be working in a specialized area or areas. The first one being disaster risk mitigation and management. The other one will be working where there is a confluence of human, animal, and livestock. And this is intervention in areas of human-wildlife conflict and zoonotic disease mitigation across these borders so that we can have sustainability in areas where humans and wildlife live together to ensure productivity and livelihoods in the livestock sector and in the wildlife area.
We in APA come with a combined experience of 25 years working in Africa, Asia, and even in Latin America, where we have the experience and the expertise to help communities, farmers, animal owners, institutions, governments to put in place policies, programs, trainings to see these things come to fusion. So join us as we protect animals in Africa.
Yeah, good afternoon once again, and welcome to this last session of the day, and also the last session of the conference. That is one of two last sessions. So this session is on epidemiology and public health, and we were expecting, or we had 7 presentations. Unfortunately, some of the presenters are not in. I've been looking for Esau Serem. I don't know if he's in the hall. Yeah, so we only have 4 of the presentations. And to start us off will be a presentation from Mark Nanyingi on One Health, multi-sectoral national strategy for brucellosis prevention and control in Kenya. So he's going to start us off. Let's welcome him as he prepares.
My name is Mark Nanyingi, and I welcome you all to this very last session. For a number of years, myself and my colleagues from the Zoonotic Disease Unit, we've been working on a number of documents that will outline Kenya's efforts to control priority zoonotic diseases, and among them has been brucellosis. We have done one for anthrax, and we have, can you go back to the last slide? This is the challenge with this kind of, you can't control your own slides. The first slide. Yeah. So it's very important to get the genesis of this. So the government of Kenya, under the Department of Veterinary Services, has the primary role of controlling zoonotic diseases. And it gets support from various organizations, and among them is the Food and Agricultural Organization, which I work for as a One Health consultant, and the Zoonotic Disease Unit, which we collaborate with the University of Nairobi and also other institutions as outlined. So I'll give you just a snapshot of a 3-year effort that we've been working on. Next slide. In 2017, the country underwent what we call the joint external evaluation, which is done by the WHO. And the JEE looks at the preparedness of a country to respond, or the preparedness and response ability of a country. Kenya, among other countries, has been doing much efforts, and I think we were on the 3rd stage where we are almost just moving to be more sustainable, which becomes the 5th step. So based on those gaps that were identified back in 2017, with support from the USAID, FAO had a program to address zoonotic diseases in animal in Africa under GHSA. And given on those gaps, brucellosis was identified as one of the 2 priority zoonotic diseases. And then we moved forward to look at the revised One Health strategic plan so that we address on how well a country can be prepared to respond better to brucellosis. Next slide, please. Yeah, and what is a PZD? So a PZD is a priority zoonotic disease. So I think in 2015, Dumbi, myself, and many other people, we worked on we used a CDC tool, which qualitatively has some parameters to measure on how important a disease can be given priority. And given this, about 5 diseases have been prioritized. Among them is trypanosomiasis, brucellosis, anthrax, Rift Valley fever, and rabies. For specific purposes, you want to look at what will the cost implications of this disease if it happened in a country. And the socioeconomic impacts go beyond just the loss, but it also touches on terms of the cost of intervention, on how much money will you want to put in vaccines and things like that. And the implications are ramified just beyond the animal aspect, and they touch on public health. And this is aspects of AMR and other issues which come up. But we've been having challenges in terms of having standardized diagnostics, in terms of what algorithms are we going to use, both in human and animals, to give standard ways of diagnosing and making a choice for treatment, both at the animal and the human level. So this propels us actually to look into treatment guidelines for humans that more so will be based on combination therapies. But an important part of it is that if you want to distribute a vaccine, if you want to understand how many doses do you want to do, you have to have a targeted way of monitoring this distribution. And that's why you talk about risk mapping and other aspects. So next slide. So I think, as I talked about, this has been a long process that has culminated into the final phase, that we had a big team of epidemiologists supported by many people from sociology up to communication that worked hand in hand with the government and with the leadership of ZDU working closely with the FAO. We went through an entire process of a stakeholder process, quite consultative. And this was both for the Minister of Health and the Minister of Livestock. And we have a document now, proudly, that we will be launching very soon as part of our efforts actually to bolster the country's preparedness and response mechanisms to brucellosis. Next slide. So quickly, when we did this process, there are many other issues, but I'll not really belabor on this slide. I think the most important thing is we are very keen to understand what will be the areas to focus on in terms of the gaps that you identify. And this moves all the way from, do we have the capacity, the institutional capacity, or do we have mechanisms that are put into place in terms of research or legislations and policy? In terms of capacity, you're looking at things like what Rina was talking about in the morning. Do we have a workforce that can enable us actually to undertake rapid analysis of data or research to come up with evidence that will streamline all this evidence and knowledge into feeding into people who do policy and things like that? So this forms the backbone of all our One Health frameworks that we do, that we want to understand what happens. So next slide. I think the ambition here, which might be of ambitious, is that we want to see a country free of this disease and many other diseases. But the main thing is, if you safeguard the animal health, I think there was a good project here, Livestock for Health, then you'll have better outcomes on the human aspect. And you can only do this with a collaborative interface. So if you have the human, the livestock, the environmental guys working together, then they have a better way of actually responding to many of these diseases. At the end of it, the main thing is to reduce this disease substantially to about 95% or somewhere there, but it's a long-term ambition that this reduction has to be felt both in the humans and animal aspect. Next slide. And for you to be able to do this, you need to have some documents that will actually guide you. And that's why we need a legal framework. We have the animal health policies, the veterinary policies, and many other legislations. So the ability to harmonize these different legislations, that they have a kind of a multiplier effect where you will be able to move on to institutionalize most of these things. When you're talking about differential diagnosis of acute febrile illnesses in the human aspect, or probably you're looking at diseases that you could not easily differentiate due to very close clinical presentations. And then you need a kind of a template or a guideline that the country is able actually to follow this. But if we are able to strengthen our capacity in both diagnosis of human and animal cases of brucellosis, then we can respond with better precision. And this is at all levels, whether the national level or at the lower level. And the difficulty we have is how to communicate this. So you can have social mobilization, but at the same time, you need to package this message as well and deliver these messages in a more professional way that is more acceptable to the communities. And you need money to do this, and that's the part of people putting in a lot of effort to get money to do implementation and applied research. Next slide. And this is just a snapshot of what happens in the surveillance of most of our zoonotic diseases. So most of the people who work with the DVS at the VS, they know about the CAB surveillance system that has been supported very much by Washington State University and many other surveillance systems that run in the wildlife. And the Central Veterinary Lab, which works with the satellite of other regional veterinary labs, is very key in terms of gathering this data from the lower level and cascading this data to a higher level. But it works in very close collaboration with the mirroring this on the human on the human side. So the zoonotic disease platform forms an anchor point where we have all these collaborations that seamlessly run between the human, the animal, and now the environmental side that is going to come in actually to look at how well can we do surveillance in terms of if just syndromic surveillance, or probably we are looking at ways on how to improve this. And a key output of this, which is going to be a milestone, is to enable the counties to have the county One Health units. So where you're going to have the mirror image of what happens at the top to work and function very well at the lower levels, where the county One Health units will run away with their own agenda, but also in line with what is happening at the national level. So all these things fall into the regional bodies, the tripartite, whether you're talking about the OI, the WHO, and FAO, and the communities are the core of this because they form a source of all this information. Next slide. One of the gaps that we saw, or one of the gaps that we identified, is that most of the disease control strategies do not pay attention to costing of disease. And if you can cost disease, you can either cost disease in terms of, what people are talking about, willingness to pay, or you're looking at the burden of the disease at two aspects. So you're talking about the socioeconomic impacts where there's a loss of revenue, where people lose money because they cannot sell their products at the farm gate, or probably you're looking at the cost of intervention. So how much money will you need actually to tackle an animal disease that has potential to spill over to the human aspect? And this can be tied at two levels. So you can have this as a monetary loss, or also you can have this as just estimating the burden of disease, the quality of life, DALYs, and all those estimates that we talk about. So these very sophisticated kind of things, what they want to do is just to inform us that you are not going to just approach a disease and go in and probably you don't really know how much it's costing for you to do this. So an emphasis that we put, and one of the outputs in the strategy, is that we have tried to outline the issues of the socioeconomic impacts and public health burdens, both in humans and animals for this disease. Next slide. Working with the many other organizations, you want to standardize in terms of having diagnostical algorithms. So we have seen very poor performance of very many tests, but then our recommendation is that at the point of care, the gold standard for this will be a Ross Bengal test. And this also will be used both on human and animal platforms. Next slide. This is very key. So following to the WHO recommendations of treatment guidelines, so we recommend for the country to adopt this. And this is tackling issues of AMR. When you're having multi-drug resistant AMR arising due to many of these issues. So this is just an accept from the WHO. Next slide. In terms of implementing this, I think I talked about these structures at the sub-national level and the national level, and we are guided by very many implementation strategies, all the way from diagnostics up to communication. And all these just follow that continuum of epidemiology and outbreak investigations and things like that, and even sample collection. Next slide. And this is the crux of all these things. So we want to move in a stepwise fashion from 2021 when you launch these, and it's going to be a concerted effort to move up to 2040, whereby you're having these phases and you really want to see that at the end of it, there's going to be a reduction, a substantial reduction in brucellosis, all the way from where you started by gathering data and doing applied research to the end. Next slide. And We need to harmonize the policies, strengthen lab, and then promote and coordinate operational research in terms of for us to go ahead and even have maps and risk maps and bioanalysis for most of these diseases. Next slide. And this is how we're going to do it. So we are going to look at areas that the disease has the highest prevalences, and that's where we're going to focus, and in that fashion, have a zonal kind of way of looking at from the high prevalence disease areas to the low prevalence disease areas. So it's a systematic way of doing it, but over a long time. Next slide. So far, I think, as I said, we are confident that despite the pandemic, we are going to do this launch. And the launch of this is going to come in a trio of the One Health strategy itself, the brucellosis strategy, and the anthrax strategy, where all stakeholders will be invited. But the next step will be now to go into the guidelines development and then go into research, which has been presented here by very many people. And so finally, I think our dream is to have a One Health policy in this country. I think that will really put everything in order. Next slide. Yeah, so I think this work was funded by USAID through more of FAO programs. It was supported by very many people, some of them in that picture, and from our various collaborating institutions. Thank you very much.
That's what is being looked at. So I'll invite the next presenter, who is Joash Ogutu. He's going to present on cystic hydatidosis in the abattoirs. Maybe as we welcome him, let's appreciate Dr. Nanyingi. And yeah, let's appreciate Dr. Nanyingi first. So as Dr. Joash prepares, let's kindly note that Dr. Joash has a hearing problem. So if there's any question that you have for him as he is presenting, just note it down and then you'll hand it to me. Then I'll give it to him when the question and answer time comes. And also the questions for Dr. Nanyingi, let's also note them down so that we'll ask them at question and answer time. So welcome.
Good afternoon, everyone. I take this opportunity to welcome you to this presentation with the title of Assessment of Prevalence of Cystic Hydatidosis in Cattle Slaughtered at Busia Town Abattoirs and the Knowledge, Attitude, and Practice of Cattle Owners and Abattoir Workers. I'm Joash Ogutu. Hydatidosis is a neglected parasitic zoonosis of warm-blooded animals caused by the larval stage of the Echinococcus species. There are 4 species of Echinococcus, but only 2 are of public health importance. Next. But only 2 are of public health importance. The first one is Echinococcus granulosus, which causes cystic hydatidosis and majorly found in the tropical regions, and infests ungulates as its prime intermediate hosts, hence the importance in livestock. The second one is Echinococcus mantellocularis, which causes alveolar hydatidosis and majorly found in the temperate regions. The other ones are Echinococcus vogeli and Echinococcus oligathrus. Cystic hydatidosis is endemic in Mediterranean areas, Eastern Europe, Asia, Indian subcontinent, Middle East, and emerging in Soviet republics. In Africa, the parasite is endemic in North and Eastern African countries, including Kenya and Turkana. Next. The problem statement of this study was, this disease affects 2 to 3 million people worldwide in extensive livestock farming areas like in Tibet, where there is close contact between humans and domestic dogs. Human infestation ranges from less than 1 person to more than 200 persons per 100,000 people in rural populations. Globally, there may be excess of 3,000 human and animal deaths every year, which translates to economic losses estimated to be more than $3 billion yearly in cost of management and treatments. The prevalence of the parasite in Kenya is at 25.8% in Turkana. And this translates livestock-related losses in Kenya that's estimated to be more than $240,000 annually. The parasite may be spread into non-endemic areas like Busia through improper disposal of infested organs from slaughtered carcasses. And therefore, the Kenyan public health players need to intervene to prevent and reduce the economic losses from the condemned organs. Next. Justification. Busia is a town in Western Kenya that offers livestock market for Kenya and Uganda. And it is feared that the parasite is being disseminated along livestock marketing chains. The porous border and controlled movement of livestock from perceived endemic areas and poor meat hygiene, especially in the rural areas, may increase the risk of spreading the parasite. And this puts the human and livestock population in Busia at risk because livestock from such areas that are endemic end up in Busia for slaughtering. Previous studies have done little on knowledge, attitude, and practice on the parasite and on risk of introducing the parasite to such areas via livestock trade or livestock marketing chains. In the objectives, the study sought to estimate the prevalence of the parasite in cattle slaughtered at the Busia abattoirs. It also sought to determine the possible sources of introducing the parasite to Busia community, and also assessed the knowledge, attitude, and practice of cattle value chain actors on the parasite. Next. This is the Busia, the study site where the study was done. The study was done in 2 abattoirs, that is Busia Municipal Abattoir and the Ameriquai Abattoir. The town sits exactly at the border of Kenya and Uganda. The study was cross-sectional within the selected abattoirs, and the study was conducted in May and June 2018. Human population in the study area is in excess of 100,000, and livestock population is in excess of 200,000, out of which more than half are cattle. The study targeted all male and female cattle destined for slaughter at the 2 abattoirs. The sample size was the minimum sample size was calculated using this formula of Cochrane with a priori prevalence of 25.8%. Using this formula, we were able to get a minimum sample size of 294, which could have been adjusted depending on the sample degree. The sample size was proportionally divided between the 2 abattoirs based on average monthly slaughter figures. Among the variables that we collected were abattoirs where the animals were being slaughtered. We estimated age based on dentition, breed, sex, body condition score, and origin of each animal. We included all carcasses whose owners consented to participate in the study through signing of the consent form, and adults of 18 years and above were also assessed on knowledge, attitude, and practice. We excluded cattle whose owners could not be traced for CAP assessment and whose owners refused to participate in the study, and organs and carcasses that were condemned for other reasons, like tuberculosis, emphysema, or liver flukes were also exempted. And any other animal that was not cattle was also not included in the study. And people that were not 18 years and above were not considered for CAP assessment. The study began by visiting all the butcheries in Busia town to establish abattoirs where they were slaughtering their cattle. And as these abattoirs were visited to know the origin of cattle that were being slaughtered. The ante-mortem inspection was conducted to record demographic information of each cattle, and post-mortem inspection was done immediately after slaughtering, bleeding, flaying, and evisceration. Standard meat inspection procedures like visual observation, palpation, and incision were used to determine the infestation status of each carcass. Cysts were removed whole, put in zipped polythene bags, and labeled for PCR test after preservation at 20 degrees Celsius. Next. We used a semi-structured questionnaire, which was developed on Microsoft Word, to assess knowledge, attitude, and practice, and interviews were conducted in a private setup within the abattoir to maintain confidentiality. On knowledge, we scored 1 for correct response and 0 for incorrect response or don't know response, whereby adequate knowledge was a response that was half or more than half of the total overall score. Good attitude means a participant found it necessary to deworm dogs and livestock, and good practice was showed that a participant regularly dewormed all his dogs and animals, and practice good meat hygiene and proper disposal of infested organs and dog feces. We entered and cleaned the data using Microsoft Excel, and also and analyzed data using Microsoft Excel and Deep Info. Descriptive and statistics was done to summarize the data, where measures of central tendency and dispersion for continuous variables were calculated, and frequencies and proportions for categorical variables also calculated. The bivariate analysis and logistic regression was used to examine the factors associated with knowledge, where p-values of 0.1 or less in bivariate analysis were entered into multivariate regression model, so that any p-value that was 0.05 or less was considered to have association with knowledge. For the laboratory data, the DNA was extracted and PCR was conducted to confirm the cysts. In the results, next, a total of 310 participants were assessed on knowledge, attitude, and practice, where male were more than half, that's at 83%. The median age was 21. Participants with adequate knowledge on the parasite were around 13%, and those with good attitude were around 35%. 196 participants admitted that they normally practice backyard slaughtering, out of which more than half of such backyard slaughterings are not being inspected by qualified meat inspectors. 302 cow carcasses were inspected, out of which positive cases were 9, and female were 8 out of the 9. Cystic organs included 7 livers, 4 lungs, 2 kidneys, and 1 masseter muscle, which gave a total of 14 samples. Using the standard meat inspection procedure, it's possible that we could have missed some cysts, especially the small ones that could not be picked by palpation. Out of the 14 samples collected, 13 were positive on PCR in the lab, and one sample calcified during processing. Next. That is the graph showing the origin of animals, with Busia leading in the number of animals that came from within the county, followed by West Pokot. And if you can check well, all the positive cases, I think that thing is not left. Yeah, you can see that all the positive cases came from West Pokot, which borders Busia to the north. Next. This is the disposal of infested, the next slide. The disposal of infested organs after backyard slaughtering, where out of the number of the 160 that admitted that they normally slaughter at the backyard, 85 of them admitted that they normally feed their dogs on infested or infected organs, either raw or in a cooked state. And the disposal of dog feces, those who buried their dog feces were the majority. And this is the next. This is the table showing association with knowledge as a coefficient with some other variables, where age above 35 years, above 35 years, literacy level and occupation were showing some significance to knowledge. Next. In our limitations, the estimated prevalence might be lower or higher than expected, or the real situation on the ground, because we were not able to sample animals whose owners refused to participate in the study, and also animals whose owners could not be traced. So the situation may not be exactly what we've calculated of 2.98%. And again, the molecular test did not go up to the sequencing level, so that we were able to tell which genotype of the parasite was circulating in the animals. And then in our conclusion, the reported prevalence shows that Busia is at non-negligible risk of infestation with the parasite. And the situation may worsen with time if proper or if intervention is not conducted. And furthermore, Busia communities are unfamiliar with the parasite, but they engage in activities and practices that may increase the risk of infestation with the parasite due to poor knowledge, attitude, and practice. In the recommendations of the study, there should be improvement in veterinary public health, especially in the rural areas where such services are very minimal, but people practice things that may expose them to dangers of infestation. And then the poor knowledge on the parasite also calls for the implementation of public health education. We should create awareness on the dangers of feeding dogs on raw infested organs and improve knowledge, attitude, and practice on the parasite in Busia communities. And future studies are suggested to be done on human prevalence so that the true situation of the parasite in the community can be established. We acknowledge the following for their support and contribution to the study. And I say thank you for listening to the party.
Yes, thank you, Josh, for that presentation on cystic hydatidosis. And there's some quite informative information from your presentation. And maybe some that I noted was when we look at a good attitude versus good practice, I think we need to think on how we can move just apart from just the good attitude, but good practice, because many of the communities or the public have the attitude or have the knowledge, but then they don't practice, and that's where we fail a lot. And then the fact that a lot of backyard slaughter and no inspection was being carried out. And then it was interesting to note that most of those that were positive were from West Pokot, and we were in Busia, and maybe Dr. Kahariri and the issue of leads would really be important and critical at that point. So next presenter will be Dr. Vivian Chemweno from Kenya Red Cross, and she'll be presenting on epidemic and pandemic preparedness through community-based surveillance in Bomet, West Pokot, Narok, and Tharaka Nithi counties. So Dr. Chemweno, karibu.
Good afternoon. I'm Dr. Vivian Chemweno from Kenya Red Cross. I know most of you have heard of Kenya Red Cross as a responder to disasters and emergencies, but also it supports preparedness programs as well as building resilience within the community. So under preparedness programs, we have a program called Community Epidemic and Pandemic Preparedness Program that runs in 4 counties in Kenya. That is West Pokot County, Narok County, Bomet County, and Tharaka Nithi counties. So the program, we know of, with the recent pandemics and epidemics that have been experienced across the globe, we know that they have devastating impacts, and that calls for preparedness initiatives that will lead to early detection as well as early response to minimize the impacts of epidemics. So today I'm going to take you through, probably you can go back to the previous slide. I'm going to take you through epidemic and pandemic preparedness through community-based surveillance. So next slide. So I mentioned of the community epidemic and pandemic preparedness program. So the community-based surveillance is a preparedness model within the program, and it calls for early detection and prevention and early detection of diseases at the community level to minimize or to stop pandemics from happening. So the project aims at increasing the capacity of populations at risk or the communities at risk to be able to prevent, detect, and respond to epidemics and pandemics. So the program also leverages on the One Health approach and community health strategy. So under the One Health approach, the program is implemented in the 4 counties in partnership with the Ministry of Health and veterinary departments within the counties. So that is where we use the One Health approach and the community health strategy. That is it's a structured strategy within the Ministry of Health where we have community health units. So that's why we're talking of community preparedness. So as mentioned, the project is implemented in the 4 counties. You can see in West Pokot, we are implementing specifically in Pokot North Sub-County, which borders Uganda to the west. And then in Bomet County, it's implemented in Sotik and Chepalungu sub-counties. In Narok County, it's implemented in Narok West and in Narok West and Narok South sub-counties. So those are the implementation sites. In Tharaka Nithi County, we have Tharaka North and Gamba Ngombe sub-counties. So what is community-based surveillance? So we know of the surveillance structures that exist within our government structures. They are basically event-based and indicator-based surveillance, but we are missing out on participation, community participation in surveillance. So community-based surveillance is basically actively involving the community to participate in disease surveillance and in disease detection, reporting, and also monitoring disease events at the community level. So we know basically epidemics and pandemics start and will end at the community. So there is need to put the community at the center of preparedness and surveillance, especially for zoonotic diseases, because if we put the community to understand, to be able to detect the zoonotic diseases as they occur at from the animals before they spill over, we are able to prevent epidemics and pandemics from happening or reducing the impact. So basically, it's to raise the voice of the community in participating in disease surveillance. So what is the aim of CBS? As I've said, the main aim is to raise the voice of the community. So if the community are capacity built to be able to know how they can detect diseases, so they are able to raise early alert, they are able to notice that there is a sign that we are having a case, and they are able to raise early alert. And when they raise early alerts, the responsible authorities are able to do rapid case identification or follow up on the alert, and therefore initiating prompt actions or control measures, and therefore we are able to avert, or we are able to minimize or prevent impact of epidemics and pandemics. So basically, we know when an outbreak occurs, normally in case of outbreaks, we will initiate responses when we are already almost peaking in the epidemic curve, because it takes time to identify and follow up. But in a situation where now we are utilizing the knowledge at the community level and the resources at the community level, so that diseases are able to be picked within the first few cases. So we are able to initiate action at a very early stage of the outbreak. And therefore we are completely going to change the curve of the epidemic curve. And we are able to save lives as well as minimize impacts of disease outbreaks. So let's look at CBS principle. So community-based surveillance is just a simple, adaptable, and low-cost public health initiative, because we can say it's a low cost because we are utilizing the resources and the knowledge within the community. The community are not paid for reporting. So we have volunteers within the community who are able to report. So it's also adaptable. Community volunteers and community members are able to raise alert. So they are trained on how they can easily identify diseases at the community level and raise alert. Also, it complements the health system and early warning system. So it's early warning, it provides early warning for potentially epidemic or pandemic diseases. So in this case, CBS or community-based surveillance does not, it's not a parallel surveillance system with the existing surveillance systems that we have. It just complements. That means it works from the community level, and then the alerts that are picked from the community level feed to the surveillance systems that are there. So it also contributes, to the epidemic management circle, which is prevention, detection, and mobilization for response. So I mentioned that the community-based surveillance is a preparedness model that we are carrying out in the 4 counties that I mentioned. So within the community-based surveillance, we are actively working through the community health strategy that is there. So we are working with the community health volunteers at the community level. So we know there are a set of priority diseases in IDSR, as well as a number of priority diseases. But the diseases that we were able to select to be put under community-based surveillance were just a number of them. So we had a criteria for selecting these priority diseases. So we looked at those that are of major public health concern. That means when they occur, they have high impact with high case fatality rate, also high prevalence of cases, and they have reported past epidemics or pandemics. Also, we were selecting those. For example, for this case, we were looking at cases like Rift Valley fever. When it occurs, it is of high impact as well as can cause high fatality. And also, we are looking at those that it's easy to have effective interventions within the community. So it's possible to, when they are detected early, it's possible to introduce a control measure to interrupt the spread of the disease. Also, we are looking at those diseases that are feasible for the community volunteers. So for this case, for community-based surveillance, we are actively involving the community and the volunteers at the community level, and they are not necessarily trained on medical, or they are not professionals. So we had to look at those diseases that when we develop a community case definition, it's easy for them to understand. Next slide. So those are the list of the priority diseases that are under community-based surveillance. So through the One Health approach, we were looking at both those diseases that are purely affect human beings, as well as those ones that cause zoonotic or that cause zoonoses. So you can look at the list. For the zoonoses, we have anthrax, rabies, and Rift Valley fever. And then we have the event-based cluster of unusual animal illness or deaths. So this one helps us be able to easily pick up emerging and re-emerging diseases. On the human alerts, we have cholera, measles, polio, and viral hemorrhagic fevers like Ebola and Marburg. Cough and difficulty in breathing, that is COVID-19, which is the pandemic that is with us currently. And the last one is the events-based. surveillance so that we are able to pick emerging diseases. So how does community-based surveillance work? So I mentioned that we are working with the volunteers at the community level. So the volunteers are trained on how to identify potential alerts and how to report them to the next level. So they were trained on how to use community case definitions. So in this case, community case definitions are simple basic way of identifying disease. These are not professionals. So they were taught on how to look at those basic signs for a disease and be able to report it as an alert. So the volunteers at the community level are able to utilize mobile app. There is a code there you can see. So we are working with we're able to subscribe for a USSD code to be able to provide service for easy reporting from the community level. So the volunteers are supposed to dial that USSD code, and then we have some leading questions. So for each volunteer, through the community health strategy, we have community health volunteers at the community level, and each of them are attached to specific villages where they are. So the villages where they live are given identity codes. So if a volunteer is in probably village number 1, they'll dial that number. If they experience a case they probably need to raise as an alert, they'll dial that. It will ask them the village, what is their village ID, and they'll input the village ID, and then it will ask, what are you reporting for? Again, in the list of the priority diseases that we've seen, each priority diseases is allocated a unique code. So if, for example, they are reporting for rabies, there is the code for rabies, so they'll enter the code for rabies. And when they do that, a message goes as an alert to the next supervisor. For this case, through the One Health approach, we are working with the community health strategy and the vets. So at each community unit, we have the community health assistant, and they are working together with animal health assistant. So when they send such an alert, the animal health assistant and the community health assistant will receive a message as an alert. For example, you can see there, alert aggressive animal rabies sign has been filed from that specific village. So when the supervisor, next slide. So you can see there, that is at the, down there, it's at the community level where we have community health volunteers who also work to report cases from the animal side, because they are trained through the One Health approach to be able to identify zoonotic diseases as well as human diseases. So they raise the potential alert through the mobile app, and then an SMS goes to the supervisor, who is in this case is the community health assistant or the animal health assistant, who now verifies the alert. So now that from the community they have raised an alert probably of rabies, so the supervisor has to have to verify if it fits whatever the community volunteer has raised, if it fits the community case definitions that are set. So if it fits the community case definition, it's going to be classified as a true alert. And if it doesn't fit the community case definition, it's classified as a false alert. For in this case, a true alert doesn't mean it's a confirmed case or it is a confirmed outbreak, but it triggers further investigation to confirm the case. So if it's a true alert now, it is escalated further to the surveillance team, who now carry out investigation to confirm the case. And if it's confirmed, if it's confirmed as an outbreak, now it goes further to the ministries who declare and mobilize for response. Next slide. So I'll just talk of so this program I've been running since 2019, and it's still ongoing in the 4 counties. And within the period that we've implemented the program, we have made a number of achievements. So across the 4 counties, we have trained 890 community health volunteers who act as community health champions, who also sensitize or raise awareness within the community, who also work together to be able to identify or detect cases at the community level. Also, there's increased community awareness on epidemic-prone diseases. Also can see early detection and rapid response to disease outbreaks. There's strengthened community coordination. So in this case, the community work together, including the key stakeholders in detecting as well as responding to diseases, and then coordinated response through One Health, now that we are working together in identifying zoonotic diseases. And you can also see strong community-led interventions as community are actively participating in surveillance. Next slide. Yeah, so that is just a snapshot. Since the program started, the volunteers were trained and they started implementing community-based surveillance. And through the period, those are the number of alerts that they were able to raise that fit the set community case definition. We can see the blue animal alerts or zoonotic cases of zoonosis that were detected at the community level. You can see across Narok 115, Tharaka Nithi 26, West Pokot 80, Bomet 52. And then human alerts, we have Narok 19, 4, 55, and 6. So those are cases that were detected at the community level using the community case definition. Lessons and recommendations. So from the implementation, we've been able to learn that it takes a collaborative effort that builds on the interdependency of each entity, that is, it can be community, the stakeholders, private sector, and even the government for successful public health intervention. That means we have to be all inclusive, put everyone to be part of surveillance and preparedness for epidemics and pandemics. Also, communities are key in preparedness to disease outbreaks. Again, I'll say that epidemics begin and end in the community, so they are the key people that need to play a role in preparedness. Recommendation: recommend to integrate community-based surveillance in the existing surveillance systems. Of innovative technology surveillance, and then advocate for allocation of resources for community-based surveillance and early response. Thank you.
Yeah, thank you, Vivian, for that very interesting presentation. And indeed, the community is very critical and important in disease control and surveillance. And it's important that we engage them from the beginning to the end. Our next presentation is a recorded presentation because the presenter was not able to join us. And the presentation is on occurrence of Ehrlichia species among smallholder dairy farms in Nairobi City County, Kenya, by Shepelo Gertrude. So we'll get to listen to it. And if there are any questions on that particular presentation, we will note, then
I'm Gertrude Shepelo.
The presenter will
the
get
Department
the
of Clinical Studies, Faculty of Veterinary Medicine, University of Nairobi. I'll present on the occurrence of Ehrlichia ruminantium in smallholder dairy farms in peri-urban Nairobi, Kenya. Now, Ehrlichia species are tick-borne pathogens in the family Anaplasmatae And these pathogens are of both public health and veterinary importance, since some species can be infective to human beings. They are obligate intracellular organisms of the white blood cells. They can usually infect multiple animal species, both domestic and even wild. Species in this genera are basically 5: Ehrlichia ruminatium, Canis, Sharpensis, and the Wingu. And of these, only Ehrlichia ruminatium is documented to infect cattle. Now, Ehrlichia ruminatium usually causes typically what we know as heart water, and it is one of the most important tick-borne diseases in sub-Saharan Africa, including Caribbean islands. Now, there has been less emphasis on its epidemiology in Africa, and this has been associated to low reports of its prevalence across Africa. And sometimes the economic losses associated with its occurrence are poorly documented. And some of those reasons are because there has been difficulty in diagnosis, because the clinical signs are not pathognomonic as we typically know the neurological signs, especially in endemic areas. And the infections with heart water most of the time coincides with other tick-borne diseases. Recently, we have had clinicians from the University of Nairobi Veterinary Hospital reporting suspected cases of Ehrlichia. These cases typically have presented with very unclear clinical signs, unthriftiness, inappetence, and some have died. And on screening, on microscopy, there are Ehrlichia-like inclusion bodies that have been observed in the white blood cells of the affected animals. This study therefore aimed at looking at those inclusion bodies and determining whether they were those of Ehrlichia ruminatium or other pathogens that appear the same on microscopy, and determining the potential risk factors that are associated with its occurrence. This study was conducted in peri-urban Nairobi, and for purposes of data collection, the CBD was taken to be the central point, and the county was subdivided into 4 quadrants, A, B, C, and D. And in each of these quadrants, representative counties, sub-counties were selected to be included in this study, depending on the level, or the number of animals that were present, and its frequency of accessing the veterinary services from the university. So this is a cross-sectional study, and as I highlighted earlier, positive sampling was used to identify the sub-counties in each of those 4 quadrants. Therefore, Kasarani, Dagoretti, Langata, and Westland were the sub-counties included in this study. And at the sub-county level, farms included were basically selected purposefully with the aid of the veterinary staff. Pre-tested questionnaires were administered to the principal farmer or the stockman to determine managemental factor and even cow level factors that were thought to be associated with the occurrence of Ehrlichia ruminatium. In the lab, blood smears were prepared, and this was observed on microscopy, and the serum was harvested for serology. An antigen ELISA for Ehrlichia ruminatium was done using a commercial kit, Bios Microwell. And this plate here shows the results, with a deep yellow indicating positive samples and those that were clear being negative. And univariate and multivariate mixed effect logistic regression was used to test for the association between Ehrlichia ruminatium seropositivity and potential risk factors. For the results, out of the 314 animals that were included in this study, 314 samples were collected. These animals were distributed in 107 farms. So on microscopy, 249 of those samples had inclusion bodies, making an occurrence of 79.3%. And out of the 249, 147 of these samples were scrutinized further to identify which white blood cells were the inclusion bodies. This table here shows us the distribution of the different white blood cells that were involved. And particularly, we can see that the monocytic cells, lymphocytes and monocytes, were the ones that had the highest number of the Ehrlichia-like inclusion bodies. And when we talk about the inclusion bodies, this is how they appear on microscopy. Now, the picture A shows the inclusion bodies in the lymphocytes, as indicated by the blue arrows. Picture B on a neutrophil, again the blue arrow. And C and D are the same inclusion bodies on a monocyte. On ELISA, 296 of those samples that were observed on microscopy were later processed through ELISA. And of these, 55 of them were positive, making a prevalence of 18.6%. And these 55 animals were distributed in 38 farms. And a farm was called positive when at least one of the animals was serologically positive. So a farm level prevalence of 35.5%. For the risk factors at the univariate level, 7 factors were identified to be serologically significant. That were significant. These were the subcounty of origin, frequency of cowshed cleaning, presence or absence of the tick, farming system, whether there were only livestock or livestock and crops, presence or absence of the cowshed roof, presence of the cowshed floor, and the breed of the animal. And at multivariate level, 3 factors were significant at p less than 0.05. These were the subcounty of origin, the frequency of cowshed cleaning, and presence of ticks. Farms that were from Langata subcounty were 3.6 times more likely to be infected than those from the Dagoretti subcounty, which was the reference subcounty. And farms which were cleaned fortnightly every 2 weeks were 3.6 times more likely to be infected with Ehrlichia ruminantium compared to those that were cleaned daily. Now, cattle that were infected with ticks were 2.6 times more likely to be infected than those that had no ticks. Now, a bit of discussion. The Ehrlichia inclusion bodies were observed both in neutrophils and other monocytic cells. And despite the brain squash smear being the common method for diagnosis of Ehrlichia ruminantium, especially when the animal is dead, still we can observe the inclusion body when the animal is alive on stained blood smears, as observed in this study. Now, some of those samples that had inclusion bodies on microscopy were negative on ELISA. Now, this may be an indication of possibility of other Ehrlichia pathogens or other anaplasma that may present similarly on microscopy, or another explanation is the low sensitivity usually associated with the microscopy. Now, the cattle that were actually Ehrlichia ruminantium serologically positive were apparently healthy. Now, this may be a suggestion of a non-pathogenic strain in circulation or presence of carrier animals. And frequent cleaning of the cowshed was also identified to increase the odds of infection with Ehrlichia ruminantium. And as we know, accumulation of slurry is an animal welfare issue, since when this happens, animals are forced to lie on the ground on those slurry for long hours. And once we have compromised animal welfare, there's a lot of stress involved with the animals. This greatly compromises the immunity and increases the risk of diseases. Now, the high odds of infection in Langata subcounty may be associated with the close proximity to the national park, since wild animals are known to be reservoirs of ehrlichiosis and other tick-borne diseases. Now, ticks was the main route of transmission, is usually the main route of transmission of Ehrlichia and other tick-borne diseases. Therefore, its presence on the animal, of course, increased the odds of infection. The conclusions of this work is that there was relatively high prevalence of Ehrlichia ruminantium, both at the animal level at 18.6 and at the herd level. In this production system, therefore, there's need to put effective tick-borne control strategies, especially effective ones, and assess the ones that we have, whether they are effective in the control of ticks. And the farm level factor that was identified was the infrequent cowshed cleaning. Therefore, there's need to emphasize on animal welfare as a preventive strategy, both for the tick-borne diseases and other infections. There's need for further studies to understand the other pathogens that were appearing like inclusion bodies on the white blood cells, but then were not Ehrlichia ruminantium. Now, talking of poor animal welfare, what you see in this picture are the very poor animal welfare structures that are dilapidated and floors that have accumulated slurry and fluids. And of course, this you'd expect to be very stressful, of course, would increase their chance. This with this animal where they are comfortable on their structures, including even when you have basic structures like this one, you can still have the animal with very good structures and very good comfortable lying areas. Now, acknowledgements to CATA for funding this research and the Department of Clinical Studies for provision of ELISA kits for this work. This work has been published, and this is a list of references. And thank you very much, and I'll be glad to respond to any questions. Welcome to this.
Yeah, let's appreciate Dr. Shepelo. Even if she's not physically here. And I think, I normally say one of the blessings of the COVID pandemic was the fact that we've been able to embrace the use of virtual platforms in things that we do. Before, we would just miss the presenter, but at least now we can have that online presentation. And we're also able to have those who are with us here in Malindi, and others are able to join us from outside. So maybe before we now go into the question and answer session, I think let's appreciate all the presenters. A hearty applause. Yes, we've been able to save time because we didn't have all presentations. So I think we'll be able to have a more interactive question and answer session. And I would ask the presenters to kindly come forward. And we had noted our questions, then we'll take the questions. Those questions that were for Dr. Joash, kindly hand them to me or to him. Dr. Nanyingi, Joash, and Chemweno. Any other question for Joash? Okay. You'll be lonely on that side. Yes, so we can start with at least maybe 2 questions per presenter. Then we can see we'll have another round. So for Dr. Nanyingi, any questions from the floor? Yes.
Okay, mine is very simple because through the time I've sat in this session, there are very good strategies and knowledge in disease management, generally through studies and research which have been done by many of the presenters here. And we still have a scenario where we cannot be able to reduce the impact of diseases within our livestock population in the country, leave alone even enabling access to markets. And yet we have all this. So as veterinarians, I think we'll be providing maybe very little impact to the livestock investors in terms of gaining a shilling from the investment. So we as a veterinary fraternity in the country, what are we thinking? Why is it that this scenario keeps on lingering all over? I think all counties are affected, and we need really to rethink. So from the presenters, especially that this scenario touches on surveillance system, disease control strategies, and probably like our madam there from West Pokot, the community-based surveillance system. I think that as much as is inherent into the existing surveillance strategy that we have, but still it does not really come out clearly why we still have this problem inherent within our livestock population disease control systems.
Thank you, Dr. Awando, for that question. Any other question for either of the presenters? Okay. Right. Maybe Dr. Nanyingi could respond to that. And I think the question also from Dr. Awando might not just be only for Dr. Nanyingi, but for the rest of us also here. We could have a few comments or two on why we think we are not achieving what the strategies hope to achieve.
Yes, so my question is to Dr. Henry Joash. When we were in school, we were told that the hydatidosis, I think you'll write for him, because we were told to write, yeah. So we were told that the hydatidosis prevalence in Busia County was quite high compared to the rest of the country, but your research findings are reporting otherwise. Is it that the control efforts are paying off and that the incidence is now reduced, so we'd have very low disease burden, or it's because of the methods that you use to conduct that research? Thank you.
Rina, could you just kindly note that and then I'll hand over to you. Yes.
Question is to the community-based reporting by Kenya Red Cross. And this tool primarily is administered by the community volunteers. Are there such a threshold that guide the community volunteers to differentiate whether the occurrence is just an event, and if not an event, it has gone to the level of an hazard, and further, the threshold which will say that it's a pandemic or epidemic in that case. Two, at what level of reporting does in this case, the support program, Red Cross, come in? Where are these volunteers going to report to you? And I say this because many of the NGOs, and I don't want to say any, rather do a lot of misreporting contrary to the government. Therefore, where do you exactly come in so that you can either counter-check the reported information? Thank you.
Okay, let the presenters respond to those questions. And Dr. Onchwangi, I don't know, are there any online questions which we will respond to after this round?
I think this is working. So, Dr. Wandos, I don't know if it's a question or is an opinion. I think it's very difficult for us, some of us where we are, to have substantive answers to that, but it's the ambition of every country or every sector to try and control diseases. For example, if the animal diseases or diseases that have potential to spill over to humans. And part of the efforts that we are doing with many other stakeholders, including FAO and others, is we are trying to unpackage research. I think research is very fancy. It gets you promotions, titles, and everything. But then how do we use this research to solve, everyday problems? And what we are trying to do is to legislate things like strategies and policies. We need that evidence from research. And that's why continuously people have to undertake research. But then attempts to come up with national strategies that will become either policies or legislations, I think is a long-term process. But to respond to exactly why we still have these diseases, I think it's because there are many drivers of this disease that keep on evolving with time. And as much as we'll put in efforts to combat them, they still escape, most of our efforts. I'm imagining a scenario whereby we never had any diseases at all. I think most of us will run out of our jobs for a daily basis, including you and me. So I think it's not that diseases give us opportunity, but I think the drivers of disease with urbanization and everyday changes, it's chasing a moving goalpost. That every time we come up with all these guidelines that we put on, it's an open book to imagine that diseases also have their own ways of adapting to different scenarios. So we can't lose the hope of trying to continue developing many of these documents. But I think my response will be, we need research, but also we need to put research into implementation. I think that's the problem probably that we have had for a very long time. Thank you very much. Josh, do you have something else to add?
I'll start with a sarcastic question. It's talking about me having said that the risk of 2.98% is negligible. In my presentation, I clearly stated that the risk cannot be neglected, and it may worsen with the time if an intervention is not instituted in good time, because animals still continue to come to Bosia, and we do not know their status of infestation. And again, we only worked with one species of animals. So we do not know the situation in other species, maybe pigs or even dogs. So I stated that the risk cannot be neglected, not that it's negligible. And it may worsen with time if the proper proper intervention is not instituted. Then the one for Ina, she's asking that in school we were told that hydatidosis cases is comparatively low, but research shows that the situation is becoming worse. In the presentation, you clearly notice that people are continuously becoming careless with the disposal of their infested organs. And we all know that a dog is the definitive host of the parasite. And the moment the infested organs are being fed to dogs in raw state, it's like you are completing the life cycle of the problem. And the eggs that are laid are easily picked by the intermediate host and the incidental host, and the situation is becoming not easy to handle. So the research, what the research is showing is that people are not becoming ideally careful with how they handle their slaughter organs, especially the ones that are being done at home without proper meat inspection and proper disposal.
Chemweno, did you have any question to answer?
Okay, thank you for your questions. I'll start with a question on if there's set number of threshold for the volunteers to identify an outbreak or an epidemic. So for this case, the volunteers are trained to identify the list of the priority diseases that I mentioned based on the community-based community case definitions. So for the priority diseases, any potentially case that fits the community case definition, they are supposed to raise an alert. So they don't have to wait for piling of a number of cases that fit the community case definition for them to report, because the volunteers, their community, they are not able to tell whether this is an outbreak or what. So they just are supposed to raise an alert that there's a there's a disease that can potentially cause an outbreak. The second question on at what level does Red Cross come in the surveillance and reporting? So the program, which is I mentioned, the program is funded by USAID through the International Federation for Red Cross and Red Crescent, and implemented by Kenya Red Cross in partnership with the county governments where the program is implemented. So we are leveraging on the existing government surveillance structures. So it's not a parallel reporting system or a surveillance system. So Red Cross is supporting the community-based surveillance at the community level. So when the volunteers raise the alerts go to the government official in both the Ministry of Health and the Veterinary department, which now feeds into the the government systems. Yeah, thank you.
Okay. Thank you for the answers to that first round of questions. We have online participants and we have some questions from online. So Dr. Edward Kiema has a question for Joash. Joash, interesting CAP study. The animal presented at Busia markets and slaughter facilities come from different counties. Clarify how the CAP can be associated with local residents of Busia County. And secondly, clarify how multiple organ infestation was used to estimate prevalence. And then a comment from Dr. Joshua Onono to Josh. Just check again the p-value for gender. It cannot be greater than 1. And then a comment from Dr. Joash Onono to Dr. Nanyingi. I think effectiveness of this strategy needs some level of participation from livestock keeping communities. It is not clear from the list of activities. Then one last question from Dr. Twahir to Joash. I'm wondering how you got people to bury dog feces as part of the effort of controlling hydatidosis. I expect most people would not bother with the feces. So maybe I will start, maybe Nanyingi can respond to that comment as I give this question to Joash.
Yeah, so the comment from Joshua Nono is, what is the participation of the community in all this? I think part of my presentation emphasized on the need of having a community approach where we have structures that will mirror what is happening at the national level and what we call the community One Health units. So this had been piloted about 5 years ago, and I think currently there are multiple stakeholders, including the CP3 project and many others who have started initiating these efforts to include communities in disease alerts and response. And as FAO, we also have the same opportunity to work with many other One Health stakeholders to strengthen surveillance systems using community-based approaches. And our hope is that the community One Health units ramify all over the 47 counties so that we have a structure that actually coordinates very well from the national level to all the other 47 county One Health units. So that's the role of how the livestock keeping communities will be included in these efforts to control brucellosis. Thank you very much.
I have 3 additional questions. One is talking about clarification on how CAP can be appreciated with local residents of Busia County. The second is asking to clarify how multiple organ infestation was used to estimate prevalence, and then how burial of dog feces is an intervention for the situation. First, I indicated that the people need to know about cystic hydatidosis so that their knowledge and attitude and practice on the parasite can help them find ways of preventing this or stopping this idea of feeding dogs on raw infested organs. And again, they also need to know that when you slaughter an animal at home, you need to call a qualified meat inspector to come inspect the meat so that in case of any infested organ, proper disposal can be done. So the knowledge, attitude, and practice can be appreciated if these people are educated on what to do about the infested organs and how to handle their meat, especially the ones that are being slaughtered at home in ceremonies and cultural activity events. Then secondly, about the prevalence, I indicated that the number of animals that were positive for the parasite were 9 out of the total number, but the number of samples that were picked were 14. From the calculation, if you get 9 out of the total number, will give you 2.98%. So we didn't use a multiple local infestation to estimate the prevalence, but use the total number of animals that were infested, which were 9, divided by the number of animals that were sampled, but not the number of samples that were picked to be used as a measure or an estimate for prevalence. Then about the burial of dog feces, in the questionnaire, this was one of the questions that were being asked to the dog keepers, that after when you get a dog feces on the compound, what do you do with it? Then options were given so that you take the one that the dog keeper would appreciate as his way of disposal of the dog feces. So it was not a way of intervening. So it was not an intervention, but it was part of the practice questions in the questionnaire, so that we would know that how many people do the right thing and how many people do the wrong thing, so that in case of any education or public health education of the people, we know which approach to give to the people.
I have a question from Dr. Awanda. Thank you for your question. The question reads, how do you make sure that the community disease reporters do not pretend to be veterinarians and start treating animals contrary to the GOK policy? Okay, for community-based surveillance, we basically train them on the basic signs that they look out for the priority diseases for reporting. And also we train them to raise awareness on disease prevention for both zoonotic diseases and human diseases and other animal diseases. So we understand this is a problem in our country, and we also try to raise awareness on importance of seeking services from the professionals. And yeah, we hope we have not actually trained them on treatments or offering veterinary services to the farmers. So theirs is basically detection and reporting and linking the community to the veterinary service providers. Thank you.
Yeah, thank you for those answers and the many questions from the participants. There's a link that is going to be shared shortly by Dr. Momanyi for us to participate, get into and participate and answer some few questions. And I think unless there's one more question or a burning one. Yes, you can ask that one.
Thank you. Thank you, Madam Chair of this session. This is more or less a comment. In fact, a mature comment for that matter. I stand up. If I want to say it, then I will stand. Yes, the reason why I think it is a mature comment is because we have had very good research programs going on and coming up with very good information. But you know, by the end of this conference, we have only talked to vets. And how many vets will live here and go back to Busia and tell people about how to solve those problems that we have seen in the presentations? Or how many vets will go back to Makueni and do more sensitization of people on the issues of rabies? So my suggested solution is that when these research activities or programs are being doled out, let us also have a very strong communication component of it so that, the findings can have an attempted solutions within the communities. And I heard my friend from Dr. Kise from Makueni saying that we need a strong communication so that people can vaccinate their dogs. And we are forgetting that we have got very many vernacular radio stations that can do this thing very easily for you. Instead of struggling, with the chiefs and running around with a microphone, like you are campaigning, those ones are good enough. But I'm sure, even from here, if you were to go to Busia, because now Busia seems to be having an incubation site for some diseases. I worked in Busia and I know that, keeping of pigs, extensively without housing them was a big, big issue. And now with the advent of the county government, it becomes very difficult, I know, for the vets that work in Busia actually to institute methods of controlling this. I can tell you this for free because I've worked in those county governments and back to national government and back to county government. So let us use our vernacular radio stations for communication. And we have got very many vets here who can do that. If they go to the studios and talk with the people, they listen to you. Because what is coming out here is that if people know that pork is not inspected in Busia, they may not want to eat it, even if it is cheaper. And this can be done better in that kind of forum. Makofi? Thank you very much.
Yes, I think that mature comment it's true. I think we fail a lot also on the communication part of all this. And so let's do our best to engage the community by communicating all this science. So before our presenters go back to seats, I would like we appreciate them in, I'm not good in those clapping. Dr. Nyamwea, would you be able to do that for us? Yes.
As a veterinary, I also practice other things. So, who can remember the Honorable Elijah Mwangari? How many were in school those days? Minister of Agriculture. Hakuna isipokuwa mimi. Sasa, yeye anawapatia makofi yaka iko inapanda 1, 2, 3. Nikisema 1, inabaki 1. Haya, twende. 1. 1. 1. Hiyo ilikuwa kionjo sasa. Wacha sasa twende. 1. 1. 1. 1. 1.
Yes, thank you. So I see the link has been shared on the screen. Momanyi, would you explain what it's on, or that you click onto the link? It's a survey, I think, about this workshop. So you just quickly fill the form, and I would encourage we all participate because it helps us to improve and have a better workshop, better content. So maybe we could do that for 2-3 minutes. And then the next activity will be a vote of thanks from the KVA leadership, which will be done by Dr. Purity Kiunga.
Good evening. Good evening once again. Kuna msemo wa Kiswahili huo inasema hayawi hayawi, hayawi hayawi, This wheel started more than a year ago of coming to Malindi, and due to unavoidable circumstances, COVID happened, but hayawi, mwishowe huwa. So I would really want to take this warm and cherished moment to say thank you, and sincerely, first and foremost, to the Almighty God. Without him, I'm not sure would be even standing here today. So we thank God for this time. And it is my privilege to propose and acknowledge all of you for actually making this event a success. Without you guys, this event would not have been a success. And this is starting way from the participants, way to the presenters, to the partners, and also to the online crew that has been here. I'm sure for sure this has been interesting in that you're here physically, but you're still attending the meeting virtually in Malindi. So for our partners, KCB Brook, we really want to say thank you for the support you've given us. Not forgetting Boringa, Ingelheim, CKL, Cosmos, OI, FAO, WAP, Animix, Medicel, Unga Farm Care, Bimeda, DVS, Kilifi County, University of Nairobi, VMD, SIVA, KVB, Metrovet, Atlantis Life Science, Kagrik Vet Care, Biodeal, Elgon Kenya, Action for Protection of Animal, Africa, Damon V, the hotel itself, Ultimate Vet Serve, Ultravetis, Ministry of Agriculture, and if I've not mentioned you, it's deep down in my heart saying thank you. The association is happy that you made the event a success. Just before I hand over to the chairman to officially release us, I have two announcements. At 6:30, we'll be having our closing dinner at Ocean Beach Hotel. Please be punctual, 6:30, so that we can be able to have a shaky leggy before 10 o'clock. And all of us, please pass by the KVB desk to make sure that you sign out. And before I walk out, maybe I would want us all to stand. Let's all stand. And I once upon a time did music, so I would want us to clap for ourselves, and I will be the choir master. So I will conduct the music. And when I do like this, what do? You clap. Okay? Thank you so much, and we really appreciate you guys. And on that note, I hand it over to our chair.
Naona watu wameanza kupack na tujasema tumefunga. We can start afresh. Yeah. Finally, we've come to an end. This was a dream. Finally, it has become a reality. And when you go, it will become a history. That's how things are. I'm happy to see all of you still alive and kicking. I've not heard of anyone complaining. Kama kuna mwenye amekuwa na ugonjwa akanyamaza, that's an unreported incident. But there's no incident of sickness, no incident of robbery, mtu ameibiwa. So I can say my members are living this place healthy and safe. Now from here to wherever you go, tunaweka kwa Mungu, si ndio tunaachia Mungu hiyo. Wamesema nifanye closing. I've done some survey on our partners. Some are still giving in their feedback. And what I've noticed that most of them are saying the question they got from their respective stations or booths were beyond their expectations. So maybe the science that was here was taken to them where they were, and the questions were beyond expectations, which means they got value. I want to believe also you who are here, you got value from the knowledge that you've acquired. And there are also some suggestions on how we can improve next year. Next year, hapa karibu to April, when we'll be having elections, at the same time having the science, and we'll put in some other things kidogo. Above all, the turnout was beyond our expectations now as executives, because we expected around 150, but from the data, the turnout together with the partners is 264. Can you clap for ourselves? That is encouraging. I thought Malindi is very fun to discourage people to come, but kumbe ukipeleka watu mbali ndio wanakuja zaidi. And I'm happy. We are happy, and we'll get back to you probably with more information on this. Maybe a report that you can read and what happened and the rest. Others, I want to say thank you for your time, for your resources, and for your presence. Sasa wana declare closed kama hakuna maombi, ama mshaomba? Mimi nda declare imeisha, alafu mtu akuja aombe. Sijui tu is praying. Mimi siombi, mimi nafunga. Tena niombe. Yes. Anaitwa nani? Ngoja kidogo ndakuita. Mimi sijajua watu wengi akiwa wananijua wengi. Okay. Okay. Yes. So, enda kuambia wakati wa kuomba. Najua mmechoka. Now, you know, I have to invite you also, as much as you said, I have to invite you for the gala dinner. Naona tayari nimetoa hata viatu set. Hata naenda kuvaa kinyasa hivi, ndio nipate baridi yote. So I'm welcoming you for the gala dinner. We interact, we talk, we socialize. Wamesema 6:30 to 10. And when you get there, you'll get instructions on how you can enjoy yourself. The place is Ocean Beach Hotel. It is 4 kilometers from here. Come on your way to Kibokoni, where we were having our main station. Utaiona tu. And if you Google, utafika tu hapo. So I'm inviting you officially. Come and dine with us. Come and laugh together. Yeah, tufurahi, sindio? This is maybe Malindi, we might come 10 years from now again. Who knows? I want to invite Mohammed, Daktari, and I want to declare that this conference is officially closed. Thank you.
Now, I was given a big task. When I am a politician. Good. Please, we shall pray in Arabic, and these are prayers of Muslims in Islam, and like this. Bismillahir Rahmanir Rahim. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين. We pray to our Almighty God for making this workshop very successful. We also pray to our Almighty Allah to make sure that all of you return to your home destination safely. Inshallah. Thank you very much.